Yes. Hello. Please.
This local will halt at all stations up to Kalyan onwards. It will halt at Dombivli, Thane, Mulund, Ghatkopar, Kurla, Dadar, Bhaikala stations.
A, boom, 79, 9023.
Hello. Mic check. Hello. Hello. Hello.
हेलो चेक. हेलो माइक टेस्ट चेक. हेलो. टेप ला ना जरा, डबल का अपना टेप देना जरा मेरे को यार. इसको भी नहीं जल्दी करना तो यार, टाइम नहीं है. 2:30 इधर. हेलो. वेट गिव मी. पीछे रखिए. सुनना ये देख.
Hello, check. Hello, mic test. Hello. Hello, check.
Good afternoon, everyone. Welcome to DRS 2025, Amchi, Mumbai. So, we're starting with the first session for the day. I would like to invite Dr. J.K. Sharma from New Delhi and Dr. Rajesh Deshmane from Kolhapur, the chairperson for our very first session. Give a big round of applause for our chairperson for the very first session.
Good afternoon, friends. Thank you, Dr. Manoj, Dr. Purvi, and everybody involved in this important conference. And we all have seen equality over here. And I welcome every one of you. We are going to start this session. And the topics are not the usual suspects. And the first speaker for this, Dr. Simon Heller. Dr. Simon Heller is Professor of Clinical Diabetes at the University of Sheffield, Director of Research and Development and Honorary Consultant Physician at Sheffield Teaching Hospital. If I read his entire CV, it will be a full day talk, so I don't want to come in between you and Professor Simon, and he will talk on the atypical diabetes. Dr. Simon, please start.
Thank you. Good afternoon, everybody. It's a pleasure and honor to be here. I want to thank Dr. Manoj, Dr. Banshi for inviting me to participate in this meeting. It's always a pleasure to come to India, although it is challenging to talk about atypical diabetes in 20 minutes. These are my disclosures, and you can see that I've been asked to speak on 3 areas of diabetes. First 2 are not perhaps as well known as they should be, but the third, type 2 diabetes in youth, I've only got 7 minutes to talk on it, and it's probably the most important condition in the world, but particularly in India. And I hope there'll be an opportunity for this in this meeting to discuss what will be one of the biggest challenges to this country in the coming years. But let's start with cystic fibrosis diabetes. The related diabetes to CF is a very common morbidity. Around the US, 30,000 individuals, 50% who are children, are diagnosed with CF in the US. And there are around 17,000 and 4,600 cases of CFRD in children and adults, respectively. Around a third of women with CF without diabetes develop gestational diabetes, and the risk of diabetes is of course increased by glucocorticoids or other factors associated with their pulmonary disease. And lung transplant recipients, of course, a treatment for some who are using immunosuppressives are also at high risk. And there are differences which I will go over, and it's therefore a unique presentation and an approach to diagnosis and management. You can see that the prevalence of related diabetes in CF goes up in both sexes, a little more prominent in women in their childbearing years, perhaps unsurprisingly, but otherwise the prevalence is the same. And you can see for those who live into their 20s and 30s and 40s, and of course that is the difference, people with cystic fibrosis used to die in adolescence, but over the last 20 years they survive and then they get their diabetes. The characteristics of the three conditions, type 1, type 2, and CF-related diabetes, are shown on this slide. I think the important things are that exocrine deficiency is present in cystic fibrosis disease. It rarely causes ketoacidosis because there's always some insulin around which switches off ketogenesis in the liver. Importantly, just a little bit of insulin will prevent DKA because the ketogenesis pathway is uniquely sensitive to insulin, and the risk of microvascular complications is less, but only because they rarely have severe disease. Insulin is the treatment, and the other difference is that it needs a high-calorie, well-balanced diet. These individuals tend to be underweight. So it's the reduced beta cell mass leading to insulin insufficiency, which is essentially present. The mechanisms may be due to oxidative stress leading to beta cell damage, a dysfunctional CF membrane, conductance regulator, a protein, and importantly, collateral loss of islets as the exocrine pancreas is destroyed. And there is some suggestion, and I'm not an expert, that the CF chloride channel defect itself, responsible for cystic fibrosis, may lead to susceptibility damage in beta cells. And the insulin resistance caused by medications, but also inflammation and chest infection itself, may also be relevant. So the management is summarized as this: screen from age 10, used to be GTT, but I suspect, at least in some countries, continuous glucose monitoring may replace that, certainly HbA1c. Very importantly, it needs a multidisciplinary team, MDT, with expertise, and luckily for us in my hospital, the cystic fibrosis unit is the floor above the diabetes unit, so we run a joint clinic with our respiratory medical colleagues, and the nurses are expert in both, and importantly can focus on self-management education for the people. We run structured education courses for people with type 1, but also cystic fibrosis. And the insulin is good for stabilizing lung function and improving nutritional status. Recommendations are different from those in type 1 and type 2. So the diet needs dietitians with expertise, high calorie, high salt, high fat diet, and we do teach carb counting to all our patients on multiple insulin injections and pumps, and it's important in this condition. So those with diabetes have a worse prognosis than those without. Ketoacidosis is rare, severe hypoglycemia is uncommon, and the risk of micro and indeed macrovascular complications is not high, but these patients rarely live into their 70s, although that's beginning to change, which is why they may not get microvascular disease. But early diagnosis is important for nutrition, lung disease itself, and survival. So let's turn to diabetes due to pancreatitis and pancreatectomy, also known as type 3C. Recent data suggests the prevalence is getting higher, 5 to 10%. It comprises approximately 75% of the non-type 1, type 2, at least in Western countries. I don't know if that's the case here. In established chronic pancreatitis, you can see diabetes prevalence is pretty common, between 25% and 80%, depending on duration and severity. And new advances in beta cell biology had found new etiologies, and I'm going to mention a couple of them. Biology, it's unique, it's different, very different, even from type 1 diabetes. It's insulin deficiency, loss of pancreatic polypeptide, and hepatic insulin resistance. And where the pancreatic head has been lost or damaged due to trauma, complete or surgical removal, or chronic fibrosis, then these individuals are predisposed to PP deficiency and subsequent insulin resistance, which can make it challenging. We're always, importantly for somebody like me who's interested in hypoglycemia, the alpha cells are damaged at the same time, so that makes these patients prone to hypoglycemia, impaired other peptides, important. The body's own GLP-1 has impaired production, and I'm sure that contributes to the phenotype. And so this combination of islet cell destruction, insulin resistance, and co-regulatory hormones produces this very complex endocrine phenotype, and that makes its management very challenging. So you might say, well, what do you do that's different? The importance is to make sure that nutrition is a focus, and so it's important that your nutritionists or your dietitians, as we call them in the UK, are trained to look at that, and importantly, they have to replace the exocrine pancreas with the relevant enzymes. So these patients should be on supplements, and again, a joint multidisciplinary clinic with expertise in those who can treat the malnutrition as well as the diabetes are important. That doesn't happen. Let me tell you about fibrocalculous pancreatic diabetes. It's confined to tropical regions, and southern India, the state of Kerala, has the highest prevalence in the world. I don't know, there's people in this audience who are probably more expert than me. So the typical patient is lean, young adult, malnourished from poor socioeconomic background, recurrent bouts of pain and steatorrhea, and characteristically, X-rays or ultrasonography are diagnostic in demonstrating a large number of discrete pancreatic calculi. It's possibly due to genetic, nutritional, inflammatory factors. The pathogenesis is not well understood. Diabetes is challenging. I've never seen a case. I'd be very interested to know whether anybody in the audience has seen that case. Often difficult to control. DK is rare, but you usually need insulin. And the other thing is they get a lot of pain, and they may need surgical removal of these pancreatic calculi. Microvascular complications common, macrovascular disease rare, and pancreatic malignancy is increased, and as we know, a feared and recognized complication, which is often fatal. And I want to finish off by talking about genetic pancreatitis. So quite a few people with pancreatic diabetes have underlying genetic causes, cause hereditary genetic pancreatitis, and they have characteristics, mutations in what is called the cationic trypsinogen gene. Don't ask me about it because I'm not expert, but you can see that 80% of patients with hereditary pancreatitis have this. And again, these patients are at risk of cancer, and so the treatment is actually pancreatectomy and auto-islet transfusion. And if you look at the success of this treatment, you can see that the majority are either insulin independent in pale blue or have minimal insulin use. So this is a successful treatment, although of course it needs specialist centers who can do it, but it appears to be the treatment of choice in severe pancreatic diabetes. But I want to finish off by talking about this condition. For those of you who don't think this is important, this is going to dominate your management in years to come. I guarantee it. It is very frightening, and I hope the slides that I've got will briefly show you how important it is. It is going to become, in my view, the most important type of diabetes, particularly in this country, in years to come. There's a rising epidemic in the US, and you can see those who are most affected are indigenous population, American Indians, so-called, non-Hispanic blacks and Hispanic. And look at the curve for the non-Hispanic white, right at the bottom in green, barely increasing, but even they have a scary time. Here's the global prevalence of type 2 diabetes, and you can see in Europe, right at the top, it's pretty unusual, or was, with a prevalence of 1 per 100,000 back in 2021, but it's increasing. Let's go down to the bottom. Brazil. India is not in this curve, but I looked up just earlier in the last few days where the epidemiology is in this country, and it's exactly the same as Brazil. That is 1,000 times higher than in Europe. And a recent paper in this country from Bengaluru showed that in adolescent individuals in this country, the prevalence of either pre or early type 2 diabetes is 10%. 10% of your adolescent population have early diabetes, and that is 1,000 times higher. So 10% of the Indian population multiplied is a lot of people. And not only that, the prognosis of these individuals much worse than type 1 diabetes. So Brazil is the maximum, and India is way up there. And it's the same pathophysiology, except probably pubertal insulin resistance, but we don't know why it's suddenly becoming so common. But these are the factors which are causing type 2 diabetes, but at a much earlier age, particularly loss of beta cells already in the teenagers. And as we were actually discussing in another meeting earlier today, they're going to go, they're going to disappear, and already this is causing microvascular disease. So let's look at treatment. This is an old study done in the US, 2004 to 2011, 700 patients. They used metformin and lifestyle, metformin with Rosie, and metformin and lifestyle. And treatment failure was an A1C above 8%. After half those patients on metformin had an A1C which was less on monotherapy. Rosiglitazone and lifestyle made no difference, and a third had egregious by greater than 0.5%, but a fifth had an increase in A1C. Let's fast forward, and what I want you to look at is these curves on the left, and on the right, as they were followed up in observational study as the years, the numbers with an A1C which was high went up, and then was approaching 50%, above 10% at the end of the study. And look at the incidence of hypertension, nearly 75%, kidney disease, 50%. These people will get renal failure and will need dialysis and kidney transplantation, and they will die. Neuropathy was also prominent here, and the chances of avoiding major complications was very low indeed, just 25%. At the age of 25, 80% of these people have complications, and if that isn't scary, I don't know what is. Look at the differences between type 1 diabetes in black and type 2 diabetes in young people in red. And you can see how scary that is. And what are the treatment options? Well, at the moment, the FDA in the US has approved metformin, insulin, and one GLP-1 agonist, but it's not, I think it's dulaglutide. It is not the most effective drugs. And SGLT2 inhibitors are not improved, yet they protect young people from kidney disease. Metabolic bariatric surgery is useful. Medical therapy for both glycemic and non-glycemic outcomes is clearly possible. And there are studies to show that you can have a greater regression and attenuation of kidney disease with medical treatment, aggressive lipid and glucose lowering. So, what's the model? Primary care screening needs to start. I don't know whether it is in this country, but it's essential. These people need referral to a pediatric specialist clinic. They need a multidisciplinary clinic. Lifestyle management, frankly, has shown to be ineffective, but what else do we have? And we urgently need to know what therapies are most effective, because we just don't know, although probably GL1 receptor agonists will be transformational, and I can give you anecdotal reports. So the conclusions are, this condition is a unique challenge to all countries, but particular to South Asia. Comorbidities develop rapidly. While the key intervention is lifestyle change, it's shown to be almost totally ineffective. Aggressive insulin treatment is probably the wrong treatment. It increases weight, it will be resisted by teenagers, and it isn't actually what we need. Clearly, GLP-1 agonists are potential, but the number of studies are very small, and we urgently need studies, and I would suggest humbly that this country is exactly the place where that should be done. But we definitely need much more research, and we need an answer quickly, or these kids will die with horrible complications. And with that, I'd like to thank you for your attention.
Thank you, Professor Heller. So we'll take question and answer at the end of this session. So I will request you to wait here. So for next session, I request Dr. Anuj Maheshwari sir. So I think everyone knows Dr. Maheshwari sir. He is President-elect for RSSDI National, and he's a Professor of Medicine. He's Vice President of Maharashtra and RSSDI, and he's Governor of American College of Physicians India chapter. So over to Dr. Maheshwari sir.
Thank you, Chairperson, for the kind introduction. So after a very enlightening talk of Shimon Heller, I'm going to tell you about the SGLT2 inhibitor therapy and its impact, or especially its expanding horizon in non-diabetic population, or you can say the benefits what we can get with SGLT2 inhibitor patient, those who are not having the diabetes. Not working? Okay. So if we talk about from sugar, when it comes to the system of our body, there has been a lot of things, a lot of milestones where we can say that fluorescein has been tested and discovered in the 19th century to the modern era of dapagliflozin and empagliflozin, where the SGLT2 development is being held finally, and it has reached to the finally 1980 to 1990 was the year when the identification of the SGLT protein for the first time has been done. In 2000, we could know about the selectivity of the SGLT2 inhibitors. 2012 and 2013, for the first time it has been approved for type 2 diabetes. In 2019 onward, it was the landmark heart failure and CKD trials which expanded the scope of this medication. Today, SGLT2 inhibitors are redefined as cardiorenal protectors rather than just glucose-lowering medications. So, what is the mechanism beyond glucose control? SGLT2 inhibitor act primarily at the kidney by inhibiting glucose and sodium reabsorption. The downstream effects are, it enhances the ketone utilization, especially the myocardial muscles, reduces oxidative stress and suppression of the fibrosis in the myocardium. It lowers the intraglomerular pressure, improves the oxygenation and anti-inflammatory and anti-fibrotic action in kidney. In liver, it reduces the gluconeogenesis and fat accumulation in blood vessels. It causes natriuresis, lower blood pressure, and improves the vascular stiffness. So heart failure with reduced ejection fraction in DAPA heart failure trial, dapagliflozin reduced the risk of the worsening of heart failure or cardiovascular death by 26%, regardless of the diabetes status. Similarly, in EMPEROR, reduced confirmed empagliflozin lowered cardiovascular mortality and heart failure hospitalization. Importantly, non-diabetic patients gained equal benefits, cementing the role of SGLT2 inhibitor as cornerstone of heart failure therapy. So breakthrough, the trial EMPEROR, which has been done in the preserved ejection fraction heart failure patient. First therapy to show outcome benefits in the heart failure preserved ejection fraction was SGLT2 inhibitor. Reduced composite CV death with a reduction in the heart failure hospitalization was the impact and effect which has been having the relevance was observed in both diabetic and non-diabetic patients, that heart failure preserved ejection fraction previously considered untreatable now has a proven therapeutic option. The SGLT2 inhibitor offer cardiovascular benefit through various mechanisms. What the mechanism has already been described in various forums as well as in the previous slides also, like reducing inflammation, like reducing the cardiac fibrosis, reducing the oxidative stress. It also helps in improving the sympathetic nervous system by reducing the sympathetic overdrive, and when it acts on the kidney, it not only improves the kidney function but also improves the erythropoietin level, which helps in improving the hemoglobin status of the body, as well as diuresis and natriuresis also helps in reducing the blood pressure. The DAPA CKD trial enrolled CKD patients without diabetes. Dapagliflozin lowered the risk of the kidney failure, cardiovascular death, and heart failure hospitalization. Relative risk reduction was considered in non-diabetics, marking the first trial to confirm the renal protection independent of the glycemia, reducing 39% kidney failure and death. Works in non-diabetics also, and first renal outcome success was beyond diabetes. CKD, in the DAPA CKD trials, in DAPA CKD trial, sorry, already it is done. EMPA's kidney highlights were over 6,000 CKD patients has been included. Empagliflozin reduced the CKD progression and cardiovascular death. Non-diabetic CKD patients benefited equally. Slower, the eGFR declined significantly compared with the placebo. This evidence repositions the SGLT2 inhibitor as renal drugs across the population. The mechanism of renal protection. Renal protection arises through reducing the intraglomerular pressure, restoring the tubuloglomerular feedback in its hemodynamic function. Metabolically, it helps in caloric loss, ketogenesis, improves the oxygen efficiency. Cellularly, it activates the autophagy and AMPK, SIRT1, suppresses the inflammation and fibrosis. Vascularly, it improves the endothelial function and lowers the arterial stiffness. So, mechanistic overview of the SGLT2 inhibitor in reducing the risk of CKD. SGLT2 inhibitors are known to reduce the oxidative stress, known to reduce the glycemic load. It helps in improving the reducing the kidney tissue damage or improving the acute kidney injury. It helps in chronic kidney disease also by supplying the efficient kidney fuel sources through the ATP when the free fatty acid oxidation and ketogenesis works for that. The overall benefits beyond the diabetes is reducing the heart failure hospitalization by 30%, reducing the cardiovascular death by 15 to 20%, reducing all-cause mortality in CKD cohorts. It improved symptoms and quality of life. These outcomes are independent of the blood glucose lowering, highlighting a pleiotropic mechanism of benefit. Hypertension and arrhythmia, when we talk about this, SGLT2 inhibitors lower the systolic and diastolic BP through natriuresis, through which it causes more of the sodium lost through the urine, improves the endothelial function. Arterial stiffness is reduced by this action of SGLT2 inhibitor. So by stabilizing the ion balance and reducing the myocardial stress, dapagliflozin and empagliflozin both decrease the risk of the atrial fibrillation and ventricular arrhythmias, including in patients, those who are not having diabetes. If we talk about the non-alcoholic fatty liver disease, which is also known as the MASLD, the trial demonstrates improvement in liver fat content and fibrosis markers with dapagliflozin, empagliflozin and tofagliflozin. Mechanism include reduced gluconeogenesis, enhanced ketogenesis, improved adiponectin signaling and anti-inflammatory effect. Benefits extend to non-diabetic NAFLD population, suggesting a future hepatology role. So if we talk about the SGLT2 inhibitor in obesity and metabolic syndrome, it provides metabolic modest weight loss in non-diabetic individuals also. Reduction in visceral adiposity. It also improves in blood pressure and arterial stiffness is reduced with the action of the SGLT2 inhibitor. Favorable metabolic shifts from ketone utilization, more of the energy efficiency, even in the absence of the available glucose. Potential role in metabolic syndrome management. Combination with GLP-1 receptor agonists has wonderful additive benefits. Ongoing trials assessing the obesity indication, expanding relevance beyond diabetes to metabolic health, and future therapeutic positioning in obesity care is important to understand. Inflammation and endothelial protections has been improved by the SGLT2 inhibitor. It reduces inflammation, attenuates oxidative stress, improves vascular endothelial function, reduces sympathetic activation. Already it has all been described in the previous slide. But apart from that, evidence of the lower hsCRP, which is a marker of the inflammatory cytokine, role in improving the vascular stiffness and compliance, possible implication in atherosclerosis prevention, and expands use in non-diabetic cardiovascular prevention. So future directions could be, for the cardiovascular protection, this is the preferred drug could be for the hypertension management as well as the prevention of the hypertension, especially in the patient with diabetes. It can also help in reducing dementia, especially the vascular dementia. Helpful in obesity correction and prevention both. CKD combination like RAS blocker when they are combined with the endothelin blockers as well as with the SGLT2 inhibitors is perfect cardiovascular CKD protector. Cancer cachexia, it is being worked up with still in the experimental phase. So there are certain limitations also in the future directions for SGLT2 inhibitor. And what are those limitations? Most large trials focused on the type 2 diabetes, CKD and heart failure. They have got the limited data in broader non-diabetic population. Mechanism behind the pleiotropic benefits are still not fully understood. Some neutral or variable effects reported in arrhythmias and non-diabetic NAFLD. There are certain adverse effects like genitourinary infections, volume depletion, and rare ketoacidosis, which is seen in the elderly or CKD patient. Incomplete responses in high-risk subgroups like advanced CKD and severe heart failure, and long-term safety and durability of the benefit is still under the investigation. With these limitations, the future directions for the SGLT2 inhibitor are still quite encouraging that guidelines shifts to the SGLT2 inhibitor. In 2019, we could see that diabetes was the only indication for the SGLT2 inhibitor. In 2021, we could see that heart failure with or without diabetes was the indication for the SGLT2 inhibitor. And in 2022, we know that CKD with the broader inclusion has been one of the indicators of the use for SGLT2 inhibitor. And in 2023-24, guidelines class 1 recommendations for the heart failure, CKD, irrespective of the diabetes is there or not. So clinical implication, SGLT2 no longer just anti-diabetic drugs. Cardiologists using as first line in heart failure patient, nephrologists prescribing for CKD progression and its prevention. primary care adoption for high-risk patients. It improves the outcomes independent of the glycemia correction. Cost-effective in chronic disease management. Potential reduction in dialysis and transplant burden is one of the most important benefits what we could get out of this. Holistic benefit across multi-organ disease spectrum, and it redefines the chronic care strategy beyond diabetes. So concluding that SGLT2 inhibitor therapy expanded from diabetes to multi-system use. Now it has not been restricted to the patients with diabetes. Now it has been open for those who are not having the diabetes, but may be having compelling indications for the use of this wonderful drug. Strong evidence in the heart failure, may it be reduced ejection fraction or preserved ejection fraction, and CKD, irrespective of diabetes. Cardiovascular and renal benefits in non-diabetes, established, it has been used and established. Mechanistic basis beyond glucose lowering validated. What is the problem? I don't know. Safe and well tolerated in broader population. There are the guidelines and real world data which support the widespread adoption. Emerging role in the obesity, hypertension, metabolic syndrome, representing a paradigm shift in chronic disease management, and of course it serves as a future cornerstone therapy beyond diabetes care. Thank you very much for your kind listening.
Thank you, Professor Anuj Maheshwari. Wonderful talk. Questions will be taken at the end of the entire session. I request to please be here in the hall.
Thank you.
And now in the series, the next very important topic on the heart failure management 2 by SGLT2 and ARNI. And we can, whenever name of Dr. Krishna Seshadri comes, it comes to my mind the research at the cellular level, the pathology, the pathophysiology. And we are going to listen and learn from Dr. Krishna regarding this topic. Dr. Krishna, please start.
Thank you very much, the chairpersons, and thank you, Manoj, and what is his better half's name? So, I'm so happy to see this conference move from a club that we started this whole a few years ago to the biggest daddy of them all, the Geo Center. So that's the happiness I have when I see Manoj and Purvi succeed so much. And I have made a little change because I really think that we have still not understood the concept of heart failure and diabetes very well. So I am dumbing this down for my own understanding. These are my conflicts of interest. So let us take this patient. A 58-year-old woman has type 2 diabetes for 10 years. She has hypertension and dyslipidemia. She's on a sulfonylurea, metformin, a glitazone, gliptin, everything else. Her blood pressure is 145 by 95, A1C is 8.1, EGFR is 60, urine microalbumin is 200, and a FIB4, please calculate it in your patients, is 1.65. I do coronary artery calcium scores very regularly. It's 150 in this patient. She does not have shortness of breath other than in climbing an extra flight of stairs. So how many of you think that this patient has heart failure? One person. So Joy, you don't count. Presidents only have casting votes. Chairpersons don't count. But it's interesting because if I ask this question to anyone, they will say, I don't think she has heart failure, right? That is the truth. So the first question is she at risk for heart failure? So let's look at this very carefully. Over a period of time, what has happened is, you will notice that myocardial infarction has moved down this list of presentation of cardiovascular illness and diabetes. And largely because of people like us, we have been using statins for many, many years that has brought down this risk. So a silent epidemic of heart failure has moved up this chain. So this is one bit. So heart failure is not discovered by the SGLT2 inhibitors. There have been studies much before that. There's an increased risk of heart failure, including the Framingham heart study. I'm not going to show it today for this thing, but this is something important to understand. The second thing is that in India, it is very much a young person disease, just like diabetes. It has a high 1-year mortality, despite having a younger cohort than the West. The fantastic data that comes from the Indian Heart Registry. And this, of course, we've heard over a period of time that this is no diabetes. This is diabetes with HFpEF and the HFpEF hospitalization rate with diabetes is the same as a HFrEF hospitalization in patients without diabetes. So clearly, diabetes and heart failure isn't very interlinked. Or this is almost like the 1999 data that you have, right? So definitely she's at risk for heart failure just by being a diabetic. Now, what are the factors? First is BMI. This is something that is very obvious. You're obese, you're at risk of heart failure. Hypertension, which Anuj spoke about so beautifully today, and I think it's a call for action. It's there. A 12% increase in heart failure, every 10 millimeters increase in systolic blood pressure. Dyslipidemia, and remember, heart failure and DKD go hand to hand. Just like you think of eye disease, whenever you see renal disease, think about heart failure. This is a point that I want to spend half a minute on. Heart and women, they wear their heart on their sleeves, but they also have great problems with heart disease, right? The heart failure risk in women is 5-fold higher than non-diabetics. This is something that you want to remember. And I want to talk to you about the ARNI recommendations in women. Second, there are higher hospitalization rates in women. Third, women are less likely to get cardioprotective drugs. This is something that is very well known from past. So remember this part. And of course, there is a link between A1C and heart failure. So quickly to reconcile, is she at risk? Absolutely. Remember also that there are multiple things that we want to think about when you think about heart failure. One is, remember, it's a clinical syndrome. But now we have stages of heart failure depending on the risk. So any diabetic is automatically at stage A. Are they moving to pre-heart failure, which is stage B, which is stage C is heart failure, or advanced? I won't talk about C and D simply because I'm not qualified to do that. Then there's a classification based on the ejection fraction. HFrEF, HFpEF, now HFmrEF, all the other stuff that we have. But the idea is for me to sensitize you, and I'm not going to get into all the details. So this is how we have. So if you go back to this woman, type 2 diabetes for 10 years, hypertension, dyslipidemia, blood pressure, BMI, A1C, DKD, presence of coexisting atherosclerotic cardiovascular disease, each of those tells you that this person is at risk for heart failure. But the question is, how do you test this person? What should you get? Well, what should you get this person? Next step in this patient. If you agree that she's at risk for heart failure and may have underlying heart failure, what test will you get? How many will get a 2D echo on this patient? Okay. Now, I want somebody to tell me how many people think that the 2D echo that you get will help you detect subtle heart failure. Exactly. And between Sujoy and me, Sujoy works at one of the premier institutions in this country, and I work in a dinky hospital called Apollo Hospitals, Chennai. And I can tell you, to try to get our technician to write EE prime has taken me 4 years. This despite being the largest cardiovascular institution in the country with the greatest number of angioplasties and at least 10 interventional cardiologists at hand, waiting to put that catheter inside you. To get EE prime reported on every echo took me 2 years. Now, I'm not even going to try to measure global longitudinal strain, which is the gold standard. So I don't get echoes on everybody anymore. Instead, what do you think I get? NT-proBNP. The simplest, and don't tell me cost, because today, whether you are in rural Midnapur or in Mysore, some lab will transport it to another place, and the more you order, the less it becomes expensive. So many of the guidelines now talk about an NT-proBNP greater than 125 as increasing the risk for heart failure and diabetes. Fantastic marker. Remember, over the age of 60, use a higher cutoff, which is like 200. But otherwise, an NT-proBNP, the incident heart failure risk is 5.2, and the heart failure hospitalization and death is 3.52. I have a risk score which I have developed, which we use in our EHR, that helps us understand the flow of heart failure, and that also tells you what is the impact based on things. So start using these tools. Your EHR should really be incorporating these kind of things. I'm not trying to sell mine, but I'm trying to tell you, start using predictive scoring. So from stage A, it moves to stage B if you use a biomarker. And this is our study, just a cross-sectional study that looked at patients, and what you'll find is that the average NT-proBNP in a community clinic, the average is around 153, and you'll find as the number of years increase, the NT-proBNP actually increases. So by 10 years of diabetes, the NT-proBNP levels are 225. A follow-up study is in the way, but I'm just telling you this was just published last year in Diabetes Care. So this patient had an NT-proBNP done, it's 300. So clearly, this is when you get an echo and you tell them, I want you to measure subtle things like EE prime. Don't just tell me diastolic dysfunction. So you really have HFpEF versus HFrEF. I don't have time to tell you which is what. There are two different pathophysiologic mechanisms. Both have different outcomes, but it's important to understand that it's not, HFpEF does not always lead to HFrEF. But look at this, something very interesting in this part. The reason why you want to get additional things than just ejection fraction is the diagnosis of HFpEF is largely also made by the presence of an E prime. So an E prime between 8 and 15 and a BNP more than 200 already makes this patient HFpEF. Remember that. So it's a little complex, but remember that the NT-proBNP is a very, very good marker. And lastly, remember for women, the LVMI can be much lower and still have heart failure. I'll show you the women differences in a moment. So here's this patient, 300, 2D echo shows an E prime of 15, ejection fraction of less than 60. Now let me show you something very interesting after this. First thing is, in women, there is a greater attributable risk from traditional risk factors. It's something that we want to understand. Second, there are unique sex-specific risk factors that include this. Lastly, there is a distinct symptom profile. More dyspnea, greater, worse health status. For example, this woman, all she would have done is, she would have just lowered her exercise level to reduce the symptoms that she has, right? Lastly, there is more concentric modeling, more impaired diastolic relaxation. Therefore, sex-neutral ejection fraction thresholds are underestimating LV dysfunction. And we really need more data on this particular area. But remember, women suffer this impact a lot more than men do. Right. What is the first thing you need to do to get the heart failure risk down? Treat the glucose well. A 16% decrease in A1, 1% reduction in A1C reduces the risk of heart failure by 16%. So take care of the diabetes well. Second, what should be avoided? Very controversial, but I'm going to tell you anyway. The moment you get to stage B, the recommendation is avoid these three classes of drugs. thiazolidinedione, sulfonylureas, and DPP-4 inhibitors. So, a little interesting because now thiazolidinediones, you really don't want to stop it till class 3 because they have benefits in at this point of time MASLD. But the data seems to be that sulfonylureas, we keep talking about sulfonylureas and other things, but nobody looks at it in heart failure where there's an actual increase. And for heart failure, there's no distinction between the older and the newer sulfonylureas. For CVD risk, there is a difference. Ischemic deconditioning, myocardial infarction. But for heart failure, it seems to be neutral. Second, irrespective of all these studies, the FDA advisory on DPP-4 inhibitors still stands, right? I won't get into the details. SAXA is different, the TCOS is different, LINA is different, but FDA has still given you a blanket advisory. It has still not taken away saying this is better or that. But I have a feeling when you combine with an SGLT2 inhibitor, the risk goes down, and therefore when you combine it with an SGLT2 inhibitor, it's probably not an issue. Glitazones, clearly there's an increased risk of heart failure, we know that, right? Then, what should be done? The 4 pillars of action for heart failure are SGLT2, ARNI, beta blockers, and MRA. Most of the time, by the time a beta blocker is required and the others are required, you probably need a cardiologist to take care of. I'm too low in that pecking order to understand that part of the story. But let me talk to you about this part of the story, which is where I and most of us are. Today, the number 1 drug for prevention of heart failure in diabetes or no diabetes is an SGLT2 inhibitor. We have data across the spectrum. This is empagliflozin, EMPA-HEART in acute failure, recent worsening, sotagliflozin and recent worsening of heart failure, the DELIVER in chronic stable, which is DELIVER with DAPA, DAPA-HF, the EMPEROR reduced, and then in the preserved heart failure, you have EMPEROR preserved, you have preserved HF, you have CHIEF HF, all of these showing one across the spectrum of heart failure SGLT2 inhibitors. And you don't have to wait for long, start immediately. Before we used to talk about slow progression of GTMD, guideline type over a year to add medications. No. You already want to get in one and maybe the second very quickly. So we understand that almost all diabetics who are at risk for heart failure or who have established indices of heart failure require an SGLT2 inhibitor. There's no doubt about it. But should you add a second drug? And that is a big question. And I won't get into the data. This is a slide that I use, especially for HFrEF, because it makes me understand many things. HFrEF, a little beyond my pay grade, I won't spend time on it. If you have HFrEF, if you have fluid retention, and class 2 to class 4, a diuretic is required. Right? Those who can't take any of these drugs, an ARB. But look at the data on ARNI. For women with any ejection fraction and HFrEF, remember I said we are underestimating cardiovascular function in women? The recommendation is start an ARNI. If it's less than 60, like this woman, you really need to be taking that ARB off and getting the ARNI in. For women of all ejection fractions and those with fluid retention and MRA. So clearly the data seems to be shifting towards adding an ARNI in HFrEF fairly early. So at least at our level, the primary and the diabetes care level, SGLT2 inhibitors, and in a patient like this where there is evidence of HFrEF, starting an ARNI. And then the next level, I think, belongs to a cardiologist. So this is the paradigm study, which is looking at sacubitril valsartan. The paradigm HF showed a 20% reduction in primary endpoint, 21 degrees in heart failure, decrease in NT-proBNP that comes on fairly well, ejection fraction improving. This is an HFrEF study. The Pioneer HF study also showing greater NT-proBNP decrease in sacubitril valsartan. So clearly, the addition of sacubitril valsartan with an SGLT2 inhibitor is something that's recommended as a second pillar of therapy in HFrEF. The third and fourth pillars I'm not going to talk about, it's way beyond my pay grade, but I think the idea of this talk was to help you understand that heart failure exists, that diabetics are at risks, we need to measure it using a biomarker, follow it with an echo. Most patients will qualify for an SGLT2 inhibitor. Well, everybody qualifies for an SGLT2 inhibitor because it should be in a tap water, but at least these patients do. And then maybe ARNI in most of these patients. So, in this particular patient, reworked, the cardiology opinion was obtained, lifestyle changes were changed, SUTZD and DP4 inhibitors were discontinued, started on dapagliflozin, basal insulin, you could use a GLP-1RA again, the data on it. Then ARNI was started, ARB was discontinued, statin was continued. So, I do primary care diabetology, and I think most of us do that. For that, I thought I will illustrate a simple patient without too many studies, too many HRs and RRs, so that we understand this a little better. So how many of you will get an NT-proBNP after this talk? The rest slept. Thank you so much.
Thank you, Dr. Sheshadri sir. So,
You slept to that part.
Questions at the end, please.
so thank you, Dr. Sheshadri sir. So, may I request Dr. Sunil Gupta sir for his talk on managing diabetes around IVF treatment. So, I think everyone knows Dr. Sunil Gupta sir. He's renowned diabetologist from Nagpur. And his work in pregnancy and diabetes is known for all of us, and he was national president for diabetes in pregnancy group during 2021-22. So over to Dr. Gupta sir.
Yeah. Thank you very much, Dr. Deshmane, Dr. J.K. Sharma. Thank you, Purvi, Manoj, and the whole team of DRS for this honor. And my today's talk is little untraditional, and thank you very much that this topic is one of the rare topic which is being covered in most in meetings. Treatment of hyperglycemia around IVF pregnancy. There's no conflict of interest for this particular session. Thank you, DRS, once again for this keynote address. Now, this is a slide which will have an introduction, some risk and the challenges which we face. Why do we get more GDM in IVF pregnancies? Do we have different strategies, those who are IVF pregnancies versus those who are conventional pregnancies? So, IVF use is rising globally, everyone knows, due to increasing infertility in our society, and IVF is among the most effective ART method. IVF pregnancies carry higher risk of obstetric and perinatal risk than the spontaneous conception, and there is high prevalence of GDM in IVF pregnancies. Uncertainty still remains on the optimal timing of the screening, when there should be screened, specific management strategies in IVF related GDM. There are no clear-cut guidelines and in the management of such pregnancies. Everyone knows that the global incidence of diabetes in reproductive age is growing a concern, and ICMR data itself says that almost out of 94 crore adult people above 18 years of age, almost 24 crores of them, they have glucose intolerance or dysglycemia. And that means every fourth individual above 18 years of age have some kind of dysglycemia. And we know that IGT in non-pregnant state is GDM in pregnancy above 140. And that is why practically every fourth woman otherwise also is likely to have some kind of glucose intolerance during pregnancy. Fertility and pregnancy outcome is again affecting the society, and there is a unique challenge of this assisted reproductive technology when it comes to women developing diabetes. So both maternal as well as neonatal risk increases. IVF itself has been linked to higher propensity of gestational diabetes, adverse perinatal outcome, and complex clinical scenarios in the specialty. GDM guidelines, we don't have the specific recommendation for this. and we have only small reviews, and nationwide evidence and clear national guidelines are still missing globally. And women who conceive with IVF had around 21% higher risk of developing GDM compared to those with spontaneous conception. So global risk, if you say around 17%, India we have around 28, it varies from 18% to almost 22%, and the IDF guidelines say that Southeast Asia every fourth woman, that means almost 25%. So every fourth or fifth woman is likely, and IVF and GDM risk is 43% higher GDM risk in patients who have IVF, and regional spots is 25% prevalence in the Southeast Asia. India, we again have the higher risk of GDM already, and when it comes to IVF, then possibly it's going to be every second woman likely to have some kind of hyperglycemia in pregnancy. Even there could be many cases of mild GDM, which is again a category which is being ignored. Now, what are the risk factors we have? So India, we have the estimated pool of prevalence around 13%, which is possibly much lower mentioned here. Overall, if we say it's around 20%, and we have to have a crucial, and then we also have polycystic ovarian disease. Most of these women who are coming for infertility treatment, they have obesity, they have polycystic ovarian disease, which itself is a concern and a risk factor for diabetes. So what are the factors which is commonly seen in IVF setting is most of these women are at least they are elderly. So if you see the average age of women in GDM, it is 30 years. Common non-GDM, it will be around 28, 29, and in the IVF women, it's around 33.5. And obesity, PCO, and ART procedure itself. What is the pathophysiology about the IVF causing high risk of GDM? So IVF cycle induces the supraphysiological estrogen levels, which can significantly alter the endometrial as well as the placental development. This combined with the metabolic stress inherent with the ART creates a unique physiological environment. Diabetes itself profoundly impacts the reproductive health by affecting oocyte quality and hindering the embryo development and compromising the endometrial receptivity. The synergy between the diabetes and ART further amplifies the risk of critical obstetric complications, which include preeclampsia, macrosomia, preterm birth, along with the potential neonatal metabolic issues that can have long-term implication on the child. So to summarize this particular slide, IVF cycle have supraphysiological estrogen levels and metabolic stress, altered endometrial and placental development. It will have its diabetes effect, compromising the oocyte quality. If you have diabetes, oocyte quality will be, means pre-existing diabetes, then you will have oocyte quality, which might have its impact, embryo development and reduced endometrial receptivity, and the combined risk will be increased risk of preeclampsia, hypertension, macrosomia, and preterm birth, and other metabolic complications. And these children who are born to these mothers have higher risk of having metabolic syndrome in their life. So challenges are high that we have, unfortunately many of them are still 50% of the people with diabetes are still undiagnosed. Those who are diagnosed, they are not taking medication and they are not controlled. Accidental pregnancies are common in our scenario. That's another challenge, but here we are talking about IVF pregnancies. So we have overlapping risk of elderly pregnancy, obesity, PCO, infertility, which all combine together to increases the risk of GDM in such pregnancies. So what are the solutions? What should we do? Practically every woman who is planning for IVF should be undergoing the preconception counseling and care. We should be trying to assess their glycemic status but much before they are planning for IVF. And intensive preconception counseling is must. Screening of all the candidates. It should not be selective. It should be all the candidates, all women before undergoing IVF procedure should be screened for diabetes and pre-diabetes. And if they have pre-diabetes, if they have diabetes, then they should undergo preconception counseling care, achieve all those glycemic target preconceptionally. These are the preconception counseling norms that we have to achieve: fasting blood glucose less than 92 hours, less than 120, HbA1c to be achieved at ideally less than 6 before getting conceived. if you can achieve up to 6.5 is acceptable, except in type 1 diabetes where you have to, if in view of hypoglycemia, you can accept up to 7% of HbA1c preconceptional in these ones. But when it comes to IVF pregnancies, and if they have pre-diabetes or diabetes, you should first achieve that insulin remains the drug of choice in such women. Insulin is preferred drug, and of course you have to have very strict control and strict monitoring. Oral drugs are not the first line therapy in such pregnancy because they are already high risk individuals, and the doses have to be individualized. These are the targets in type 1, in GDM, and those who are GDM not treated with insulin. Now, there are some guidelines about the management of pregnancy where they have just not too much covered about the IVF pregnancy, but they say that such women should be should be subjected for preconceptual counseling more aggressively, and it should start from the much before you go for the procedure. And these are the checklist from various places. So when you talk about pre-existing already type 1 or type 2 diabetes and undergoing IVF pregnancy, in that situation you have to see for their vasculopathy, rule out microangiopathy. If they have pre-existing retinopathy, you have to assess. There are some absolute contraindications for pregnancy. You should know these contraindications. If someone has proliferative diabetic retinopathy, cardiomyopathy, autonomic gastroparesis, or someone has severe diabetic say coronary artery disease, or even chronic kidney disease, those patients with chronic complications, either any of the vascular complication, there is relative contraindication that we should know about. And if they have everything through, then also see the coexisting drugs. They should not be on statins, they should not be on other oral drugs, they should be only on insulin therapy before they are planning for IVF procedures, and they should be well evaluated for statin should be stopped, ARBs and ACBs if they have hypertension should be stopped beforehand and should be shifted to the safer drug. So good, safe antihypertensive drug, safe glucose lowering therapy, safe no statins are being allowed except very recent recommendation for the familial hypercholesterolemia, where it has been allowed that if you feel that such patients are having very severe hypercholesterolemia, familial hypercholesterolemia, they may be continued with statin. No other patient should be kept on statins. So these are some of the, and of course smoking cessation, lifestyle modification, weight reduction, all these things should be, and of course retina examination and laser photocoagulation should be done beforehand, and if it is indicated. So these are all preconception things which should be done. Management part, of course, once you are diagnosed to have GDM, those who are, I'm not talking about pre-existing type 1 or type 2 diabetes planning for IVF, but even those who are developing GDM for the first time after the IVF procedure, the treatment remains almost the same line, but here again, instead of metformin or sulfonylurea, we prefer insulin therapy in such women. So basic principle remains the same: medical nutrition therapy, physical activity and weight management, and of course 70% of them may do well with diet therapy alone, but rest of them may need insulin therapy. But in my opinion, they are elderly patients, high risk women, and many of them have infertility for years together, and sometimes it's just the only chance, and that's why insulin remains the drug of choice for them. Of course, regular exercise will also help. Insulin becomes a drug of choice. All type 1 diabetes, practically all type 2 diabetes and GDM, also this becomes a drug of choice. Again, I'm not going in detail of it. Sulfonylurea, though it has, glibenclamide has been approved, but government of India has, as well as DIPSI has not approved it yet, and very few people are using it, but not in this IVF pregnancy. Again, I'll avoid metformin at this moment of time unless and until the patient is obese and severe insulin resistance, and where insulin is not so capable enough of achieving good glycemic control, you can add. Insulin remains the drug of choice. And of course, postpartum follow-up of these women is equally important. 85% of these women will become normal after the delivery, but 15% may remain hyperglycemic, and they will again need insulin till they breastfeed the baby. And rest of the women need to be go for postpartum care. So every rule of 6th day, 6 weeks, and then 6 months, and then once in a year, you are supposed to go for oral glucose tolerance test or the HbA1c after the 3 months of postpartum. and they should avoid the postpartum weight gain also. That should be our strategy. Ultimately, what is important is we have awareness about GDM now across the country because of the because our government of India has declared 10th of March is a National GDM Day, and now awareness has become a part of the DIPSI as well as the government of India, and most of the clinicians who are involved in the care of pregnancy diabetes are involved into education. And we also do this Prega Talk, which is one of this unique program in the world. We have 22 languages in the Constitution of India, and we do this program in all the languages. We have completed first cycle, second cycle, and we have started now the third cycle. And we already completed 6 programs in the third cycle, and we'll continue doing so under the auspicious guidance of Professor Sheshiya. And I'll appeal every one of you, if they're not doing so, please do that. So finally, irrespective whether it's IVF pregnancy or any pregnancy, the glycemic control during the pregnancy is at most important. Early detection, early treatment, early intensive control, and not only neonatal outcome. If you want to give a best outcome in this baby in their adult life, you have to give a good, healthy intrauterine environment to avoid the epigenetic risk of developing non-communicable disease intrauterine. And that is why we say if the glycemic control can be maximized to the extent that the fetus no longer recognizes that the mother has diabetes, then the treatment of mother during the pregnancy may become the first step in the prevention of obesity and diabetes in the offspring of diabetic mother. And this is what is the primordial prevention is before the baby comes in this world. So it is a growing challenge. We need to have holistic approach. It's early screening, intensive glycemic control, collaborative therapy involving gynecologists, involving diabetologists, endocrinologists, and physicians. And the risk has to be explained to the patient. And of course, not only you have to have a baby, but also have a healthy baby and a healthy future of the baby. And that's why don't underestimate the early control and treatment of GDM to aggressive manner. I always show this slide before I stop, wishing you all a happy Ganesh festival, Onam, Teachers Day, and stay safe, stay healthy, and keep smiling, or stop cutting the cake and cookies, and give another message to the society: cut the fruit and not the cake to celebrate your birthday or anniversary. Thank you very much for patience listening.
Thank you, Dr. Sunil. May I invite Dr. Krishna on the stage, and also Dr. Simon, please come on this stage. So, before we take the questions from the audience, I would like my co-chair, Dr. Rajesh, to start the question.
So, Dr. Simon, one question for you. If the C-peptide levels are on higher side and in patient with secondary diabetes due to pancreatitis, so would you opt for insulin therapy or oral anti-diabetic agent in clinical day-to-day practice?
The C-peptide was diminished?
No, it's on higher side. It's normal or...
I would always use insulin. I just think I have better control. I don't think that in this condition, the response to sulfonylureas is consistent, and indeed, if there's progressive loss, just think that insulin is the treatment of choice. If you have experience, frankly, I don't have experience in using sulfonylureas in that condition, and if people get it well, but I guess I've always been told insulin is the treatment of choice. I know how to use it, and I can titrate it and teach the patient accordingly. That's the answer to your question.
Thank you.
To Dr. Krishna, in your patient, why did you not use the GLP-1 RH?
That's actually a very good question, and I think the answer is you should have used a GLP-1 RH. This patient, we just used insulin because that's what she wanted. But today, there are there's a lot of data that is coming in saying that there is a fifth pillar for heart failure, and that fifth pillar is a GLP-1 RH. Absolutely. If I were to go back and talk to that patient, I would tell her very strongly, maybe the GLP-1 RH is the right drug. And for most patients, a combination of GLP-1 RH and SGLT2 inhibitor is in fact a very, very good way to do these things. Absolutely. Where's Banshi? He wanted to ask the same question.
Yes. Banshi has gone. He has given it to me to ask you. So, Dr. Simon, you have shown about the Indian studies of the cystic fibrosis and the FCPD, everything. How is the status in the Western world?
I mean, cystic fibrosis for how I use it in the Western world?
Yeah, and what is the incidence and of the FCPD and the cystic fibrosis?
I think that in Western populations it's pretty similar around the world. What was it? I think out of the population in the US, and I don't frankly know the numbers in Australia, I don't actually know the numbers in the UK, but I think in the Western world they're pretty similar. We're talking, I think by the time people get into their 30s and 40s, 40% of that population have it. Of course, they're the survivors, and it's only in the last 15, 20 years that we've seen people survive into that. The adolescent population is much smaller. I think we have around 10 to 15% in my own hospital, in the multidisciplinary clinic, people, teenagers with cystic fibrosis who have that. But the longer they live, the more the likelihood is they'll develop.
Thank you. So for Dr. Sunil, any question from the audience, from the floor? Yes, sir. Roll off.
Which actually have dual injection, I mean insulin on one side and glucagon on the other. And if the diabetes, of course the cost is a problem, but then if the diabetologists were to convince the government to reduce the customs duty and all other taxes, I think this would be a very good answer for control of diabetes, particularly if you can set the levels if you want to, desired levels.
Yeah.
So,
I feel you are talking about the bionic pump. So we are yet to have it available here, but then we have now AID system available, which is 780G, which is practically one of the almost matching that of the requirement of a person with type 1 diabetes without glucagon, of course. Yeah. But you have an inbuilt sensor and the pump, and it's being synced. So it's a good tool, and most of our patients who are on this particular device, insulin pump, they are achieving good glycemic control across. And it's a good tool before, of course, we go for the glucagon also inbuilt in that. I feel that will come little later.
But rather than using the drugs, why don't you use the pumps?
That's mainly for, usually it's being used mainly by type 1 diabetes and few of the type 2 diabetes who are having multiple dose of insulin therapy. And I'm more about pregnancy diabetes. Yes, certainly it can be used even in pregnant women. In type 1 diabetes, we have good data of using insulin pump and having good neonatal outcomes.
Numbers you should tell me. Numbers you should tell me.
I agree.
So thank you. So please.
Now we take the honor to present the mementos to our esteemed speakers. Dr. Rajesh, please, to Dr. Simon Heller. Dr. Krishna. Thank you. This is self-help program. Everyone.
Thank you to our wonderful speakers. Moving on to the next session, a dialogue on insulin, I would like to invite our chairperson for the session, Dr. Brij Mohan from Kanpur and Dr. Kavita Rane from Mumbai.
Good evening, everybody. Thank you, Manoj, for the opportunity. And this is about insulin. Way different from what we heard from in the previous session. The speaker is going to be none other than Dr. Rishi Shukla. He is going to, what his biodata says, he's a very good friend of mine and from Kanpur only. So it's a Kanpur session basically. And we have Suresh also, Suresh Damodaran. Rishi is DM Endocrinology and Director and Head of Department of Endocrinology at Regency Hospital. And he has lot of publications. He has keen interest in type 1 diabetes. Recently he is going to organize a national level meeting on type 1 diabetes at Kanpur. And over to Rishi.
Good start? Yes. Okay, so you got it. So good afternoon, everyone. Thank you very much. And it is a duologue, actually. So it is going to be not one speaker, it's going to be two speakers, and we're just going to make more fun in terms of just discussing and making it answer to the questions.
Just hold on, Suresh. I need to introduce you also at the same time.
Okay.
Suresh is MBBS and MRCP and internal medicine specialist, diabetology and endocrinology specialist. He is from Coimbatore, consultant diabetes and endocrinology at Ramakrishna Hospital, Coimbatore. Over to Suresh and Rishi also.
Thanks for apologies, sir. We didn't know that you haven't completed. So it's going to be a duologue, and we'll just try to make more entertaining by just asking ourselves questions and then try to come up with some answers. So I think it is about the unlocking the power of innovation with a new generation of insulin and the need to advance from human insulin. So we have moved in a lot of ways with our practical things in life, like that for the usage of insulin. We have to move on from the human insulin, how we do that and how practically we can think about few options and what are the challenges and what is the evidence available and how to switch over very smoothly. And this is the whole agenda of this program. So we got financial disclosure and it's Novo sponsoring the talk. So the agenda is going to be about the conventional insulin. So what is available, how it started and what are the things that has happened over the years. And after that, what are the challenges that the insulins are facing out, why we need to think about the other generation, new generation insulins and the new generation co-formulation, how it is made with the solubles and rapid acting ones. And the third one is about the new generation of basal insulins and then the new generation of bolus insulins as well. So this is our agenda. We'll just take it. So the context is about 8 in 10. These are the challenges. These are all the unmet needs that is in the diabetes. So we got 8 out of 10 have got uncontrolled glycemia. And then the 2% will have more A1C. You and me see in the practically in the clinic. So HbA1c of 10 and other things. So, and insulin initiation is still a challenge. We all know that. And with gliptins and SGLT2s and incretins coming into play, the delay of insulin initiation is extending more and more, and the average is around 8 to 8.8 years, and only 3 out of the 10 being managed with insulin. And there is one data is missing. There are only less percentage of people who are managed properly with insulin. So because a lot of insulins are happening ad hoc, how well it is managed and what are the appropriate insulin for the right guy, that is also a thing that is not done in Indian context. So I'll leave it to Dr. Shukla to start. One more thing, it's just about the injections 2 injections with NPH, and then a lot of changes after that, and then that came to where there is a less variability. Insulin was discovered with nocturnal hypoglycemia, and the insulin development, as I said, has come long way from animal insulin. I mean, those days we got trained, I think that was the pork insulin is going out of this thing. We're talking about 94, 93, those kind of times. But before we dive in, I just want to ask Dr. Shukla, can we elucidate what are the clinical challenges? So persist with the conventional formulation what we got now, and can you explain to us these challenges, or how we can rectify the challenges as well, but what are the challenges mainly? I leave it to you, sir.
Thank you, Dr. Suresh. A very warm good evening to everyone. Thank you, sir, Dr. Bijmohan, Dr. Kavita, for nice introduction, and thank you, Novo, for the opportunity. Actually, whatever I am going to speak, we are going to talk about new insulin, everybody knows it. But one thing for sure, it is not possible for any new insulin to have existence without the old. So this is the basic thing. And it is more than 102 years. 1923 the insulin came, and now 25, so 102 years, a lot has happened. So every insulin will be new and every insulin will be old. But we're going to talk whatever is at the moment. The challenges with conventional insulins are variable absorption, slower onset, less predictable action, delayed action, high risk of hypoglycemia, no meal time. So lot of things are there, but we have been using these insulins. So this is one thing. It's not, we have better insulin, but at one point of time, it was also better. So this is one thing that one has to keep in mind. And the best part with the conventional insulin is that it is a cheaper insulin also. So that thing you have to keep in your mind. With the known limitations of conventional and premixed insulin, I think this is the question for you. I can read for myself.
Yes, sir. No, I can do that, sir. So I think you explained it in a way. These are the challenges. Now I'm going to ask a question. With the known limitation, we know that conventional premix have got the challenges, what you mentioned, the less variability, slow onset, and delay in getting action. So how does the evaluation of the co-formulation insulin improved glycemic control, and whether it's safe to use it, and what are the safety outcomes? So I want to know your input on the glycemic variability, the safety outcomes, and other things. So I'll leave it to you, sir.
I think we have moved a long way from mixtures to analogs to co-formulations, and what next? And next is also in the row. We have icodec insulin, we have the combinations of various insulin, we have vinase. So a lot has started happening. So with the known limitations of conventional and premixed insulin, so we have a basic human mixer, the mixtures, 30-70 mixtures are available. Then analog, the 25-75 or 30-70 analogs. And the third is the co-formulations, the degludec aspartame. By now, only one co-formulation is existing in the market, and this is degludec and aspartame. So the question is, what is difference between premix analog and the co-formulations? I'll not be reading out the thing, but the basic thing is, in co-formulation, in the premix analog, there are 2 molecules, and in co-formulations also there are 2 molecules. But in premix, what happens, there is a one live molecule, that aspartate insulin is the active molecule, whereas the analog is relatively inactive. It works in a subtle way and more or less responsible for the basal control. Co-formulation, both the molecules are active molecule, and these solutions are together in a fixed ratio or a combination. Thank you. And it mimics physiological insulin secretion closely, and no shoulder effect compared to analog insulin, and it simplifies the insulin regime without requiring resuspension, and lower the suspension is no longer, you need not shake it, you can use it as such. And if you look at the co-formulation, it has a very nice HbA1c reduction, and on your right side, the extreme right is the OAD treated patients, and the left one is the OAD plus insulin. And if you look in both the category, when Rhizodec was used, the the fall of A1C was almost equivalent. It works very nicely in fasting and the pre-meal blood sugar control because it has a very nice basal insulin, and it also works very nicely with the postprandial because it has an active SPART component. So whatever meal you are taking, it reduces the post meal. You can take it once, you can take it twice, or you can take it thrice. The safety wise, so far this is the safest mixture, and if you look at the confirmed hypoglycemia compared to baseline, you can observe there is a significant reduction in the confirmed hypoglycemia, whereas on the right side, the severe hypoglycemia, which is a very dreadful. I mean, all of us have experienced severe hypoglycemia through our patients. Patients need somebody's help. They were found unconscious, and more or less most of the time they stop taking nitroinsulin. No, doctor, I don't want to take insulin because it's better to have uncontrolled diabetes than to have hypoglycemia or severe hypoglycemia. So this is no longer severe hypoglycemia. So this is, I think I remember my 2-3 of very well-read patients, they had nocturnal hypoglycemia, and when I put them on this, they are intelligent. Doctor, you have done wonders. So use this molecule and use this intelligently. And it can be used across all populations, from pediatrics to elderly, to fast, to type 1D. I mean, everywhere, very field like to pregnancy, hepatic insults, renal insults. So wherever, whatever is the condition, you can use it. Yes, sir.
Okay. So thank you for explaining that very nicely. So you said that the co-formulation has got its own advantages and there's less hypoglycemia and it's quite safe and quite efficacious. So while we have discussed the efficacy and safety of Rhizodec, that how would you describe the impact on dosing convenience and how it is how it makes a difference? You mentioned 1 or 2 cases of yours, but overall quality of life in managing diabetes, and could you explain on that, please?
The quality of life is what? Life becomes smoother. One thing for sure, whenever our patients use, patient goes into resistance and we go into a lot of persuasion. And when patient starts using it, and fortunately, if patient is switched over from one variety to second or second to third, maybe from mixtures to analog or analog to co-formulation, they can feel the quality. And you can see on your left side, improved quality of life with reduced pricks, found in comfortable to inject Rhizodec, could manage their day-to-day activity. So it matches because you can take it any time of the day. So you have a lot of meal flexibility. And quality of life is, I mean, from baseline and at 26 weeks, you can see that a very nice quality of those for busy workers where meal time is not fixed. They forget. Probably this is one of the best insulin which controls, and the compliance part is also taken care of. So meal flexibility is there. People traveling across time zones, shift workers, and young people, the weekend syndromes. I mean, I was talking to some of the guys outside who are coming, because we'll go to pub tonight, today and tonight pub. So those who are on insulin, so they can modify their insulin, not pub. So this is the way they want to do. So Rhizodec is a pragmatic choice at insulin initiation. Low hypoglycemia, mealtime flexibility, simple regime, better quality of life, not much confusions, and it works very well. The next, I think, next question I'm going to ask from Dr. Suresh. What would you say are the shortcomings of conventional basal? So now we are going to talk about basal insulin. So a word about basal. Yes. Over to you.
Thank you very much, sir, and interesting about the pub thing, but yeah, so I didn't see in that this category of people.
Sorry,
but yeah.
I'm crossing those from apologies from the people, but I think it has to come from heart also.
Oh yes, sir. So I'll join the club. Anyway, so what
he
would
was talking actually? He wants to. But
so I am one of them anyway, so that's why I get the blame always. thank you for this. And so next 4 or 5 minutes or so, we're just going to concentrate on basal insulin. So thank you for updating our co-formulation, how we switch on from the traditional premix and what are the advantages of co-formulation. Now we're just going for the basal. Now isolation of Banting and Best and to animal insulin preparation. We went through all that, and the NPH is the molecule until now providing the sort of basal cover for human insulin, and detamir is going to be go off, phase out, and we still use for a lot of pregnant women, but it's a very good molecule, but it's got its own challenges. And then we got glargine 100 and glargine 300, and then now degludec is also available. So this has moved a long way, and if you look at the half-life of the newer generation thing about glargine U300 and Tresiba, which is the degludec, so we got a really ultra long-acting basal insulin analogs, almost 25 hours of half-life. And then I'll show you some good data, just a couple of slides. It will just demonstrate how the glycemic variability is less, and also the TAR is maintained with this molecule. So this is the molecule that we are going to talk about. Now, this is the unmet needs. We have seen the unmet challenges for the twice daily insulin, but if you look at the challenges for the basal insulin, if you think about the days of insultard, now it's not true insulin once daily, 24-hour coverage is not there, and then the variability is there. That is one of the biggest challenges. And then dosing flexibility. We are mentioning about pop guys, but also the type 1s and other guys who needs a bit of flexibility, and then it should be a peakless insulin, which all we like about in view of avoiding hypoglycemia. So I'll just want to say that these are the unmet needs that is there in basal insulin.
Yeah, I think let me share my experience, because I have done endocrinology almost 31 years. 93, 94 I started, so 25, so completed more than 3 decades. So I'm the person who used lente insulin. I'm the person who used NPH insulin. I'm the person who used, when glargine was launched in Philadelphia, I was there. I'm the person who used youth. And when Dr. Damodar was showing the first slide, I had a very deep respect for the person who evolved insulin.
Absolutely.
From simple insulin to intermediate acting to long acting insulin, and how it modified his life. Because now we are moving into BMWs and Jaguars,
exactly.
And I think I'll call these like that. So coming to the next question, can you deep dive into how the PK/PD properties of Tresiba contribute to its suitability as a basal insulin in clinical practice? Dr. Damodar, please.
Yeah, so we are talking about the BMW. For example, if you got a BMW, you need to identify what are the good things about that BMW and how it is different from the other cars. So if you really want that and the high quality insulin, what is the unique features that makes that insulin to be used just like that compared to other things, and that too in the clinical practice. So if you got NPH, as I mentioned earlier, the onset of action is only 2 to 4 hours, and 4 to 12 hours, it has got its, definitely it's got its role, and the duration of action is almost 12 hours, so we need to give it twice daily along with a rapid acting insulin, then it sorts out. So almost like we got 2 of the basal insulin and 3 of the short acting insulin, which makes it 5. Now glargine U100 has made a difference, and it came up with a real this thing when we are all training. They said the training, and I'm also almost in the same troop, but 2 to 4 hours and 8 to 12 hours of peak action, but the 22 to 24 hour action was there with the glargine, and this is the molecule that made us to all start using basal insulin just like that. But the Tresiba, which made a huge impact with the molecule by itself, it is the fastest onset of action, and then it prolongs for a very long time, so with a minimal peak. So peakless insulin is the one I mentioned about the challenges what we wanted for a basal insulin, and this has provided And that is why I think in clinical practice, if you look at it, you want to use something like that and just forget, so that the patients will not get any nocturnal hypoglycemia, the variability will less. I'll show you 3 or 4 slides on that. So this is the thing that I was mentioning earlier, the daytime glycemic variability. You see the hours here from 0 to 6, 6 to 12, 12 to 18, and 18 to 24. The variability for all these people who are on that is definitely almost neutral. So you see that. And then when you use the glargine, you see that 18 to 24 hours, there is a slight dip in the variability. This tells you that the total glucose lowering effect distributed of the 24-hour period, it is definitely better with Tresiba as a deglutec as a molecule compared to glargine 100. Because if you see all the clinical trials, it's almost comparable or almost compared with glargine U100, because that was the standard molecule for decades. From our training days. So, and then how about the glycemic variability in glucose lowering effect when compared to deglutec versus glargine 100? So you can see clearly the gray ones are glargine 100 and the Tresiba or the deglutec is in the deep blue. So you can see the difference. The variability is more in glargine 100 compared to deglutec molecule. So the total lowering effect distributed within a day, days, the Tresiba as superior. So I've given you 2 things. One is the glycemic variability and then the hypoglycemia. I'll let Dr. Rishi to handle this.
I think while he was describing, I was imagining we had gear cars. Now we have automatic cars. So we need not apply our brain when to put a next gear and synchronize with the speed. Something similar is take insulin and forget it. And if you forget the time, you can take it any time of the day. Even if you forget the day, you can take it next day. So, I mean, the amount of flexibility is too much. Now, I think the another input which I would like to have from Dr. Damodar is, have these attributes transferred into real world evidence? So, over to Dr. Damodar.
So, if you take a BMW, that will be mostly gearless anyway, so it will be automatic. So we got quite a lot of attributes to the molecule by itself. As I mentioned, the fast onset of action, and it's there for a long time, and the variability is less, and the efficacy is more, and the chance of getting less hypoglycemia is more. So these attributes, any evidences, one RCT has to come in, and then the next one is the real world evidence, whether it's proved in our practice. We can all say in our practice it is all there, but when it comes to real world evidence, whether the evidence is available and whether it shows the attributes that we are talking about is translated into clinical practice, the answer is yes. If you look at the efficacy, the baseline 12 months and the change, there is almost like 1.8% A1C change, which means almost like a 60% 60 millimoles or milligram per DL of blood sugar changes. So that is a huge impact when you compared with the molecule. So a significant reduction in A1C and fasting, which is the very, very important thing. I mean, you come up with concepts every now and then saying fixing the fasting first, and the hepatic glucose output has to be addressed and other things. But if you take it, the overall A1C reduction has to be there. And in Asians with the PPG excursions, that with the carbohydrate load, that has to be addressed as well. So the overall A1C is number one, and the fasting will make a huge difference. So if you look at the...
I think just one point I would like to highlight. I think if you look at the baseline 9.6 in 12 months, it was 7.8. So I would always say, give some time. आपको चाहिए एक उम्र असर होने में. So I think there should give some time. Don't run after blood sugar. Don't run. Give some time. Monitor and titrate dose gradually, and don't get panicky. Neither you nor your patients. Yes.
So you mean to say probably not glucose-centric, but there are a lot of things, and don't be just focus on blood sugar in a short time duration.
Then only we'll be able to achieve that.
So we need to be aware of that. But I think when we talk about the molecule efficacy, it is there, definitely proven. And this is the real world evidence. And the superiority of deglutec over glargine 100, this is by TIR. So we are talking about TIR is the scientific way nowadays. When you get a molecule, that excursion should be reliable, or it should be acceptable to provide. You can pass the exam by multiple ways, but the passing the exam in the right way is the one we are talking about. So having less excursion and maintaining the TIR and achieving the A1C will be the right way to do. So estimated treatment difference is significant, and 20 minutes is the variability less. That means the efficacy is super. So we are talking about Deglutec comparing with the Glargine 100. And how about the hypoglycemia? So efficacy is proven now, and then this is for the real world evidence for hypoglycemia. So when you take the BEGIN trial or SWITCH or DEVOTE, which is more of a cardiovascular outcome trial, and then real world evidence of EU treated type 2, which is done in Europe, but consistently proven hypoglycemia benefit is definitely there. When you take the BEGIN trial, 28%, and then the nocturnal hypoglycemia reduction is 49, and then that will lead to severe hypoglycemia reduction by 86%. Almost all the clinical trials are showing the same. So hypoglycemia benefit of Deglutec compared to Glargine across all the RCTs, and then I mentioned about the real world evidence which has to be translated in clinical practice, almost 16,000 patients. So we got a safer molecule, we got an efficacy molecule that needs to be taking care of all the attributes that I was mentioning earlier. So, and then flexibility. How about the flexibility? You know that when it started marketed, it's almost every 3-day molecule, and Icodec is planned for a 7-day molecule, but I think this is the molecule initially planned, so that much half-life and almost 40 hours are there, and there is flexibility is very much so, and it is proven beyond doubt with the Deglutec. So it can be used with multiple population, and pregnancy, yes, pediatric, yes, adults, yes, adolescent, pub goers, yes, and elderly, yes, and the renal and hepatic, yes, and hospitalized patient. And hospitalized patient is much more convenient. I look after a lot of cardiothoracic patients, so putting on basal insulin like Deglutec, it just solves a lot of problem, but you have to explain sometimes the cost and everything to the patient relatives, and they definitely will accept. And that time of post-op period, if you don't get a hypo, and that is the biggest advantage, and they'll eat or they don't eat, or it just varies accordingly. So having a molecule which takes care of that attribute of hypoglycemia is so much advantageous. So hospitalized patient definitely definitely a winner in this aspect. So I would say Deglutec as compared to Glargine, time to upgrade, and the reason for that is I've just mentioned in the last 4 or 5 slides. So action, it is because of the faster and the longer duration of action, and the variability is less. I've shown you a couple of data with glycemic variability and also time in range. And then efficacy, it's super efficacious with the A1C reduction and the fasting reduction I've shown you. And then the safety about the hypoglycemia is less, and it proven safety in RCTs and then real world evidence both. And the convenience wise, it is super convenient with flexibility. So I'm going to ask, so we just done the co-formulation number 1, and we have just touched based on the basal insulin. Now I'm going to ask Dr. Rishi about the bolus insulin. Now bolus insulin reimagined the shaping the future from a strong foundation. So we got Novorapid and other molecules in the baseline. Now how we upgrade it and then shaping the future, I'll let you answer this. Thank you.
So we have base short-acting insulins, then analog insulins, and then ultra-short-acting. So 3 category of insulins we had, and the limitations we have already discussed: slow absorption, unpredictable absorption, does not match with meal time, and the chances of hypoglycemia later is also seen. And lot has happened over the decades. I think 10 decades is a huge period. So now we are seeing one of the finest and best insulin. So from basic short-acting insulin to Lente to analog came in India, if I remember, 1992 or 3, and then the aspart insulin, and various other analog. If you look the physiology wise, it's not coming. The ultra fast insulin starts functioning little earlier, and it tries to match with the meal spike. So, and it finishes faster. So this is the advantage. So spike, the meal spike is definitely lesser. So aspart and ultra short aspart, both are useful. And again, I would not say that everybody should use ultra short acting. Depending on meal pattern, you have to tailor the dose. Then if you use Fias, the ultra short acting insulin, the area under curve is 70% lesser. So the prandial control is a little better. But what is important, and again I am contradicting the fact that A1C is same in both the categories. So this is a very, very important part. Safety wise, low risk of delayed hypoglycemia, which is evident that it starts acting faster and finishes faster. So chances of later hypoglycemia are lesser. But if you eat less, the chances of hypoglycemia within 1 hour, 2 hours are a little more. So that one has to keep in the mind. So within 2 hours after meal, 22%, within 2 to 4 hours, 28%, and between 3 to 4 hours, I think. So it is a convenient insulin. You can use it, it functions faster, and it covers the, I think, post-meal rise of blood sugar, and useful in patients with erratic eating patterns. So I think this is the comparison of regular human insulin versus Fiasp insulin. So it mimics more with the physiology. I will not be going into detail, and lesser chances of hypoglycemia. And it can be given in, as we have been discussing, in anything. And another part is that is at the right side of bottom is you can use it in the pump also. So pump, this is a very good insulin, because pump we have been using 3 types of insulin: regular insulin, analog insulin, and the Fiasp. The chances of hypoglycemia are lesser with the Fiasp insulin. So to sum up, greater A1C reduction, lower risk of oral nocturnal hypoglycemia, lesser glycemic variability, wider window of dosing flexibility, and improved quality of life, because you can take it anytime, and convenience with pen device. So this is, I think, thank you so much. And
yeah, so I think last, thank you, sir. So last 25 minutes or so, you might hear a lot of insulin talks over the period of this conference, but I think what we would like to send a message is that there is human insulins are all available, but I think overall with the newer this thing, people deserve to have a better quality of other insulin, which is also in the market, and it is really the attributes what we mentioned about less hypoglycemia or quick onset of action, and all sort of people can be using, and it produces efficacious results, and it causes less hypoglycemia. So all this has to be taken into the account. So thank you very much, sir. So we have done justice to the time, and also for the molecules by itself. Thank you, and I'll leave it to the organizer.
Thank you very much, sir. I'd like to ask you one question.
Yeah, sure.
So, which insulin would you prefer post cardiac surgery, since you mentioned?
Yeah, I did mention actually. So I personally have loads of cardiothoracic patients in my center, and we have a Portland Diabetes Project and quite a few other things about the wound healing post-op. So I personally, we did an audit because the only way to improve our clinical practice is doing clinical audit. So we started on a lot of basal insulins for the patients with just even oral tablets, because my cardiothoracic surgeon, within 1 day, he just sends patient out and start all the oral treatment. So we tend to give slight dose of metformin and other drugs which is already there, not the catabolic drugs like SGLT2 and other things, but give the right drug and then give a basal insulin. It works wonder, and that's our personal experience. Giving mixed insulin and everything, it confuses a lot for me, just because people may not eat like what they used to with the carbo light overloading and this thing. So if you do have a control challenge, then I use a basal bolus. That's
actually,
my practice.
One line I would like to add: we are conditioned to use glargine insulin. Mentally, we are conditioned to use. One suggestion to everyone: use degludec maybe for 6 months and see the difference. Because there might not be every time hypoglycemia with glargine or every time better control with degludec, but the chances of hypoglycemia, the smoothness of control probably would be better.
Yeah, but the basal insulin is the answer.
Anyone else would like to ask?
Any other question? Deepthi is standing up for a question? No.
So this was not a duologue. Duologue is over now. Now it is your turn.
It's audience time.
Yeah.
Yes.
Yeah.
House is open for discussion.
Yes, sir. Please, sir. Once a week insulin, I think it should be in the pipeline, but I think you can answer the DCGI. Probably they need more data and everything. And for type 2, definitely it is the molecule to be used up. That is out of this thing. And type 1 is also has got this thing, but probably Novo people are the right people who can update you on that.
But what I recall, icodec is a good insulin. And interesting thing is you have to start with 70 units per day, per week. So this would be interesting, and it would be interesting to titrate the doses. We titrate 2 or 4, there you titrate 20 units at a time. So it would be interesting to titrate the doses also. So it is a good insulin. I mean, it would be use one semaglutide, and when icodec task is done. And that's all.
Okay.
So, I mean, like good car. Yes.
So you can answer, guys.
Yes.
It's approved in India now, sir. It's just not launched, but it's approved in India.
Fantastic. So that is the news that he wants to hear.
Yes.
So it is approved. This is from the.
It has to come from horse's mouth. Actually, I was not speaking.
Anybody wants some?
Yes.
No, you're sure. So can I repeat the question?
No,
what
no,
you're asking?
I understand. I'm repeating the question.
Yeah.
You can give it once, can you give it twice, can you give it thrice? Actually, what happens, the long-acting insulin gets deposited into a depot. And depending upon the volume of depot, it gets released. So this is one thing. So you can give it 3 times, you can give it even 4 times. It gets deposited. And short-acting insulin is independent. So how you want to use short-acting insulin? This is the all game. So you can use twice, thrice, or you can use 1 mixture and 2 short-acting also. So it is up to you. You have to tailor doses as per your requirement. Same units. No.
Nobody can audible. The
question is Mixtard to Rhizodec. Is the unit should be any conversion change? I think it's not. Only in pump when you shift, you have to reduce by 25. Otherwise, no need to change. Thank you.
Thank you very much. Sir, I would like to
Thank you.
request you for a moment.
They just get a bad, but do it like that.
Up next, we dive into the future of weight loss with GLP-1 therapies, digital tools and real results, moderated by expert Dr. Manoj Chawla from Mumbai. I would like to invite the panelists for this session, Dr. Krishna, Dr. Banshi Sabu and Dr. Supratik Bhattacharya from Kolkata.
Hi. Evening, everyone. So let me just start this conversation. Drugs, the long-acting GLP-1s or the GLP-1s and the dual peptides. How many of you are using these drugs? So I see quite a few hands going up. And how successful you think every time we've used GLP, just using the drug has been? You think there needs to be something more beyond just the drug, and which is where today we have this session supported by Healthify, which is digital support for weight loss with GLP therapies, and I have a panel of experts. Dr. Krishna Sheshadri, introduced earlier, senior endocrinologist from the city of Chennai. Dr. Supratik Bhattacharya, again, an eminent endocrinologist, diabetologist from the city of Kolkata. And joining them very soon would be Dr. Banshi Sabu, the organizing chairperson for DRS Cody 2025. So let me start the conversation and take this to a case example. The question is, when medication alone isn't enough, do these questions come up when we are using these drugs? Intolerance to medication, aversion to food, eating as reward, no lifestyle support. These are the kind of patients that you see in your clinic. But the statement that I just made and the slide that you see up is pretty vague. What exactly are we trying to convey? And to that, let me ask Dr. Krishna Sheshadri to start taking up these pointers that we have and your thoughts on the patients that you see in the clinic and whether medications themselves are enough. Dr. Krishna.
Right, I think I'm going to take a couple of minutes. To understand this, we need to understand the biology of eating, right? There are two parts to the biology of eating. One is, it is controlled homeostatically, meaning there are signals that go to your brain that tells you the metabolic requirement of the body. I need this much carbs, I need this, I need this. This is done acutely by ghrelin. On a long term, it's done by leptin and insulin. So that is the metabolic part of it, which is homeostasis. But for most of us, food is also a reward. This is done by hedonic inputs, our memory as children, our own taste. For example, the taste receptors in Europeans versus Asians are very different. We like it a little more sweet than the Europeans can tolerate. So, taste. Our exposure to childhood, for example, in the Netherlands, during the famine in the 40s, because of the war, there was an explosion of eating habits after that place. So a lot of these are wired in, for example, I'll tell you, my father grew up very poor. So his one thing was that everybody should eat well. That included the people who came into our house and they would be fed to their gills, right? So past experiences, each of these develop, give you the reward system. So so you like certain foods and then you tolerate certain foods. The second part of this is two hormones. One is the endorphins, the second is dopamine. Endorphins program a likeness for food. Dopamine programs a motivation to get food. You may like something, but your satiety may say, look, I may like it, but I don't want to take it. But wanting that food is maintained by dopamine, right? So what do GLP-1 receptor agonists and others do is, while they also work at the metabolic level and alter the sensations that we have, they alter GLP-1 receptors in the hypothalamus, they work at the level of the liver, they work at the level of the hindbrain, which is the predominant area where the sensations come. They also work at two parts. One is satiety, the second is aversion. Aversion is given at the area of the
what is it called, striatum nigrarum in the corticolimbic area. This is from the area posterima, into satiety. Now, clearly, there is a dissociation between the two. That is why, when you see patients, you will generally, I'm not able to tolerate this drug, really has many connotations. That's really what I was coming to when I looked at the biology of this. One, it could be that I have an adverse event to this drug, commonly nausea, vomiting, and now the GLP and constipation. A lot of the reasons the constipation is actually the food is reduced, and that's really why they're complaining of constipation. But with the GLP-GIP combination, at least in the south and the east, there's a lot of diarrhea. So, adverse events. These are true adverse events. I have nausea because of this. And remember, people, we used to think that the nausea is the way it is working, but that's not true. Second, an aversion to the food. For example, I'm not able to, when I see salty food, I absolutely can't do this anymore. There's the second part. And this is also part of it. The third complaint that you will see is, doctor, it's not the kind of food I take or anything else, but the moment I take a small amount of food, I can't eat anymore, which is exactly how the drug works. And then yesterday I had a patient who said, look, doctor, you gave me this drug. I definitely wanted to go and have a rava dosa at Woodlands last night. I had this for lunch. I went ahead and somehow finished the rava dosa that night. And the next day morning, I threw up all night. So if you look at these four things, one is clearly drug related. The second and third are also drug related, but the second is an aversion that is not the same as intolerance. And third is satiety, which is preventing you from overindulging in the food that we take. Lastly, of course, is this, that if you have your higher cortical functions are still not telling you that, eating so much is a bad thing and you need to get off it, you get this fourth part, that you'll do something, you'll vomit, and then still go and eat, and there no drug can help you. So these are the four parts I thought would be useful for us in the next 22 minutes to dissect out in patients and talk about it. So Pratik, I don't know if you have any comments on.
Yeah. So I totally agree. So we have a hunger center, which is the lateral hypothalamus, and you have the satiety center, which is the medial hypothalamus. And the medial hypothalamus, goes and gives a negative feedback to the hunger center. So it's usually under the negative control. So as he was saying, you have the area postrema and nucleus tractus solitarius, and these are related to the nausea, vomiting sensation. Then you have the delayed gastric emptying time, for that matter, which gives you the sensation of bloating, so as to say. And then you have the vagal afferents that are also related to the vomiting sensation that comes with it. And then you have the areas of the hedonic eating, like the amygdala, which is, they send out negative feedback, and that pleasure eating part, but you can't go ahead and eat too much. And it usually preserves your appetite for healthy food, whereas the carb-dense food, the fatty meals, you can't have a large portion size, even if it is sitting in front of you. So that's the best part of the GLP-1 receptors. The way it works is it cuts out the pleasure eating, but for those kind of calorie-dense food, which is going to actually be detrimental for your health, and preserves the appetite for healthier food.
Okay, so what we're going to do...
Just to add, 1 second, and I think all of us need to remember one thing. While we call these GI side effects, these are not GI side effects, they are CNS side effects. I think that we need to understand that the side effects are maintained by your brain and not by the... Go ahead, sorry.
No, so just said the reason that we're having this session in the evening is, I was well aware that you guys are going to take the fun out of eating completely. So that's the reason we didn't do the session in the pre-lunch period. I'm going to be asking all the three panelists to, it's time. The larger essence of this conversation is, we have these wonderful drugs today. Are they doing enough, or do we require to go beyond that? And as we introduce the subject, this is the era of digital technology and digital therapeutics, which is entering as an associate to the clinician in every field that we are moving in, whether it is monitoring of diabetes, whether it's management of diabetes, whether it's chronic weight management. So when there are great drugs coming in, they require additional support, and which is where we want to take this conversation to. So let's look at these profiles quickly. 46-year-old female, BMI 33, started on GLP for obesity and pre-diabetes, has nausea, cramping and vomiting. The patient says, I've lost a few kilos, but I feel sick all the time. Is this really worth it? The challenge for the physician is balancing the therapeutic benefit with the tolerability aspect and the risk of early discontinuation, which I'm sure all of you have experienced, that more so with the earlier GLPs, probably lesser, but that happens even now. What can we do? The question that we are asked, or we should be asking ourselves, is, do you feel you have the right support system or team in place for these patients? So I take the question to Dr. Banshi. Let me start with this, not only the case, but asking a question. Is GLP for every physician to use, or having a support system is absolutely essential?
So it's very, very important for a support system. Even not, there are many non-physicians, or some of the times when patient is buying on their own and taking it, and they don't get the benefit as required, rather they get more side effects. So its need is there for a complete support system. Even when you start it, a physician has to teach, educate, as he has very rightly said, it's not GI side effects, it's our CNS side effects, and that also you have to explain the patient in advance. They are not, I normally tell them it's not even side effects, these are the effects of the medication. And you may feel fullness, nausea, and you should not worry for all these things. So to continue these patients on a long-term therapy, they need a support system. And where digital engagement definitely helps these patients in the long run. For a, you have said this particular patient, after the few kilos of weight loss, now she is nervous, she is not ready to continue, she might have changed the physician, she is discontinuing the therapy. So I think a busy physician who is, mainly concentrating his practice on an acute management of the things where, symptoms and writing the medication, immediately seeing hundreds of the patients may not be the right one, or the person who is not having the supporting system. So you don't have the educators, social support system, or you are getting the patients from distant places, then also you will be able to see them more frequently. And there the digital therapeutic, or further they can be connected with the digitally, these patients are very, very important. We are practicing in like a town which is having a lot of patients coming from different parts of the country, like he is based at Chennai, Kolkata, or you are in Mumbai or Ahmedabad. So from 500 kilometer patients are coming to you 200 kilometers away. They will not come to take every week or every alternate week or every 3 weeks.
True.
So they need a digital system for them to continue.
Great. So I think the point being made is, everybody should be using these drugs, but everybody cannot have that kind of support system, having a counselor, having a diabetes educator, a nutritionist, an exercise expert. And all of this support system is important for you to get the results, the ideal results from these drugs, and which is where lies the strength of these systems. So let's, you have another patient example, and then I'll take it to Dr. Krishna. 29-year-old male, BMI 30 on GLP for 2 months, significant appetite suppression, unintentional eating, just minimal, less than 800 calories per day. The patient says, I'm just not hungry anymore. Food feels unappealing. I know I need to eat, but I can't force it down. So you'll have some such patients whose appetite goes down drastically. The challenges for the physician is nutritional deficiencies. And how to encourage the healthy eating. Do you really have the means and time to guide on the right kind of protein nutrition? How to handhold such patients who are having severe nausea or appetite suppression? Dr. Krishna, can you do something, or you need help of somebody else to do this?
So there are two parts to this. One is, I think the two, let me make two statements. One is the care of the diabetic patient, especially with chronic care, cannot be for 5 minutes in a doctor's office. I think the moment we realize that, we understand we need more people to help us. This could be a digital tool, it could be a monitoring device, it could be a person who's calling up the person and asking them, and somebody who has more time to actually dissect it out and understand this. The second part is something that I read, which I really like, is that pharmacotherapy has gone from cure to subscription model, which means that every drug is going to come and tell you that you need to take it for a life. And the moment you tell them, look, this is for the rest of your life, you've already lost a battle simply because they've lost their will in many, many places because they're resigned to it. So what is the via media in all of this? I think the first is, in this particular patient, for example, this is not an intolerance. This is an effect of the medication that is creating an aversion to certain foods, right? So you really want someone who talks to them and says, look, which are the foods that you're averse to, right? Usually, oh, I love to go and have chips, I'm not able to have them anymore. Okay, fair enough. You can't stop it, but can you take 2 of it? So someone who handholds them and reviews this on a regular basis is very, very important helping them. The way I talk to patients is this, that the medicine is so doctor, can you do this without a medication? I say, no, you can't. I'll tell you why you can't do it with medication, because you've come to a point where you need a crutch. The crutch is the medication. But if you're only going to use a crutch and not strengthen your limbs, you're never going to walk. The digital support or my nutritionist calling you and supporting and you doing self-improvement based on the tools that we give you is the strengthening exercise that may help you come off the crutch or use it to a lesser degree or be dependent on a lesser degree. So as Krishna says, abhyasa tu kaunteya, the coach is like helping you improve yourself and change the way you eat so that while only 19% of patients will ultimately come off the medication, you could be one of those 19%. So two points. One, don't think that 5 minutes is the end of the life of your patients because their entire life is beyond those 5 minutes. Second, you need a way by which their data comes to you, that and this is not, fill it, shut it, forget it disease. That's what pharma wants you to think, but really you need to help them make those changes. And I don't think any of us are equipped to make those changes without a team. It could be your own clinic, it could be a digital platform, it could be someone or a coach who works with you. My only worry about coaches is suddenly they decide to change their medications. Somebody decides to suddenly send them to most doctors fear this, that they will send you to some other doctor or will recommend 6 almonds for breakfast, 2 peanuts for lunch. No. Somebody who understands what you believe in, who works with you and helps them understand how to use these drugs, how to approach them. I think that's where it is.
Okay, thank you. So we have 10 minutes on this and I want to ask pointed questions. And Banshi or Supratik can take this. Should a family physician use these new drugs? And if so, what tool should they use? Is digital therapeutics more an allied to a family physician without the support system or more an allied to a specialist who has all the support system? Quick answers to quick questions is what I'm requesting for.
So family physicians should know about the subject. They should know that these type of drugs are available. I'm sure many of the times when you are prescribing, they may go and ask them. But I think they don't have the supportive system or neither they have sufficient knowledge to understand the side effects, when to give, not to give. They may listen and see sometimes from the social media, and I don't think they are the right person. But again, now family physicians, other than Mumbai, in other parts of the country, a number of family physicians are less. But definitely, if they feel that they can write it, it's not like they can't write. In India, one can write. So, but then they should have supportive system, and I think they need more supportive system like a digital therapeutics for them.
Okay. So,
but your question was there, the nutrition deficiency and loss of lean muscle mass. That's very, very important. And how to encourage a healthy intake when medication blunts the appetite. So these are 2 very, very important, and that requires a very regular nutrition counseling, monitoring, regular follow-up, asking them and motivating them to take healthy food and to take more protein diet, for lifestyle to change, going for exercise, doing muscle mass strengthening exercise, all those are very, very important.
So, Pratik, the question to you, when you start these newer, more effective GLPs and dual peptides, what should be the frequency of follow-up? What should the physicians here tell? How often should these patients follow up with you in the initial days after you've started? And body composition analysis. So for all of you, the BCA machine is there in one of the stalls outside, and all of you are welcome to do your own body composition analysis, look at your own muscle and fat mass. It's important for us to know. How often should do the BCA where it's there? These two questions.
Yeah, so I think the whole idea is to empower the patients at large. And as I say, reinforcement is needed. So that 5-minute conversation that we have with the patient is probably not good enough. And that needs to be, backed up. They would be signposted to somebody who would be having the same conversation again. And it's bound to happen that they are going to come back and ask the same questions, and they need a one-to-one support. Now, body analysis is done for me at baseline and at each visit. So usually, the protocol is when you're stepping up the dose, it's in dose steps, and then you go like every 4 weeks if they can tolerate. But I'm saying that you don't need to force up titrate. You can jolly well make them stay back on the same dose as long as they're connected to you. You can always ask for their feedback, and that's why that support is very much essential. So that when they go back and start on the medication and they, face the challenges, they can get back to you. If they can't, find you directly, there'll be somebody in the team who'd be addressing that, and that's why you need that support that, they'd be talking to you. You had already done that conversation before. You'd have talked to them about what challenges they might face after starting the thing. But once they are actually facing it, they want to have a chat with the doctor, and this becomes much more easier if you have somebody in the team who'd be catering to them on a one-to-one basis.
So we're going to open this up for last 5 minutes to all of you who have questions on GLP usage, to the 3 experts here. So keep your questions ready. A quick question, Banshi. Patient comes and tells you, you started on this drug, doctor, but खाने का मजा ही खत्म हो गया है. I used to enjoy eating, right, or drinking or whatever at the end of the day, and I've worked hard enough, but I just don't enjoy that. You've taken away the joy of eating. Do you hear that, and what to do about it?
This is, I think, what we should explain in advance also. It's not the joy which is important. You also have to tell the patients about the health and benefits, because ultimately a healthy life is going to give them a lot of happiness. And we also talk to them about the cardioprotective and then the fatty liver part, which is also a bigger person with obesity have all those complications to happen to them. So I always explain them, and we also ask them, what you are saying that this is, or by seeing this type of foods you would like to have, you can't resist yourself. So as here said rightly that, the quantity can be small, and then slowly we change it. And that's the reason we need more follow-up, these patients, because they require a lot of motivation. Otherwise, they will stop it after 1 or 2. So initially, when in last 4 months, what I have done is, in some of the patients, we have given them and we ask them to come next week only. Now, after 2 weeks or 3 weeks, or on telephonically, we are connected with them, or we ask them, if you develop any problem or any issue, please call us. And now all these things we are doing. So this digitally engaging them will definitely help. Now this digitally does not mean that all the time you have a third party. Your team can be digitally connected. You can be connected.
But
on
how do you help
WhatsApp.
with the joy of eating not there on digitally?
That's what you have to tell them again and again, and motivate them for.
Yes, Krishna.
So, see, I think Indians generally understand when we explain it into their own philosophical terms sometimes, that we are not necessarily the bogies of the West. You tell them, look, you know that this is bad for you, but I understand. The reason the joy of eating is that they associate food with a reward. The medication is now doing what you should be able to do yourself, which is to dissociate food from a reward. And how is it done? It's done with practice. There's use a discriminatory function. Every time you think about food, think that is this something that I really need, or this is something that I'm just doing it for the pleasure of it. And that comes with just practice. It is abhyasa tu kaunteya is the right word. It comes slowly over a period of time. Then why do I need a drug? You need a drug it is like, taking a dip in the Ganges. All the years of accumulated fat you need to get rid of. So that the drug does. But can you prevent this from happening? By adopting these practices, and that comes by training your mind to think healthily. I think that's really where, time with the patient, and if you can't do that, a coach doing it makes that difference.
Essential.
That engagement is what is that engagement doing? It's creating that change through repetition, through reinforcement of adopting the healthy lifestyle which we've lost. That dissociation from the reward is the key.
I think that's important. The essence of whether we do it or digital therapeutic is the engagement. I invite questions. Any of you interested in asking questions, please come up to the mic in the center and then line up there so we can take the questions. Yes, sir, I'll start with, I have a lot of questions here, but I'm going to take a pause here and let the audience
Hello,
take
sir.
that.
My question is that in the Indian scenario, whatever you have said, it is a very pertinent, important thing. But apart from all those things, in my opinion, we must study the genetics of the patient. How the genetics is going to affect the GLP-1 respondents and non-respondent. What's your opinion?
Quick answers to these questions.
So remember that there are no genetic markers of GLP response. So there's no blood test you can do for it. 10% of your patients' glucose will not come down. 10% of your patients' weight will not come down. So unless you try it, you'll never know who's going to respond or who's not going to respond. Everything else there are markers, but for GLP-1 response there is no marker.
See, nowadays a lot of problems are coming with and the retinopathy is concerned with GLP-1. And the cause is not known, and a lot of patients are suffering retinopathy. What we have done, how far we have come for that? Retinopathy.
Go ahead, please answer.
Diabetic patient.
I don't think a lot of patients have this problem. It's a rare problem.
No, sir, I have 3-4 patients I have seen.
You have three patients with NAION. Then you should report it, sir.
No, is it NOION you're talking about or just worsening retinopathy? Here, sir. So worsening retinopathy.
Those who are on GLP-1.
On GLP-1, they have increase in retinopathy. It's a complication, normal complication of diabetes also. So they have diabetes retinopathy. When you are tightly glycemic control, when you are tightly controlling the glycemia and with GLP-1, there may be slight increase in it. But if you are talking of NION, it's very rare. It's not like very common side effects. We should explain the patient about the common side effects which they may have. Again, as I told you about the GI side effects or the diarrhea some of the patients which they may have. Sometimes you may have to discontinue only for those reasons. It is not recommended to screen them also because it's not a very common side effect. It's a
They are all related with
Any
the
other
diabetes.
question?
So I'll quickly explain that you have to screen the retina at baseline, and then if you see background changes, not worrisome, non-proliferative, be watchful, and early worsening is known, but it's not like you can't use it. In fact, if you're using it for a long term, you probably do justice. But in advanced retinopathy, you have to be very, very careful using anything which is robust in bringing down the A1C very fast. Not just GLP-1 receptor analogs, it could be insulin
or
therapy.
any of them.
So they're all known to cause early worsening of retinopathy, but that doesn't warrant you to stop using it in background retinopathy or
Thank you.
early
Sir,
stage.
Sir, I'll let the next doctor take the question. Here, sir.
Sir, nowadays when diabetic patient goes for the surgery, invariably we stop for the medicine for a day or two. And now there are cases are coming where the doctors, they recommend to stop the GLP-1 before any operation.
Banshi,
Why?
I'll take this. Sir, here. You have a complete session on this of perioperative management on GLP in this conference and you'll get that answer. So sorry for I'm cutting you short. I have another question and then we're winding up. But this you will get this answer in this conference. We've kept that topic.
Yeah, hello. I'm a family physician and I have patients coming, non-diabetic patients coming for the weight loss, and now all these drugs are available, the information is available on the media. So they just come and ask me, how do I start Rybelsus? What is the investigations do I do? So like as a family, you said that family physician should use it with caution. So now the patient, the information is available everywhere. They know the names of the drugs. So I just want your opinion, like
So-
if it is a non-diabetic patient.
So Rybelsus is not for anti-obesity.
Yeah,
Rybelsus is
so-
the oral semaglutide which is approved for as an anti-diabetic agent. Injectable semaglutide which is available in India is Wegovy or Mounjaro which is available.
Mounjaro, yeah.
Yes, dual, which can be given. But in an obese person, I think first they also need to be investigations and all other things. It's better. And then you should ask them that these are the medications which are available. It is best that they should take from those doctors who are regularly prescribing it and they can follow it also.
So
and
if-
you can also follow these patients once they are taking from the consultant to whomsoever they are taking.
Right.
And
So
then you
if
can
the-
follow these patients
If the
regularly.
patients are above 60, I expect some comorbidities and go with caution. But now the younger patient, now
No,
because
but even for the comorbidities, these are the medications which are actually preventing. Even with the patient with established cardiovascular
no, but
disease also.
if the
with
patients
fatty
are
liver disease
younger,
also.
30, 35, and if they want to use it for the still
So, ma'am,
The caution.
one thing be cautious about, if it's an obese patient with gallbladder diseases, they might end up in pancreatitis. So you be very, very cautious who are coming to with gallbladder stones, and then be watchful about starting and not monitoring them. And you have to tell them about the red flags, and then if a pain develops and if it's, something of a red flag nature, they need to get back to you immediately.
So I'm going to stop all of you here because we're way out of time. Sorry, Dr. Rishi, Smruti, but there are multiple sessions on these new drugs today and tomorrow, so you will all get the answers. With this, let me thank the panel here. May I ask all of you to come in the center to receive the mementos. Thank you all for that nice discussion. The experts are around for those who still want to talk about GLPs and digital therapeutics. They're around to help us. Thank you. Let's hear a round of applause for these amazing experts.
Thank you, experts, for a wonderful session. Up next, for a session on diabetes and beyond one, I would like to invite the chairperson, Dr. Mahendra Patel, Mumbai, and Dr. Anirudh Makhija, Mumbai.
Good afternoon, everyone. So now the topic is basically type 2 diabetes and beyond. Basically, all the clinical, what we do in our daily practice, the topics are related to your clinical practice on daily basis. So I'm inviting Dr. J.K. Sharma from Delhi. He is IPF Global Ambassador, founder and Secretary General, Innovative Physicians Forum, and Treasurer of RSJ National. So Dr. S. Sharma, up to you.
Thank you very much, chairpersons. My heartfelt thanks to Dr. Manoj and Dr. Purvi and the entire team. Can I request everyone at the back to please come inside and close the door? Now, after listening to these mind-boggling talks of the new generation anti-obesity, anti-diabetic drugs, I will take you in next 15 minutes to the basics. And that is very important for all of us. And the topic given to me is the dermatological manifestations of diabetes. When a diabetic patient comes to us, the dictum is that we must examine the patient thoroughly. Then only we can pick up these things. Or we ask the patient some leading questions also, so that we come to know that what exactly the patient is suffering from in relation to the dermatological. So, can the integument be the curtain raiser for poor glycemic control? If the glycemic control is not good, then definitely these symptoms appear and the signs which we have to look for. The incidence is 30 to 70% of diabetics in different studies, and at times they may precede the development even before the development of clinical diabetes. Prevalence is similar in type 1 and type 2 diabetes, and they are more common in type 2, whereas autoimmune related lesions are more common in type 1. Good metabolic control may prevent and help cure some of these. If we look at the cutaneous markers of diabetes mellitus, we can classify them into the cutaneous manifestations, cutaneous concurrences of diabetes, then diabetes associated with dermatological pathologies, and the diabetic therapy causing cutaneous complications. This is the etiopathogenesis, and the seat anchor is the hyperglycemia. There occurs the endothelial metabolic dysfunction leading to retinopathy, neuropathy, nephropathy, and other vascular complications. And we can see that these are the basic things for anything related to the complications of diabetes in all systems. The pathways are different: the polyol pathways, the hexospin pathways, protein kinase C pathways, and AGE pathways, but I will not go in detail about these. And we can divide them into vascular, metabolic, necrobiotic, bullous, infections, neuropathic, treatment related, and the miscellaneous. And I'll take you through one by one. Diabetic dermopathy, the shin spots, there are multiple round oval macules over the shins, thighs or forearms, hyperpigmented and atrophic. Twice common in older people, should have more than 4 lesions, and they are the marker of microvascular disease, high correlation with the diabetic retinopathy. So if you find these in any of the patients, look for the retinopathy as well, because of the endothelial proliferation, past positive deposits in the BM of the blood vessels. And this is a typical picture of diabetic dermopathy. So you must look for this in your patients. This is another picture. Then second comes the rubeosis faciae, diabetic aurum. Rosy redness of the face, newly diagnosed diabetics, 60% hospitalized patients with diabetes associated with vascular tone and increased viscosity, that is the functional microangiopathy. A sign of poor glycemic control, and with the improved diabetic control, it returns to the normal, and this is the typical feature of the diabetic aurum. Then the erysipelas-like erythema that mimics acute dermal infection by streptococcal bacteria, well demarcated red areas in the feet and leg. They are painless, lack of systemic signs of infections. Compensatory increased peripheral microcirculation caused by decreased perfusion due to the large vessel disease, and this is the picture you can see. These are the erysipelas-like erythemas. Then comes the pigmented purpura. RBCs extravasation from the superficial plexus, then frequently associated with the diabetic dermopathy and increased incidence in elderly diabetics with cardiac failure, marker of microvascular disease. So if we do not know, the thing is our mind does not know, the eyes cannot see. So first we have to ourselves learn how to look for, what to look for, and then of course we have to look for all these into. This is the pigmented purpura. Then comes the periangle telangiectasia, which is very, very common and seen in up to 49% of the diabetics. Megacapillaries and irregularly elongated loops, often associated with nail fold erythema, accompanied by fingertip tenderness and ragged cuticles. Functional microangiopathy, engorgement of venular limbs, tortuosity indicates structural changes, and this is the typical picture of the periangle telangiectasia. Now coming to the metabolic. Acanthosis nigricans, we all know about this. Eruptive xanthomas, yellow skin and nails, and the diabetic scleroderma. Acanthosis nigricans, they are symmetrical, verrucous, hyperpigmented plaques associated with papillomatous skin tags, axilla, nape of the neck, occasionally hands and feet also, mucous membrane. Hyperinsulinemia stimulates IGF receptor on Kc plus dermal fibrillite. And I'll not go about the treatment because if I start treating these patients, it will be very difficult to cover this topic. This is very, very typical. So always look at the back of the neck, nape of the neck of the patient, and you can find, and this is very typical of insulin resistance. This is at the axillary region. Now look, so these are the common photographs which I am showing you of this acanthosis nigricans. Then the hair and syndrome, hyperandrogenism, insulin resistance, acanthosis nigricans, you can see, and this is the typical picture which has been shown here. Eruptive xanthomas occur in less than 0.1% of the diabetic patients, very uncommon. Crops of small 1 to 4 millimeter yellow papules with an erythematous halo may be pruritic and tender. Buttocks and extensor surfaces of the body appear in association with the elevated triglycerides, resolve with treatment of the increased blood glucose levels and the lipids, and these are the typical eruptive xanthomas. They look like this. Then the yellow skin and the nails. Prevalence is 40% in type 2, more common in elderly, and most evident in the distal end of the helix caused by hypercarotinemia and protein glycolation end products. Diabetic scleroderma, non-enzymatic glycolation of the collagen. Finger and dorsum of the hands with limited joint mobility. Chest, neck and shoulder, there is increased dermal thickness. Difficult to tend the skin. May be subclinical, and it improves with tight glycemic control. So you can see that the tight glycemic control controls many of these features, and they improve with that, and that remains the main important part in the management of this. This is the diabetic scleroderma. Then we come to the necrobiosis lipoidica and the disseminated GA. 0.3 to 0.7% of the diabetics, case series of 107 patients, 60% diabetes, 20% impaired glucose tolerance, 15% patients precede the development of diabetes by more than 2 years, more common in females, Caucasians, type 1, and mean age of onset is around 34 years. Well circumscribed papules, radial expansion, sharply demarcating slightly depressed yellow waxy plaque with erythematous raised border, central atrophy with telangiectasia. And they are pretibial, medial malleolus, chronic course, 20% damage spontaneously in 6 to 12 months, and this is very typical of the necrobiosis lipoidica. This is another picture. Then comes the disseminated granuloma annulare. No clearly established association between localized form and diabetes. Symmetrically distributed on the arms, neck and upper half of the trunk and less open on the legs. Runs a protected course, and this is the picture, disseminated granulomatous annulare. So once you have seen these patients, you will never forget in your lifetime. Once you've seen one patient, you will remember always, but you have to look for, at least have once a good clinical examination of your patient, physical examination, especially when the blood sugars are not under control, patient coming to you for the first time. This is again another picture of disseminated granuloma annulare. So now come to the bullous diabeticorum. More common in type 1 males, usually confined to the feet, occasionally hands, spontaneous, not related to trauma or infection. Blisters contain sterile clear fluid, rest on a non-erythematous base, and it heals in 2 to 3 weeks without scarring. This is the bullous diabeticorum. You must have seen a number of times. This is another picture. Now 3 types of bullous diabeticorum. Common type is clear sterile blisters on tip of the toes, fingers, heals without scarring and intraepidermal cleavage.
hemorrhagic bullae heals with scarring cleavage, multiple tendon non-scarring blisters in sun-exposed areas. Now I come to the infection, which is again very, very important. Infections can be of bacterial, fungal or the viral type, which you must be seeing it more commonly. The common skin infections in diabetic patients are Staphylococcus, furuncle, carbuncle or ichthyoma, then Streptococcal pyogenes, cellulitis and erysipelas, and then Pseudomonas, malignant otitis externa, cellulitis, osteomyelitis, meningitis, cranial nerve palsies, mortality is 50%. So they are more difficult to be treated. Toenail infection and toe web infection is also there, and this is a very, very typical picture of the bacterial infections. Now impetigo, you see the photographs. Furuncle. So what is erythema? Chronic, asymptomatic, symmetric, red, scaly, macerated plaque in the axilla or the groin, non-clostridial gas gangrene, which is another important region, develops in soft tissue near a gangrenous focus, and the pathogens are E. coli, Klebsiella, Pseudomonas, and the bacteroids. And this is the picture of the erythema. Now fungal infections, again very, very common, oral or the perlic, vaginal melanoposthitis, interreginous skin including toe web, paronychia, nail infection, and the dermatophytosis like incidence not increase in diabetes, commonly caused by Trichophyton rubrum. And look at the picture, these are the fungal infections. Very common, very commonly patient comes with, and patient himself tells that, look doctor, what has happened to me? These are again the fungal infections. And look at this, fungal infection. Then very important is melanoposthitis. And this has increased after the use of these SGLT2 inhibitors. If we do not educate our patient properly and the patient does not keep the local area clean, then this is the infection. These are the various pictures of melanoposthitis. This we all have seen the rhinocerebral mucormycosis during the COVID times, especially associated with the ketosis. Sorry, black crust, pus and turbinate, nasal septum, palate and the orbit, and a number of patients have been operated for this. Cerebral involvement in 2/3 of the patients. Treatment I will not discuss. And this picture is very common. We all have seen during the COVID times, different patients, and especially those patients who have received the oxygen therapy, it was more common into that. Now coming to the viral infections, they are the fulminant herpes zoster. I don't know how much effect the vaccine does in preventing these, but definitely vaccines are for prevention. Fulminant herpes zoster, recurrent herpes simplex infection, and the mechanism behind the cutaneous infection stands as deranged microcirculation, which causes decreased phagocytosis. And this is the picture of herpes zoster. Herpes simplex at the angular region of the lips. Now we come to the neuropathic anhydrosis, hyperhidrosis, and the neuropathic ulcers. Anhydrosis, neuropathic ulcer, these are circular, punched out ulcer in the middle of a callosity over the metatarsal heads. And if there is involvement of the peripheral nervous system, diabetic peripheral neuropathy, and on the top of that, if there is a peripheral arterial disease also, then this incidence increases. Now we come to we treat diabetic patients, and what are the complications, skin complications of the diabetes, treatment related, and one very common, this is the diabetic therapy and the CADRS. But the insulin reaction to the insulin, immediate localized generalized edema, urticaria, delayed itchy nodule 4 to 24 hours after inspection. Then this also we see the lipoatrophy, circumscribed depressed areas after starting the treatment, lipolytic component of insulin preparation, immune complex mediated inflammation, and the lipohypertrophy also. And you must have seen this picture in a number of your patients, those who are on insulin. Now I come to miscellaneous. Vitiligo, localized generalized forms, 1 to 7% in type 1 diabetics, may be a part of the polyglandular syndrome type 1, and treatment again, we don't know about what treatment it is.
but this is the common picture which you have seen. So this is also related to diabetes. This is vitiligo. Then lichen planus, very common, and you must know pruritic, pinpoint papular, polygonal, plain topped, violaceous to grey itchy papular lesions. They may be purple at trauma prone sites, Cobner's phenomenon being positive. If you just half a minute more, sir, half a minute. So if the patient start itching, because they are itching, if the patient start itching, the number increases. And this is a typical picture of the lichen planus. Psoriasis, papular squamous condition, chronic relapsing, trauma prone sites. This is psoriasis, you all know about that. So the incidence is increased in diabetic patients. So these are the key points we should look for all such type of cutaneous manifestations. But dear all, if we do not know, our eyes cannot see if our brain does not know. So please study it well, look at your patient, examine your patient thoroughly, and then only you can pick up, because certain lesions patient may not tell. And with that I finish. Thank you very much.
Thank you, Dr. J.K. Sharma. It was a wonderful talk on cutaneous presentations in diabetic, and the fact that more often people who are not knowing they're diabetic, they come with these manifestations and then they get to know that they're actually uncontrolled diabetic. Thank you so much. Thank you.
Thank you.
Now I call upon Dr. Nilesh Kapoor, who is an MBBS, MD, CCBDM. He's a senior consultant, physician, diabetologist, lawyer, and health tech entrepreneur. He is visiting consultant with Kailash, Yatharth, and Manipal hospitals, founder secretary of Noida Extension Medical Education Association, founding team member of Eka Care, various other memberships, and he's ex-WHO, USAID, MOHFW, and more than 16 publications in national and international journals by Dr. Nilesh Kapoor.
So thank you very much, and it's indeed an honor and pleasure to be on this August platform, and I've been interested to talk about this detailed support for improving insulin initiation and optimization. So how we are going to take this is basically what are the current challenges, probable detailed solutions, the clinical evidence around them, how we can implement them in our day-to-day practice, and what are the future probable directions. So everybody knows that diabetes prevalence in India is, in fact in the world, is increasing multifold. In 2021 it was around 537 million and estimated to grow to around 783 million by 2045. And type 2 diabetes mellitus is the most common type, accounting for almost 90% of all diabetics worldwide. In India, as per the latest ICMR India B study, we have around 101 million diabetes and 136 million pre-diabetics. So it's a huge number. Now coming to detailed health. So what actually is detailed health? So it is limited, it includes but not limited to these 11 subheadings: the remote sensing and wearables, telemedicine, data analytics and intelligence, predictive modeling, health and wellness behavior modification tools, bioinformatic tools, medical social media, dataized health record platforms, patient portals, DIY diagnostics, decision support systems, imaging, and now we also have AI, which is kind of coming up in a big way. So what are the factors which are favoring digitization in India right now? So I believe fundamentally there are 4 things which are happening in parallel. First is the advent of AI. Second is the Ayushman Bharat Digital Mission, which has created the digital tech stack for the country. The advent of 5Gs. In fact, the mobile internet penetration is around 76% in the country. It is estimated to grow to around 86% by 2030. And the 4th tangent is the Personal Data Protection Bill, which has been formulated in 2023, which ensures that data cannot be used for the purpose which it was intended to be, and in fact ensures data privacy and security. So coming to the context, so why do we need insulin in type 2 diabetes? So basically there is a progressive beta cell failure in type 2 diabetes, which necessitates often that insulin be introduced to control the hyperglycemia, and guidelines advise starting insulin when non-insulin therapies fail to achieve glycemic targets. Now the timing of this introduction of insulin is very, very critical, and if timely introduced, it can prevent complications in select patients with severe hyperglycemia. So early insulinization is crucial for preventing further deterioration. In fact, all the major guidelines like RSDI, ADA, they recommend starting with basal insulin and eventually moving on to basal bolus regimen as per need. Similarly, in type 1 diabetes, also insulin plays a major role. In fact, the physiological needs of type 1 diabetes require lifelong insulin replacement from diagnosis to achieve near physiological glucose control through basal bolus therapy or insulin pump technology. The clinical challenges incorporate proper dosing requirements, in fact, carbohydrate counting and frequent glucose monitoring. There is also a high risk of DKA and significant hypoglycemia risk during optimization phase. So the optimal approach is a structured education combining insulin adjustment protocols with frequent monitoring to gradually achieve target glucose levels whilst minimizing acute complications. Now, what are the barriers and facilitators to insulin therapy optimization? So again, this was a study, and Dr. Manoj Chawla was one of the expert group members who wrote this study. And what they found out was that there are 4 kind of factors which are barriers. So there are patient-led factors, there are physician-led factors, there are healthcare system factors, and there are technology-led factors. So if you look at the patient-led factors, the barriers are fear of hypoglycemia, therapeutic misconceptions, low health literacy, complacency in long-term type 2 diabetes patients, high cost and limited access to supplies. Some of the facilitators are structured education and counseling, accessible digital tools, family involvement in management, peer support groups, and shared experiences. Among the physician-led factors, the important ones are clinical inertia in adjusting regimens, limited consultation time, concerns about precipitating complications. In fact, there is a significant clinical inertia, and many times physicians even fear losing a patient because if they will introduce insulin, they might, the patient might move to some other doctor. Some of the facilitators can be evidence-based titration guidelines, targeted CME training programs, integrated clinical decision support tools. Among the healthcare system factors, the important barriers are shortage of diabetes educators, fragmented care pathways, pronounced rural-urban digital divide. This term is important. The facilitators are integrated multidisciplinary care models, multilingual digital health platforms, task sharing with nurses and educators. The technology-related factors, the barriers are low data literacy among key populations, usability concerns, insufficient personalization. The facilitators can be real-time glucose monitoring with feedback, user-friendly applications, automated titration algorithms. Adherence and persistence, so 44.3% non-adherence rate is there, and 20% first-year persistence is there. So these are alarming statistics, again from important studies. So what can be the detailed support to overcoming insulin therapy barriers? So we need educational tools, something like apps and healthcare platforms. Some of the, in the previous panelist also, Healthify Me was one of the examples. I have not taken it as one of the examples, but it is there. Reminders and feedback, mobile reminders to check blood glucose or take insulin. Remote monitoring. Clinicians can track patients' glucose logs online, enabling timely dose adjustments. Especially now we have CGM devices where all this is possible. If we look at the digital health ecosystem overview, so we have got CGM devices, smart insulin pens, mobile applications, automated insulin delivery systems, telemedicine platforms. If we look at the digital intervention types for insulin management, so we have got mobile apps which can have titration calculators, glucose diaries, educational content. We have got telemedicine platform for remote consultations. India's e-consult guidelines, which were formulated during COVID-19, are very much in vogue, and they facilitate structured teleconsultations for diabetes care. Connected devices like CGM, so there are examples like Beto and Dexcom, which sync with apps, smart insulin pens, track dose history and timing for better adherence monitoring. We have got AI and EMR systems, especially Eka Cares. We have got a voice-based scribe also, which is like a text-to-speech, speech-to-text engine, which can record the patient conversation and convert into a codified language, sort of data input. Peer and social support, online support groups and chatbots like MySugar help with motivation problem solving for insulin-related challenges. So in a nutshell, if you look at the digital diabetes ecosystem, it includes CGM devices, smart insulin delivery systems, algorithms, medical apps, e-prescriptions, telehealth solutions, and e-health records. So digital intervention types for insulin management, So they said data is the key, but which one is it? So a little bit of humor for everybody. Among the CGM devices, so basically what it is, it's a small electrode placed under the skin measuring interstitial fluid glucose, real-time reading transmitted to the smartphone or receiver every 1 to 15 minutes, trend arrows showing glucose direction and rate of change, and customizable alarms for high-end glucose levels. The clinical impact is improved time in range without increasing hypoglycemia risk, enabling more confident insulin adjustments and reduced glycemic variability. Smart insulin pens, so basically they are detailed dose capture, automated recording of insulin doses, timings and amounts, creating an objective record of therapy adherence. There is a bolus calculator as well, personalized insulin dosing based on current glucose carbohydrate intake. Real-time connectivity, Bluetooth integration, smartphone applications, memory display is also there. Smart insulin pen, clinical benefits, dose accuracy, adherence improvement, and data visibility. These are three major, you can say, benefits of smart insulin pen. Similarly, we have got automated insulin delivery systems, which include these 4 or 5 system components: a CGM device, an insulin pump, an algorithm, a user interface, smartphone app for monitoring and meal announcement. And if you look at the way it works, is there is a predictive low glucose, suspended hybrid closed loop, and full closed loop. So these are how it works. So how it aids system clinical outcomes? So almost 70% time in range, 53% hypoglycemia reduction, and 0.7% HbA1c improvement. So these are all studies which say. Mobile applications for insulin management. So we have got insulin dose calculators. We have got glucose tracking kind of instruments like CGM and BGM. Lifestyle logging like comprehensive meal exercise factor documentation. We have got many apps which do this thing. We have got apps or online platforms which provide educational resources like interactive diabetes self-management content. So what is the clinical evidence? So mobile app interventions, so there's 100% adherence improvement. All 7 clinical studies which I looked at, they showed that. 2.1% maximum HbA1c reduction and 0%, so zero safety profile. So no severe hypoglycemic events reported in pilot studies of app-based titration. So this is something which is to look at. So insulin titration algorithms, we have got static algorithms, we have got adaptive algorithms, we have got dynamic algorithms, and model-based systems. And you can go into the details in the paucity of time. I would just skip it for now. Among the AI-powered insulin optimization, we have got voice-based AI assistants, faster insulin dose optimization, predictive analytics, personalized treatment is there, clinical decision support systems now have come up, especially in the newer EMRs. You will find you can ask questions, and LLM-like models are already integrated into them, and they can kind of guide you how to go about it. Telemedicine insulin, so virtual consultations you can do.
giving us that glucose-centric approach is still important and very important. Now next point is whom we are treating. What is my patient which is sitting in front of me? So you know Dr. Mohan's like low clusters and difficult nomenclatures, but we should know a patient sits in front of me. What is his character? So most of our patients with this analysis have low HDL, high TG, more insulin resistance and more insulin deficiency. Similarly, which I was a part of this, severe insulin deficient diabetes is the more predominant, and these patients are obese when you take Indian type 2 diabetic patients. So whatever therapy we are using is, we should always remember there is more pronounced beta cell dysfunction. So we need more insulinotropic. That's why incretins are working so good in Indian patients, because they produce more insulin. Then we need sulfonylureas, we need DPP4 inhibitors, and we need insulin. So because beta cells are not working and they are going down. So when I see my patient, the diabetes at younger age, MI is at decade earlier than the rest of the world. There is a faster ectopic fat gain for a given BMI. So more ectopic fat, that's why the 35, 40 years of patients are getting diabetes. If you see Sarin's talk, 8 years old children are having fatty liver, which is a good publication. Dr. Yajnik's, which maternal nutrition study, children are followed. 8 or 10 years children born to GDM mothers, that's different, but still they are showing adiposity, which correlates more with beta cell dysfunction. So we are born, we have genetic predisposition for beta cell dysfunction, and once it is there, it's a more rapid beta cell deterioration in Indian type 2 diabetes. Within 2-3 years, the glycemia goes up. If you can see, chronic kidney disease, a patient of normal albumin, say 30-60, within 3 years he will come with frank proteinuria. That all of us routinely see because we don't control glucose rightly and intensively in such patients. We lose time because we don't use insulin or whatever, but most of the time insulin is required. If we want to actually see this rapid beta cell deterioration and glycemic deterioration, if you want to curb that, we need good kind of insulin. We have seen many times that there is no stage like impaired glucose tolerance in Indian patients. A NGT gets frank diabetes because of this adiposity at younger age, liver fat, beta cell dysfunction, as I said, genetic predisposition, epigenetics, and of course in girls, pregnancy. So frank diabetes is coming very fast. Once someone gets diabetes, there is, as I said, deterioration, getting complications early is very often seen, and unless we are tuned with the intensive control, we cannot make this beta cell dysfunction, which is progressively increasing in patients. So we need, there is a insulin is relevant, whatever combinations I am using to tackle all these problems and preventing my patient to reaching all the complications of diabetes. We were taught like microvascular and macrovascular. That was a typical kind of a complications like nephropathy, retinopathy, neuropathy, microvascular. Big arteries, macrovascular. Microvascular, glucocentric. Big arteries, not glucocentric. This is gone. So please don't take neuropathy. We know at diagnosis it is there. There is a role of adiposity there. Heart failure is no more a micro or a macro. It's itself a combination. Diabetic kidney disease itself, it's a different complication. You can't categorize it. So you can't categorize that microvascular needs intensive A1C and other complications. No, intensive A1C control is required everywhere. And what about the leading cause of death in type 2 diabetes? Now it's cancer, which again correlates with the A1C levels. And of course, duration of diabetes. Dementia, liver disease, sarcopenia, all these complications are also important in type 2 diabetes and increasing, and they are nowhere in our micro and macro. So we are forgetting, they get neglected in day-to-day practice. So need to redefine the complications of diabetes. Here comes, I want to tackle the obesity, which is a major part of all these complications, and of course the glucose, which is also very important. So incretin and insulin, both are required for that good prevention and good treatment of type 2 diabetes and these complications. So we need both. Insulin is definitely relevant, and whatever insulin it's, whether it's injectable, oral, inhaler, but we need insulin. And of course, if it is oral, it is still better, because I have done clinical trials with oral insulin, inhaler insulins. It goes in the portal circulation, the oral insulin first. like natural insulin. So its effect goes through the portal liver, then it goes to the periphery, but it will come. So we need both incretin insulin to tackle these menace of type 2 diabetes, which is because of adiposity as well as hyperglycemia. Just a study grade, I think though, it is good to remind and see the nuances of this good study, where what it did, type 2 diabetic patients of 8 to 10 years, they all were on metformin. Then they were put on either liraglutide, glimepiride, sitagliptin or basal insulin glargine and followed up for 5 to 6 years, and it was a good learning kind of a trial. What you see here, these two are liraglutide and a basal glargine. There seems to doing better, whatever is the A1C below, around 7, 7.5, whatever target A1C, different kind of outcomes. And you can see here, the glargine and incretin are slightly better. So glargine and liraglutide were more effective in maintaining glycated hemoglobin levels, target range over time. Sitagliptin was the least effective. Glargine was the most effective in maintaining around more percentage of patients were maintained are between around 7 and 7.5. So it was a very good trial which taught us, so even metformin plus one drug is not sufficient. That's what this trial is telling, and it's still telling that glargine insulin was better. If you see the adverse event, of course GI was much more with liraglutide, nothing it's expected. Severe hypoglycemia was generally uncommon, affected more participant to glimepiride group. So it was not with basal glargine. Also, if you see the weight changes, of course weight loss with liraglutide much more, but even with glargine, there was a small weight loss, there was no weight gain. Even if you remember the origin trial, 7 years long, glargine insulin, I was a part of that, and still it never showed severe hypoglycemia much. It never showed weight gain. So these two issues which are actually create a fear for using insulin early are not there in big trials. And even cardiovascular safety was established with origin trial for glargine. So insulin is a must, it is a better, it's a good tool if you want your patient to have it. So what grade actually concluded? All 4 medications when added to metformin decrease HbA1c. However, glargine and liraglutide were significantly, modestly more effective than sitagliptin and glimepiride. So what was the learnings? What I feel, it is a very good large number of patients. The overall results highlight the difficulty in achieving and maintaining recommended glycemic. And what was the target here? 7%, not 6.5. Even 7% was difficult to achieve with 8 years duration of type 2 diabetes. This is the baseline. Even 2 drugs are not sufficient. And again, I want to highlight, grade was done in United States. So it was most of a white Caucasian population. If you do this in India, we know that metformin monotherapy doesn't work good in Indian patients, not at all. If you see the verified trial, it will show that Indian patients do not respond very well to monotherapy of metformin. They fail much earlier. So we need something more than that. So this will be much more higher in Indian type 2 diabetic patient if this is in US. Another learning was during a 5-year follow-up period, A1C less than 7% was not reached. Even in a good clinical trial setting, 71% of patients did not reach 7% at the end of 5 years, even with 2 drugs. So it's more kind of a message for us that we need more combinations right from the beginning to achieve that 7% without hypoglycemia and weight gain. Another learning that even the patients who were baseline A1C was 6.8 to 7.2, even these patients, to only 60% actually could have that kind of a target level of 7. So in general, type 2 diabetes, these are the patients from US. For them, even that population, it was difficult. What will happen in India if we conduct such kind thing is definitely we know. Just 2 slides. So in the era of fixed drug combination, I know incretins, GLP-1 analogs, dual incretins, triple agonists, we all are important because we are need to obesity and weight is very, very important part, but we can't forget hyperglycemia. So these combinations, we have lixisenatide, we have degludec plus liraglutide we used for some time, and now icodec plus sema is coming and so on. There will be more and more combinations. So one injection. So I am not going in detail of this, but if I want to manage this menace of type 2 diabetes, I will use one injection with incretin plus a basal insulin and a SGLT2 inhibitor. If needed, I will add another. So this is best, one injection, one tablet, patients will be fine. Then if you can have all other drugs, whatever. So you cannot remove insulin from any combinations, and that is the need. These are the goals. Intensive A1C, whatever is the duration of diabetes, without hypoglycemia weight gain. We need decreased variability, which is very good, showed with degludec in the DEVOTE trial. I was a part of it. Just fasting variability, which was controlled better with degludec, and all the organ protection which I discussed and the adherence, it improves. So insulin is definitely relevant if it needs to achieve these goals. So insulin is a must. Insulin and incretins are today's Jai and Viru, that's what I will say. So insulin is relevant, as well as we know incretin are so much important in our patients. Thank you so much.
Ma'am, as much as I would hate to, thank you so much for this wonderful and bringing so much expertise into your talk on shedding light on the complications of diabetes and importance of injectables to a great extent. Thank you so much, ma'am. Thank you. Moving on, I would like to invite Dr. Rajesh Deshmane, who is a consultant diabetologist and metabolic physician at Kolhapur. He's an ex-registrar, Department of Endocrinology, SAIT GS, Medical College, KM, Parel, Mumbai, principal investigator, global and regulatory clinical trials, and several publications and names in various journals, and life member RSSDI and other organizations.
Thank you.
Over to you, sir.
Thank you, Chairperson, and thank you, Manoj and Purvi. So my topic of discussion here is prevention of type 2 diabetes with pharmacotherapy. And right now, just Shailaja ma'am highlighted certain points about Indian diabetic patients. So Indian diabetic patient, they progress very rapidly from normoglycemia, NG2 to pre-diabetes and diabetes. So its progression is very fast. Diabetes development is also very early in Indian population as compared to Western population, and keeping this in mind, it's very important to think of pharmacotherapy while prevention of type 2 diabetes. As we know, the diabetes is progressing day by day, and the numbers of people suffering with diabetes increasing. And if you look at the Southeast Asia, the percentage-wise improvement increase in another 20 years is almost 73%. So almost doubling of disease burden in another decade or more than that in coming years, and that needs to be taken care. And if you look at the prevalence of pre-diabetes in India, it's very high. The recent ICMR INDIAB study clearly reveals the pre-diabetic population is similar number of pre-diabetic residing in India. And if you look at the data, from Maharashtra, it's almost 12.8%, Jharkhand 8.1%, Chandigarh 14% people with pre-diabetes. And the data from one of the laboratory source, almost pre-diabetes in adult population, almost 22% population, they are pre-diabetes. So, and this is our Indian nation's graph, in which you can clearly see the Madhya Pradesh, Rajasthan, Delhi, Chandigarh, West Bengal, the prevalence of pre-diabetes is more than 15%, so it's very, very high. And yes, the recent publication from Diabetes Care 2024, which clearly tells us that Indian pre-diabetic patient, they progress to type 2 diabetic very early, and they only spend 9.7 years in pre-diabetic stage, either IFG stage or 6.1 year in pre-diabetic IGT stage before development to type 2 diabetes. And the rate of progression is very rapid once they land up in either diagnosed with either pre-diabetes or IGT. So the conversion rate is also very high, 8.6% per annum. And that's why it's very important to prevent that progression from pre-diabetes. So IGT, IFG, and pre-diabetes, these are some distant categories with a little bit of differences. So particularly if you look at the IGT, in which the 75 gram OGTT, the 2 hours sugar is between 140 to 199, and it's because of mostly impaired first as well as second phase of insulin secretion. Particularly, they progress much rapidly to type 2 diabetes as compared to IFG alone.
And important thing is the risk of cardiovascular disease in such population is higher as compared to IFG. The impaired fasting glucose people in which the fasting blood sugar is between 100 to 125, basically the defect is in liver particularly. The first phase of insulin secretion is impaired, as well as there is more increased hepatic glucose output, as well as there is a postprandial hyperinsulinemia. So that's why there is little bit difference, and that subtle difference we need to know while prescribing some pharmacotherapy. And if you look at the conversion rate from pre-diabetes to type 2 diabetes, it's in between 32 to 60% over a period of 5 to 7 years. So practically 7 to 10% per year, they are converting from pre-diabetes to diabetes, and it's really worrisome. And why should we use pharmacological treatment? So we know statins, we are using left and right statin for primary prevention of cardiovascular disease. Whenever ASCVD score is more than 10, we start prescribing statin. And that's why, if you look at the reduction, relative risk reduction, particularly in MACE, it is practically 20 to 30% relative risk reduction when we prescribe statin to patient with high CVD risk score. And number needed to treat one cardiovascular death is almost 45 to 22 with statin use. And what about type 2 diabetes then? So type 2 diabetes, we call it as a coronary risk equivalent. Its leading cause of CKD, risk of stroke is almost 2 to 3 times higher. Its leading cause of permanent blindness, its life expectancy is reduced by 5 to 10 to 17 years, and quality of life is also impaired, problematic with type 2 diabetes. That's why it's very important to prevent the progression of type 2 diabetes. Then why pharmacotherapy? We have data that diabetes prevention program, one of the best study in which lifestyle modification shows 58% relative risk reduction. But apart from that, we have metformin which shows 31% relative risk reduction. With acarbose, 32%, or veglibose, 40% relative risk reduction. Pioglitazones, almost 70% relative risk reduction. We have liraglutide, 78% relative risk reduction. And we have a bariatric surgery in which almost 80 to 90% relative risk reduction in progression of type 2 diabetes has been seen. So yes, on long-term basis and in long-term run, it's very important, not just diet and exercise, but pharmacotherapy plays very, very vital and important role in preventing the progression of type 2 diabetes from pre-diabetic patients. So this is actually a diabetes prevention program in which intensive lifestyle modification, metformin 850 twice a daily, or standard lifestyle modification were used for almost a period of 3 years. So, and also that time troglitazone was used, but it was discontinued after 1.5 years because it was banned because of liver toxicity. So what the data says, almost 31% relative risk reduction in patient with metformin arm, and with lifestyle modification, 58% relative risk reduction. So very good data with metformin as well as diet and exercise. But problem, if you look at how they have implemented this program. So there were 16 sessions taught by class manager, and it's 1:1 basis during first 24 weeks. Thereafter, monthly 1-to-1 session, as well as group session to reinforce behavioral. So it was very reinforced program, 1:1 discussion about diet, exercise, and the adherence were followed up. But after the program has been completed, 3.2 years, then they converted into a DPP outcome study, which was continued for another 8 years. But look at the weight loss. Initially, the patient in DPP lost almost 7-8% weight, but immediately after that program stopped, they again regained the weight, and after 4 years, their weight remains same as whatever the metformin loss. So, in progression of type 2 diabetes, still we do not consider this molecule when in eligible patient. I'm not talking about all patient, but eligible patient. And number needed to treat one type 2 diabetes from pre-diabetes is just 18. So this is alpha-glucosidase based AGI based prevention strategy like STOP NIDM as well as EDIT program, where it has been clearly shows that with STOP NIDM there is 36% relative risk reduction from progression from type 2 diabetes, And the Chinese diabetes prevention program, almost 60% relative risk, and it did trial 8%. So we have SGLT2 inhibitor based intervention. Particularly this data is from DAPA CKD trial as well as DAPA heart failure trial, in which it has been clearly shown that there is almost 33% relative risk reduction from progression of type 2 diabetes in non-diabetic patient, those who are enrolled in this trial for either CKD purpose or heart failure purpose. So that has also been seen. Then there is, why it's so with SGLT2 inhibitor? So the reason behind SGLT2 inhibitor improving the glycemic status, particularly the metabolic status, is it improves hepatic as well as serum triglyceride level. It decreases visceral fat. Also, it has a positive impact on hepatic liver fat content. And all this leads to the slowdown in the progression of diabetes. Then we have a GLP-based data, and the results were excellent in GLP-based therapy. What the result says, in liraglutide arm, the 2% population only suffer from type 2 diabetes, where placebo 7%. So practically, conversion from pre-diabetes to diabetes has been reduced by 66 to 67%. And in semaglutide, we have step data in which also the development of type 2 diabetes has been reduced by almost 66%. It is actually a calculated one, but 66% practically. So we have another data from Swedish obesity registry. So look at the number of people, 71,495 patients, out of which 23,000 patients undergone gastric bypass surgery and 32 they have not opted for gastric bypass surgery. Those patients who opted for gastric bypass surgery, they had 85% lower risk of diabetes as compared to patients who have not opted for bariatric surgery. So almost 85% relative risk reduction in development of diabetes if obese patient underwent bariatric surgery. Then there is another study by Dr. DiFronzo as well as Dr. Amato regarding known as a stop diabetes. So they have directly mentioned stop diabetes, in which they have enrolled patient on triple combination, double combination, and lifestyle modification. Triple combination such as GLP-1 receptor agonist, pioglitazone and metformin combination, double pioglitazone and metformin, and lifestyle modification. So they have compared, and this study lasts for 32 months. Look at the hazard ratio. Those patients who were put on metformin plus pioglitazone combination, the hazard ratio is just 0.29, and those patients who were put on metformin, pioglitazone, and GLP receptor agonist, the hazard ratio is 0.12, means practically 99% risk reduction in progression of type 2 diabetes from once the patient before the diagnosis of pre-diabetes only. So yes, it's very important to preserve that beta cell mass, prevent the progression of continuous beta cell loss. That is very, very important. And if you look at the another data in which it has been clearly, you can clearly make out from data, those patients with normal glucose tolerance, impaired fasting glucose, and type 2 diabetes, the beta cell volume is reduced significantly. So type 2 diabetes, there is beta cell volume is very low. So before diagnosis of type 2 diabetes, if the patient is in early stages, that is either pre-diabetes, either IFG or in such condition, we should implement certain things, pharmacotherapy, then it will work very nicely. So let's talk about different thing, that is seat belt. If someone is using seat belt, then the reduction in fatal injuries there are by 45%, as well as critical injuries by 50%. If someone is using helmet, then the death can be reduced by 69%, head injuries can be reduced by 69%, and death can be prevented in the tune of 42%. So yes, it's time where we should use pharmacotherapy while prevention of in certain patient. So which class of patient we should consider pharmacotherapy? Particularly, yes, a young individual with type 2 diabetes, with family history of type 2 diabetes, in which the progression is very fast, particularly a patient with history of gestational diabetes. If she is not losing weight, and definitely we should think of
Thank you so much, ma'am, for the wonderful talk and establishing that glucose monitoring is utmost important, especially in pregnancy. We have a next speaker.
We welcome Dr. Rutul Goklani from Ahmedabad, Chief Diabetologist and Managing Director, AMC Diabetes Care, the visiting consultant at IDF Ahmedabad. I think so lots of mid-pens, feathers in his name. So I hand over to you.
Thank you very much, Dr. Mahindra Patel, sir, for kind introduction. And I am today a 12th man, a wildcard entry instead of Dr. Mayura Kale. So the topic assigned to me is hyperglycemia in pregnancy, what is new. Already Dr. Alpna Sawani has explained so many things regarding CGM in pregnancy, what are the benefits of CGM in pregnancy. So I'll skip that part as already we are running late, but still I'll be taking few of the important points, and thank you very much Dr. Manoj Chawla sir and Purvi ma'am and Bansi sir for inviting me and giving me the chance to be here on such a wonderful platform. So first of all, we need to understand this concept of hyperglycemia in pregnancy, any kind of diabetes in pregnancy or gestational diabetes. This comes under hyperglycemia in pregnancy. So it is an umbrella term. So ideally we should write in our diagnosis, in our prescription, hyperglycemia in pregnancy or diabetes in pregnancy or gestational diabetes in pregnancy, and not only GDM. So that we need to practice first, and for that, if any pregnant woman who is knowing that she has type 1 or type 2 diabetes or even pre-diabetes, then it falls into category of diabetes in pregnancy. If any woman who has who is diagnosed during pregnancy for the first time and who has HbA1c more than 7%, then we even that lady comes under diabetes in pregnancy. So any type 1, type 2 before or after diagnosed during pregnancy, it is diabetes in pregnancy. But gestational diabetes or pure gestational diabetes, it comes when it is diagnosed during 24 to 28 weeks during pregnancy. There is definitely a concept of early gestational diabetes now, but mostly pure gestational diabetes is we call gestational diabetes. So for screening, definitely the international guidelines are different than our Indian guidelines, our Indian government guidelines, which is adopted from DIPSI. And as DIPSI suggests that it should be universal screening, also not only universal screening, but antenatal screening, prenatal screening, and even in the first trimester, you should screen women with pregnancy. So why this concept is there? Because as we all know, Indians are at high risk population for gestational diabetes, developing gestational diabetes. So this universal screening is there for us. So I'm not going too much into detail as already I've explained. So what are the benefits of DIPSI recommendation? Again, we have gone through this slide again and again, and Dr. Bhavtarini ma'am is sitting here, and we are going to have some separate session on DIPSI criteria and benefits as well. So I'm skipping this, but the target blood sugar level for pregnant women that we need to understand. So for pre-existing diabetes, there are few people who believe that post-meal blood sugar could be up to 140, especially in type 1 CGM during pregnancy. So for type 1 diabetes, target is definitely the same, but we want it more than 70%, whereas in the pregnant women with type 2 diabetes or gestational diabetes, we want target between 63 to 140, but more than 90% or even 94%. They don't have, is not updated for type 2, is not updated for type 2 and gestational diabetes. As you can see here, they have not written percentage. So even right now, we don't have clear-cut guideline how much we want more than 90 or 95%. So continuous glucose monitoring derived glycemic metrics and adverse pregnancy outcome among women with gestational diabetes, a prospective cohort study, and it has suggested this derivatives are more useful than alone SMBG, and what they have explained that time in range, time above range, area under curve, or mean blood glucose daytime or daily mean amplitude of glucose excursions were positively associated, while time below range was inversely associated with the risk of large for gestational age. So this data gives us more clarity than self-monitoring alone. So monitoring should be beyond SMBG, and we should use continuous glucose monitoring as much as possible in women with pregnancy. Automated insulin delivery in women with pregnancy complicated by type 1 diabetes. So this is one of the landmark study where 124 pregnant women were studied in comparison to standard of care or basal bolus therapy. So this study suggested that insulin pump is quite superior than basal bolus therapy in pregnant women, and it has better time in range, as Dr. Alpna Sovani also showed this concept trial where in comparison to CGM plus insulin pump were 68%, and in non-CGM women it was 56%, so almost 10% improvement in total TIR. Hybrid closed loop system in pregnancy, where if we see overview of hybrid closed loop pump system or CAM, artificial pancreas FX system details, 10.5% more time in range with a CAM APS system. Reduction in hyperglycemia and gestational weight gain is also there. So less gestational weight gain, around 4 kilogram overall, 10.2% less time in hyperglycemia, 12.3% more time in overnight glucose control, and reduction in nocturnal hypoglycemia with that. So in 2024, Norbert Frankel Award lecture in ADA was about insulin pump in comparison to CGM alone, where pump plus CGM had showed better result and almost 10% more time in range. Another concept is Tobo GM study, where whether we should treat early GDM or not. So in this Tobo CGM study, Dr. Siemens et al. From Australia, what they suggested, there is not a much benefit in treating early GDM. So the women who were diagnosed before 20 weeks of pure GDM, so they don't have HbA1c more than 7%, then you don't need to treat it aggressively. Definitely we should ask them to follow lifestyle modification or maybe metformin in few of the cases with PCOD or such, but we should not be very aggressive, as there is a very moderate kind of benefit in treating early gestational diabetes. So Dr. V. Mohan sir was also part of this study, and he talks about this study a lot. So another thing new in pregnancy is basal insulin during pregnancy, as we are seeing more and more cases of pre-existing diabetes as conceiving age is increasing. So we need basal insulinization more in diabetes with pregnancy, and for that CDSCO has already approved Tresiba or Degludec in 2021. We have multiple real-world studies and data for Glargine or even Glargine U300, our own study. We have done one study, real-world study of Glargine U300. We are going to publish it in IJDDC soon. So which insulin can be used? This is the recent thing. Only insulin glulisin doesn't have data for diabetes in pregnancy. Otherwise, we have all the insulins which are almost approved except Glargine, which doesn't have RCTs, but we have enough data for approval. So GDM is a window of opportunity, and for that I would really mention every time Dr. V. Seshia sir, who is father of gestational diabetes and he is guru of all of us for gestational diabetes, he says that pregnancy offers a window of opportunity to provide maternal care services. It reduces traditional maternal and perinatal morbidity and mortality indicators, and it addresses intergenerational prevention of NCD such as diabetes, hypertension, cardiovascular disease and stroke. And for that, he has a newer concept of primordial prevention through gestational diabetes screening, and this is quite a different thing than what we think. So during 8 to 10 weeks in first trimester during pregnancy, we screen the woman with postprandial blood sugar. If it is more than 110 during first trimester and between 8 to 10 weeks, it is more than 110, then this woman has higher chances of getting gestational diabetes. And even he is going beyond, and he has proved this thing, and he advised to give metformin, and already the prospective study has been done, and it showed the better results. So the women who were given metformin, who had more than 110, and the women who had more than 110 and women who were not given metformin, the better results with metformin given women. So with this, I'll conclude with this talk, the newer concept, and I invite you all to Pregnancy Study Group India conference in Surat on 29 and 30 of November of this year. With this, I'll conclude, and if you have any question, I would like to address.
Thank you so much, Dr. Rutul, on shedding some light on this little complicated management of hyperglycemia and pregnancy, but not so complicated after you explained us.
Thank you, thank you.
And I think since we're running short of time, we'll first felicitate you all. And I'll invite all the speakers of this session, please. Dr. Alpna ma'am and others. Dr. Kale.
Dr. Kale.
Yeah.
Up to Kalyan onwards, it will launch at Dombivli, Hani, Mulund, at Kopat, Kurla, Dadar, Haikala stations.
Mumbai Central, Surat, Kichang वेळे 17:55 मिनिटांनी प्लॅटफॉर्म क्रमांक 3 वरून जाईल. कृपया ध्यान दीजिए 1292 मुंबई सेंट्रल सूरत अपनी निर्धारित समय 5:55.
Thank you for insightful session. Now moving forward to last session of day 1, Diabetes and Beyond 2. To chair this session, would like to call upon Dr. Manilka from Sri Lanka and Dr. Rakesh from Jaipur.
Just another announcement, the Lily Dinner Symposium will be shifting from Bombay Chowpatty to Bombay Central. So after this session, we'll have the other last session in this hall while that room gets going for the evening arrangement. So this hall continues to remain premium.
Good evening, everybody. Welcome to the last symposium of the day. Although it's the last one, but I think it's not the least important. It's lots of couple of very interesting topics to be discussed, diabetes and beyond. And the first speaker is going to be Dr. A.G. Unikrishnan, a well-known figure to all of you, and he'll be talking about topic is. So let me introduce him first. He has a MD and DM in endocrinology, and all his documents are given on the screen, and now he's working editor-in-chief of the Journal of Chronicle of Diabetes Research and Practice, and he has been a principal investigator in several international multi-center studies, and he'll be talking to us on SGLT2 inhibitor combinations, focus on empagliflozin and the liver alpha cell axis. Something new for all of us, I think. Over to you, Uni.
Thank you very much for the kind introduction. It's a pleasure to be here, and I'm going to talk about empagliflozin with something different called the LACA, or the liver alpha cell axis. So we know that SGLT2, DPP4, metformins have been there for years and years. So please raise your hands if you have used all the three together in a patient. I think it will be easier to ask who has not used it together. So all of us have used it together. And if you see, this is a very common concept in Western countries. You have a common, which is a common area where people use all the facilities commonly. And then, this is a very old concept. It is there in today's societies also. And there are individual families living around the common, which have got some individuality, but they use the common facilities. So similarly, if you look at SGLT2, DPP4, and metformin, there are some features common to all of them. Let me try to get the pointer, sorry. There are some features common to all of them, and those features are, they're all weight friendly, they don't have hypoglycemia, they have good A1C control. Then there are some features unique to SGLT2. They cause weight loss, they have cardiorenal benefits, they cause urogenital infections, they cause ketosis. There are some features common to DPP4, mainly good glucose control, and of course avoiding pancreatitis risk. There are some good features of metformin. It's got good glucose control, no hypoglycemia, but GI intolerance and B12 deficiency. But if you look at glucagon, and that people don't look at glucagon always, all three have very different actions on glucagon. SGLT2 increases glucagon. Metformin, there are studies which show that it may raise or decrease glucagon. And DPP4 will lower glucagon. And why are we talking about glucagon? Now this is a picture, sorry I generated this, Jerry are playing, and Tom is glucagon and Jerry is insulin. And if you look at Tom and Jerry cartoons, always Tom gets a bad name, Tom always loses. But Tom wasn't always bad. Tom got a bad name very early on. And this is a picture of Tom on his first day in school. On the first day itself, the teacher got a bad impression. What happened? That whole year is gone. Similarly, glucagon was actually described as a villain. So glucagon had a very inauspicious start. It was discovered as an impurity in early preparations of insulin, and it was called a toxic fraction, causing a rise in blood glucose levels and even death. Then in 1973, Robert Unger and Leloard, they sort of hypothesized that diabetes is due to two diseases. One is insulin lack and glucagon excess. But glucagon kept on getting a bad name. Now glucagon is a 29 amino acid peptide produced by the alpha cells, and it depends on where glucagon, the precursor is. Some precursors convert into GLP-1, some convert it into glucagon. Now it's important that we don't know even today whether it is glucagon or insulin which keeps the blood glucose levels in check. But one thing is for sure, when there is low blood glucose levels, the body releases more glucagon. And when there is high blood glucose levels, the body releases more insulin. And within 80 to 100, we really don't know, but many people believe that within the normal range, keeping the glucose in check, glucagon has an important role to play. So let's look at this picture. On your left, you have glucagon agonism. What does glucagon do to the body? Very interestingly, if you just look at weight, glucagon causes weight loss. It destroys amino acids, it destroys lipids, it makes ketones, and it causes beta oxidation, destroys fat. And it also increases brown fat related energy expenditure by increasing brown fat. It can also act on the brain, but the main thing is it acts on the liver, causes lipid beta oxidation, and it destroys fat. The other corollary of that is that if you antagonize glucagon, if you become an enemy of the glucagon, it may control the sugar, but it is going to increase the liver fat. So that brings us to the liver alpha cell axis, because you have liver and you have the alpha cell making glucagon, or the LACA, which is a very important concept to understand, because it also is one of the theories to explain why you have type 2 diabetes and MASLD. So let's look at metformin. Metformin, by bringing down the fasting glucose, it can increase glucagon, and that's why people on metformin don't get hypoglycemia. Metformin can also counteract the catabolic effect of glucagon, and metformin therefore can also induce glucagon secretion to some extent. So metformin has a very complex effect, but largely it allows glucagon to come in when there is hypoglycemia and therefore increases it. DPP-4s reduce postprandial glucagon, but remember, they actually act like a software for the beta cell and alpha cell. When the sugar is low, they can increase glucagon. When the sugar is high, they can suppress it. But overall, when the sugar is high, like after a meal, they suppress it. What is very interesting is SGLT2. Now, SGLT2 has two effects by which it increases glucagon. One is the indirect effect by causing glycosuria, it stimulates glucagon, and second is a direct effect. The direct effect of inhibition on SGLT2 on pancreatic alpha cells. The other thing is, if you remember, that now there are SGLT2 receptors on the alpha cell. And if you block them, what happens? If you block an SGLT2 receptor on the alpha cells, whenever there is, say, hyperglycemia outside, because of the blockade, the alpha cell cannot sense glucose. So the alpha cells think there is hypoglycemia. So therefore, it can make glucagon, because you are blocking the SGLT2 within the alpha cell. Now this brings us to the very interesting liver alpha cell axis. According to this axis theory is that the liver, there are a lot of amino acids, and the amino acids act on the pancreas, the alpha cells, to make glucagon, and glucagon dissipates the amino acids and the cycle is complete. But what if the amino acid pathway is blocked? Only the amino acid pathway, which means that because the amino acids are not destroyed, there are lots and lots of these amino acids. Here there are less amino acids. Here there are lots and lots of these amino acids. They keep on stimulating glucagon. This glucagon keeps on releasing glucose, but the body can't stop making glucagon because the amino acid pathway is actually blocked. It also leads to fatty liver, because the fatty liver, glucagon cannot act to destroy the fat also. So it also causes fatty liver. So you have amino acids not destroyed, you have the glucose production by the liver continuous, and you have fatty liver because the glucagon fatty acid pathway is also blocked. So that is a theory of the liver alpha cell axis, or LACA. If you look at it, none of these agents, DPP-4 can reduce glucagon, metformin can increase glucagon, but metformin has a GLP-1-like effect, so it actually eventually brings it down. But the only drug that can favorably harness glucagon for the benefit of the liver is SGLT2. How does it do that? Number one, it reduces the glucose load. Second, it increases the glucagon level and that dissipates the liver fat. Why are we talking about all this? And of course, none of these cause hypoglycemia. And there is this paper, we are talking about this because recently, as maybe a week ago, the US FDA has approved injection semaglutide 2.4 for the treatment of fatty liver disease. And if you look at MASLD as a disease, and if you look at which is the other anti-diabetes drug that can help semaglutide, the answer is only empagliflozin or dapagliflozin or whichever gliflozin you want to. But empagliflozin, what is fascinating is there is an Indian study from Medanta Hospital. It is called the E-LIFT trial. It is the only Indian study which was done and which showed that in people with diabetes, it can reduce, empagliflozin can reduce the liver fat and improve the ALT levels in Indian people with type 2 diabetes and MASLD, and they did MRIs and they showed that. So in other words, empagliflozin, by throwing out glucose through the urine, reduces the overall glucose levels in the body. So when there is reduced glucose, the glucose is not converted by the liver into fat by de novo lipogenesis, and whatever fat is available in the liver, that is dissipated by the action of hyperglucagonism due to SGLT2. And that is how a drug like empagliflozin, or for that matter dapagliflozin, or for that matter canagliflozin, can all reduce liver fat and can be a useful adjunct in type 2 diabetes and mast cell. And it's very important that this role of empagliflozin and glucagon is recognized as a therapeutic benefit in today's world. Because you are going to have survodutide. You know, survodutide is about to be the next to be probably approved by the US FDA. It's not been approved yet, but it's one of the most promising agents for treatment of fatty liver disease because it also targets glucagon. It's a glucagon agonist. Retatrutide is another drug which is a GLP, GIP and glucagon agonist. So glucagon agonism is going to be harnessed for obesity, for type 2 diabetes paradoxically, and for mast cells. So understanding a molecule that can use glucagon in the right way is important. And why are we bothered about cardiovascular outcome in mast cells? It's important to remember that people with mast cells may progress to MASH, they may progress to cirrhosis, they may progress to hepatocellular carcinoma, but the most common cause of death in patients with mast cells is cardiovascular disease and cardiovascular death. And among all the SGLT2s, whether you take dapagliflozin, empagliflozin, canagliflozin, only one agent has been shown to reduce cardiovascular death. There are many agents which may reduce MACE, 3-point MACE, that's a different matter. But a statistically significant hierarchical testing proved reduction in cardiovascular death. To date, only empagliflozin in the EMPA-REG trial has been shown to reduce cardiovascular death, and that's because of its hemodynamic effect, such as reduction in plasma volume and the direct effects on the heart. So before I show you the take-home points, I want to talk about all of you to rethink glucagon. Glucagon has been an enemy. It's not a friend. It is a partner, a strategic partner to be used in the right way in a multilateral world, which is the world of the body. I'm sure you know what I'm talking about. You have the pancreas, you have the heart, you have the liver, and it's a very multilateral world. And glucagon, used the right way, can actually be of therapeutic benefit. So friends, there is good rationale for the SGLT2, DPP4 and metformin combination. But among them, the SGLT2 stands out. Yesterday or day before, the UK regulatory authority, NICE, has actually approved SGLT2 as a first line for management of type 2 diabetes, and they said metformin is not the first line. SGLT2, especially in cardiovascular disease with diabetes and in chronic heart failure, today SGLT2 is a first line therapy according to the UK regulator, and I think we need to stand up and take notice. The glucose control, weight benefits and cardiorenal protection has to be looked at, and you can look at, if you look at the 3-drug combination, is a pretty good way to get all the benefits. And if you see, if you use it early as a single tablet, not much titration is needed. Patient's initial HbA1c is 8.5, you give a triple drug combination, the value stays down. So friends, glucagon is like Tom and insulin is like Jerry, but if you think of both of them as the two hormones playing on the landscape of the pancreas, you now remember, we'll have to reimagine glucagon as a new player, a beneficial player, may reduce NAFLD, may cause weight loss, and if used rightly, can be harnessed for betterment of care of patients in future. Thank you for listening to me. It's a pleasure talking to you. We can take questions now. I think maybe 4 minutes are left, so if there are any.
Yeah, thank you, Dr. Unni. It was an excellent presentation and a new one. We learned so many new things from this presentation. Can you take the questions at the end of the session?
It's up to you. I mean, whatever you decide.
Yeah, because we're running late, so we'll see how
No
the
problem.
other sessions go. Thank you, sir. Thank you. Now I invite Dr. Brij Mohan for the next session, a very senior diabetologist physician from India, and he is an active member of various national and international bodies like ADA, ESD, AAC, API, RSSDI, and so on. He's also been past president of UP Diabetes Association, past vice chair of UP chapter of RSSDI. He has been organizing chair of National RSDI Conference 2015, and he has been honored with Lifetime Achievement Award by UP Diabetes Association. Dr. Brij Mohan will be speaking on diabetes in elderly. Over to
Thank
sir.
you, Mr. Chairperson, for nice words of introduction. And thank you, Manoj and Purvi, for inviting me to this DRS meeting. Topic for today's discussion is diabetes in elderly. I understand that it is too late in the evening, but still the study must go on. What we need to know that diabetes is highly prevalent health condition in elderly population. Over 29% of people over the age of 65 years, that is the age for elderly, are suffering from diabetes, and one half, that makes it another 50%, that makes it 80% are suffering from diabetes or pre-diabetes, and number is expected to increase in coming decades. It may be type 2 diabetes in elderly, or type 1 of childhood, or adult onset of type 1 diabetes may be seen in elderly population. It's a functional diabetes in elderly do have functional disability. They have cognitive impairment. There is sarcopenia and or accelerated muscle loss with so many reasons behind it. There may be mobility impairment and frailty. Other than this, diabetes in elderly may have comorbidities like hypertension and CKD, CAD, stroke, and premature death in elderly population with diabetes is very common. We need to understand that we don't need the diabetes treatment only in this elderly population. That must include psychological aspects, that must include functional aspect, that is the self-management abilities, and the social aspect of diabetes in elderly. While assessing elderly diabetic, it is important to know the type of diabetes, what is the duration of diabetes, that is very, very important, and presence of complications. What complications or target organ damage is already existing in this elderly population, and we know that hypoglycemia fear can be there. Screening for complications in elderly should be individualized and periodically revisited, depending upon various reasons for it. Now, recently, ADA 2025 has said 4M framework for elderly diabetes population, that includes mentation, medication, mobility, and what matters most for elderly diabetic. Elderly diabetes, we need to impart self-management training that may include family members or the person himself or the caregivers are important. Essential points to keep in mind are hypoglycemia, neurocognitive dysfunction, various geriatric syndrome, which I will enumerate just now, benefits of medical nutrition therapy and physical activity are still there in elderly population, and medication review on time may be earlier than what we do in younger population, and evaluation of complications like cardiac, renal, neuropathy, or foot complications. Various geriatric syndromes associated in elderly with diabetes that affect treatment and quality of life may be polypharmacy, frailty, injuries can lead to fall, the fall can lead to injuries, the fractures can be there, disability and or persistent pain may be there, urinary incontinence in elderly population, whether it is male or female, is quite common. Type 2 diabetes is very common, as I said. Cardiovascular disease, cognitive decline, and depression because of various social and cultural issues may be found in elderly with diabetes. What are the general principles of therapy? Elderly are at increased risk of hypoglycemia, so we must use medication with lower risk of hypoglycemia, which is preferred. I don't say that don't use drugs which cause hypoglycemia, but preferred drugs are those with less common hypoglycemia. Overtreatment should be avoided. De-intensification or simplification should be done. Cost of care should be taken care. And two important issues in elderly with diabetes are neurocognitive dysfunction and hypoglycemia risk. And we know that elderly with diabetes are at increased risk of cognitive decline. Identifying cognitive impairment, it may be minor, that is important. Impairment may range from subtle dysfunctions to memory loss to dementia. Diabetics have higher incidence of all cases of all causes of dementia. It may be Alzheimer's, vascular dementia, then non-diabetic counterparts. Poor glycemic control leads to it. Longer duration of diabetes leads to neurocognitive dysfunction. Challenges for clinician may be increased with cognitive impairment. Cognitive dysfunction may make it difficult to perform glucose monitoring and adjusting insulin dose. That is very, very important. It also hinders to maintain timing of meal and content of diet. It is important to simplify drug regimen and engage in various support structures. Screening for early detection of mild cognitive impairment is very, very important, and the level of evidence is B. And hypoglycemia, there is increased risk of hypoglycemia because of various reasons, including insulin deficiency, which leads to insulin therapy, and progressive renal insufficiency in elderly population. Elderly population may have unidentified cognitive impairment. Glucose monitoring and insulin dosage may be forgotten by elderly population, elderly diabetic. Severe hypoglycemia leads to increased risk of dementia because of several reasons. To mitigate hypoglycemia risk is to see whether the patient is skipping meals or inadvertently repeating doses of medications. And it is very important that type 1 diabetic in elderly population, CGM should be done to reduce the possibility of hypoglycemia, and the level of evidence is A. Now coming to treatment goals for healthy elderly population with diabetes, These are the various things that we should look for in elderly diabetic population, healthy with longer life expectancy, but elderly. The A1C should be between 7 to 7.5, maybe less than 7. Time in range, 70%, TBR, less than 4%. Fasting or preprandial glucose should be between 80 to 30, 80 to 180 is bedtime glucose, and blood pressure is less than 130 by 80. And statin should be used unless contraindicated, and that is intermediate elderly with diabetes. Intermediate means variable life expectancy and individual preferences of family members or elderly population. The A1C goal should be less than 8. TIR, TBR, fasting, bedtime glucose, and blood pressure are mentioned there. Statin are important unless they are contraindicated or not tolerated. For poor health, elderly diabetic, poor life expectancy, avoid reliance on A1C. CGM should be avoided, reliance should not be there. Fasting or preprandial glucose should be between 100 and 180, bedtime between 140 to 200, and blood pressure less than 140 to 90, and consider risk-benefit ratio with statin use. Now coming to drug therapy for elderly diabetic, obviously metformin is the first line agent because of various reasons, but we must understand that it is contraindicated in patients, elderly patients with renal insufficiency, especially it is EGFR more than 30 should be there to start metformin. Metformin should be used with caution in patients with impaired hepatic function, heart failure because of risk of lactic acidosis. It should be temporarily discontinued before procedures. During hospitalization, metformin can cause GI side effects, reduce appetite, reduction of or elimination of metformin may be necessary for patients experiencing persistent GI side effects. Elderly taking metformin should be monitored for B12 deficiency. DPP-4 are clearly not causing hypoglycemia. They should be used as second-line agent. Insulin secretagogue may be used in selected cases. SU with shorter duration of action, such as glipizide, are preferred. TZDs should be used very cautiously in elderly patients, especially those who are already on insulin therapy because of various risk of heart failure, osteoporosis, falls or fracture, or bacular edema. SGLT2 inhibitors are useful, as Unni has already told you. They are oral, convenient for elderly population, established risk of ASCVD or at risk of ASCVD, heart failure and CKD. These drugs have shown benefit, and analysis of various trials done with SGLT2 inhibitor show that older patients may have similar or even greater benefit than younger population. Side effects are many and they should be looked after. GLP-1RA, CV and renal benefits are there in elderly population also. Meta-analysis of GLP-1RA trials, these agents have been found to reduce major CV events, CV death, renal benefit, stroke, and MI in patients above 65 years of age. These are injectable agents with exception of oral semaglutide. Weekly dosing schedule should be utilized properly. It may reduce burden of administration, and GLP-1RA should be avoided if there is constipation, gastroparesis, recurrent ileus or bowel obstruction. This is a recent article on 16th of August 2025 in Journal of Nutrition, Aging and Health, which shows that sarcopenic obesity in elderly population may be problematic, especially if you stop GLP-1RA, highlighting the need for raising awareness and preventive strategies. We may use resistance exercises, increase protein intake, and that may improve muscle mass during weight loss. Insulin is used in all type 1 diabetics and those type 2 who are uncontrolled with in elderly type 2 diabetics who are uncontrolled on oral drugs. Good visual acuity and motor skills and cognitive ability is a must. Insulin therapy relies on, just 2 minutes more. Insulin therapy relies on ability of elderly to administer insulin on their own. Individualized glycemic targets should be used. Avoidance of hypo is very important. Once daily basal insulin of analog variety is reducing hypoglycemia. Long-acting analogs may be helpful in that. Multiple daily injections of insulin may be too complex in elderly with diabetes. Caregiver must apply approach to simplification of insulin regimen. So this is about simplification of complex insulin therapy in elderly population. Patient on basal or prandial, we must try to simplify it. Patient on premix, the goal should be individualized, and do not use rapid acting or short acting insulin in the evening. End of life care, this is the last slide. Strict glucose blood pressure control are not necessary in elderly with end of life care. Simplification, lipid management can be relaxed. Primary goal for diabetes management at the end of life care is overall comfort, prevention of distressing symptoms of diabetes, and preservation of quality of life. Thank you very much.
Thank you very much, sir. In the interest of time, I think we have to proceed for the next lecture, and it was a very comprehensive lecture in a very important topic, especially with the aging population in our part of the world. Now, it's my pleasure to introduce, I think he doesn't need any introduction in Mumbai, but it's my duty to introduce Dr. Manoj Chadha, a consultant endocrinologist at the PD Hinduja Hospital in Mumbai, and he has been a past president of the Endocrine Society of India and also a past president of the Indian Society for Bone Mineral Research in 2015-19 and many other accolades. It's my pleasure to invite him to speak on the current place of SGLT2 inhibitors and DPP4 inhibitor combination in the era of GLP-1 receptor agonism. Over to you.
Thank you. Thank you not only for introducing me, but sitting through the talk. And thank the audience in advance for being here at this late hour of the day. See, I think what I'm going to be discussing is not something new. You have all been exposed to this in the last maybe 10 years and more so in the last 3-4 years. I'm just going to give you a snapshot of what has really happened over the last 20-25 years in terms of how our focus from infectious disease, tuberculosis, cardiovascular disease has now become non-communicable disease, including cardiovascular disease, diabetes, cancer. So there has been a drastic change. We are all living longer. And in that process, we're seeing more complications of conditions like diabetes. I was a student of diabetes in the 80s. And I think in the last 40 years, we've had so many new medications, but whether our patients are doing better, I'm not saying whether they're living longer, but whether they're doing better. So let us look at two prototype patients, which you would be seeing in your practice quite regularly. So this is a 45-year-old young patient. Dr. Bridgemohan, for the record, 65 is middle age and not elderly. That's what WHO has said. So we are, at least I am still middle age. So diabetic for last 1 year, hypertensive since 7 years, dyslipidemia 10 years, family history of myocardial infarction, moderately active lifestyle, occasional smoking, the standard metformin, rosuvastatin, telmisartan on his treatment. BMI is 28, waist circumference is 102 centimeters, blood pressure is okay, ankle break-in index is a little on the lower side. So you can see from now that his A1C is 8.1%, insulin fasting is on the higher side. Lipids, you can see LDL is 92, so if you take 100 as the target, then he's below target, but if you take 70 as the cutoff, then he still needs some more aggressive management of his lipids. GFR is 80. Let us say for the sake of argument that the UACR is normal. On the other hand, if you take a 58-year-old patient who's got similar medical history but hypertensive for a longer period, dyslipidemia for 15 years, on metformin, atorvastatin, telmisartan, amlodipine, and hydrochlorothiazide. BMI 26, blood pressure 130/80, A1C 8.2%, lipids look reasonably good, but his GFR has now come to 46, creat is 1.7. So one of the take-home messages at this stage is do not rely on serum creatinine to decide where the patient stands. Simple formula, get the eGFR from your smartphone, and then talk to the patient whether they're in stage 1, 2, 3, 4. So the albumin creatinine ratio is 180, which is something we recommend that you should do it at least once in a year. Treadmill test positive, echo shows grade 2 diastolic dysfunction. So we've heard this time and again that when you're looking at type 2 diabetes with declining renal function, it's not the renal function which will kill them, it's the cardiovascular disease that you're really worried about. The ADA, EASD, IDF, RSSDI all have stressed on the fact that along with control of hyperglycemia in patients who are having underlying heart disease, ASCVD, heart failure, or a declining renal function, you have to use SGLT2 inhibitors and or GLP-1 receptor agonists. There's absolutely no doubt about it. And anyone who's not following these guidances, even if you don't look at it as guidelines, is doing a great injustice to their patients and to their practice. So this is one important point. And we could have been discussing this 3 years earlier, but today there is absolutely no two views about it. We are all familiar with the octet, and we have gone on to the dirty dozen various factors which keep causing type 2 diabetes. The reason I've shown you this slide here is to tell you that one single drug, whether we are talking of orals, we are talking of insulin, we are talking GLP-1 receptor agonists,
is very difficult to control because type 2 diabetes by itself is a progressive disorder. So when we think about therapy, you could go 1, 2, 3, 4, or you could at least go 2, if not 3 at the beginning. And the focus of my talk is going to be on EMPA and LINA combination. So EMPA, I think those who heard Dr. Unni, he's very vividly described the good points of empagliflozin in terms of glycemic control, then the hepatic fat that he was talking about, reduction in MACE, one of the only drugs which has actually shown reduction in CV death. Two people could argue whether the patient is in failure or not, but there is no argument on whether the patient is alive or dead. So empagliflozin has shown reduction in CV death. And then when it comes to heart failure, I think as a class effect, all SGLT2 inhibitors reduce the hospitalization for heart failure. And you're all aware that it's an important pillar of management of heart failure, whether it is reduced ejection fraction, minimally reduced ejection fraction, or preserved ejection fraction. Probably the only class of drugs which works with HFpEF is SGLT2 inhibitors. And in addition, when it comes to kidney production, the nephrologists initially had their doubts, but they're excited about how SGLT2 inhibitors help protect the kidney and those who have a declining function to prevent the further decline, and there is enough data to even show that it can reverse the declining kidney function. Linagliptin came late on the stage, but it got labeled as a kidney-friendly DPP-4 inhibitor, and over the years has shown that it's about as good or as potent as the other DPP-4 inhibitors. The beauty about DPP-4 inhibitors as a class is they may not be as strong as sulfonylurea or as cardioprotective as the SGLT2 inhibitors. But as like one of my friends used to say in the beginning, that you can prescribe a DPP-4 inhibitor over the telephone and you don't have to have the patient sitting in front of you and giving you a whole list of do's and don'ts. So when you combine empagliflozin and linagliptin, you can see that it takes care of nearly all the defects that were shown in the earlier ominous octet, and that gives it a couple of brownie points. Multiple studies have looked at the outcomes, whether you're looking at EMPA-LINA 10/5, EMPA-LINA 25/5, EMPA alone 10, 25, and LINA 5. And the fact remains that whether you're taking the combination 10/5 or 25/5, they have better outcomes and a stable A1C over at least, this is 52 weeks, but this goes on to 104 weeks also. We have now started talking not only of A1Cs, but we're also talking of time in range. And as you can see in this study, from placebo to empagliflozin 10 milligrams, 25 milligrams, the time in range improves, and it starts from day 1, and by day 28, 4 weeks, there's a big difference. I remember years ago we used to say aggressive management, intensive control, and the bottom line used to be risk of hypoglycemia and risk of weight gain. So we know that empagliflozin and DPP-4 inhibitors run a less risk of getting hypoglycemic in a patient. And the beauty is that there is some amount of weight loss against weight gain which you would see when the patient is well controlled. So it may not look big as compared to the GLP-1 receptor agonists that we keep hearing about, but a 4, 5, 6% weight gain over the period of few weeks is significant. Dr. Unni did speak about the ELIFT study from Delhi, and one of the short, sweet, successful studies of reversing fatty liver in our type 2 diabetic patients. Do I really need to talk more about EMPA-REG? I'm sure, and I see some of my seniors who would like to see me off the stage fast, but give me another 5-7 minutes and I'll be done. So, like I said, one of the first CV outcome which didn't talk about non-inferiority or just being equal to placebo. They actually were superior to placebo. And as I said, the first studies where they showed that there was reduction of CV death in addition to reduction of 3-point MACE. And the subgroup of the Asian patients, if you can see, as compared to 38% reduction with the total population. With the Asian population, it was about 56% relative risk reduction. So major adverse events, cardiac vascular, myocardial infarction, coronary revascularization significantly reduced as a part of the EMPA-REG outcome. And although not a direct primary event, but the worsening of nephropathy was slowed down, progression to macroalbuminuria was slowed down, the doubling of serum creatinine and the risk of renal death was significantly slowed down. In addition, those patients who already had developed nephropathy, you can see that at least 43% reversal of microalbuminuria into normal albuminuria and macro into micro, 82% risk reduction. So that was something in the beginning, which now has been confirmed by multiple other studies. In addition, the fringe benefits, you can say, or value-added benefits with empagliflozin was improvement in hemoglobin levels. We now know the importance of treating hemoglobin even in cardiac failure, not general health, but with cardiac failure. And there was some amount of reduction in uric acid. So as I mentioned with EMPA-REG, that was not the primary focus, but in EMPA-Kidney, the primary focus was looking at what happened to the kidney disease. So these patients, again, 45% risk reduction in progression to CKD, 44% risk reduction in terms of reversal of the disease. So that gave the confidence not only to cardiologists and now nephrologists, and this use of empagliflozin has progressed from diabetic patients to non-diabetic patients. A real-world study from insurance data, 145,000 odd patients, as compared to the use of GLP-1 receptor agonist. The use of SGLT2 inhibitors and specifically empagliflozin reduced the risk of myocardial infarction and stroke to the same extent as seen with GLP-1 receptor agonists. But when you look at CV death, hospitalization for heart failure and end-stage kidney disease, there was a slight benefit in favor of empagliflozin. Just a couple of slides, not to be unfair to linagliptin. You know what happened with the saxatimine. We started off on the wrong foot and we got worried about increased risk of hospitalization for heart failure. Poor saxagliptin never came out of it, although real-world studies showed that it was not true. But with Examine, TCOS, and then Carmelina, the issue about heart toxicity or issues of heart failure were set to rest. These drugs have been shown to be neutral in terms of 3-point MACE reduction, and leave aside that little mark on saxagliptin, everything else seems to be quite normal. And Carmelina sort of again sealed the point in favor of linagliptin when it came to the renal dysfunction, when it came to progression to micro and macroalbuminuria. And the most important thing, as you see at the bottom, is albuminuria reversal, which was seen with linagliptin. So I'm going to conclude my talk by telling you that diabetes is a complex metabolic disorder. It's got a progressive nature. Multiple defects have been described in the pathogenesis of type 2 diabetes, and you do not expect one single drug to take care of all these pathogenetic defects. So combination therapy is here to stay, whether you use dual or triple combination. Linagliptin with empagliflozin is a wonderful combination in terms of efficacy, in terms of safety, and as the various guidelines, guidances tell us, in the presence of ASCVD, in the presence of heart failure, and in the presence of declining renal function, SGLT2 inhibitors without GLP-1 receptor agonists are here to stay. Thank you very much for your patient hearing.
Thank you very much, Dr. Manoj. I think speakers have done well to save little time. We have 4-5 minutes left. Let me invite all three speakers to the podium, and if the audience has any questions, very interesting lectures, 3 lectures, you are free to come to a microphone and ask the question.
Till the time any question comes, I have a question for Dr. Unni Krishnan. It was an interesting talk and something new that we learned. So I believe glucagon also has some differential role on the weight at different doses. Can you throw some light on that? Like glucagon acts differently at different doses when given. I think there are some studies which that show that.
Not aware of any studies, but you can please clarify.
I just heard in some conference that glucagon, which is being used as a combination with GLP and GIP, there are drugs. I don't have much of details on that, but I think it's got some differential
Sure.
roles. Yeah.
So I think what these drugs do, these are unimolecular drugs acting at multi-targets. So these are biased to have a particular level of action on glucagon, particular level of action on GLP-1, particular level of action of GIP-1. For example, we know that glucagon causes hyperglycemia, but the positive action on GLP-1 and GIP will overcome that hyperglycemia and retatrutide. Similarly, we know that GIP to some extent affects the white adipose tissue, but the effect of GLP-1 and glucagon will increase the fat loss and counteract that. So that sort of post-receptor kind of targeting happens.
I think what you mentioned was the glucagon has dual action at different levels of glycemia.
Yeah, I think I mentioned that at lower levels of glucose, it is glucagon that keeps up the sugar. At higher levels of glucose, it is insulin that brings it down. Between 80 to 110, we really don't know, but it seems now that glucagon has an important action to play in keeping it there.
I think it's very interesting, a lot of new stuff. Please come to the microphone, sir.
Just one question. This is regarding the cost of glucagon. I think glucagon is very costly, isn't it? And what is the cost of the overall molecule?
No, my talk was on glucagon agonism as a tool for managing diabetes, not on glucagon injections. Glucagon injections are costly, and glucagon injections are available but are very costly. And you have a rapidly acting glucagon called dasiglucagon, which is now available in many countries. But glucagon injections causing preventing hypoglycemia, that was not the focus of my talk. It was how drugs can be used to harness the liver alpha cell axis of glucagon. But I take your point, sir, that glucagon injections are costly and difficult to get, and that it can be a valuable tool for managing hypoglycemia.
And what could be the cost? Any idea?
So it's not available in, yeah, you can answer.
I agree.
1,000 rupees. But and it expires also, 1 mg.
So at what stage would you recommend?
No. We don't use it routinely, sir. In some countries where people are on with type 1 diabetes on basal bolus therapy or on pumps, they carry glucagon with them when they are prone for hypoglycemia. You can inject. Otherwise, as a routine drug, it has no role to play.
But there is a recent pump, a smart pump, which is supposed to have dual injection.
Yes. You have something called a bionic pancreas. A bionic pancreas is like a artificial pump which gives insulin if the sugar is high and gives glucagon if the sugar is low. But that is by only experimental, and in research, that pump has not yet been approved for clinical use.
I thought it was approved in
No, it is not used. It's not been approved as yet. It is not available for clinical use, but yes, trials are going on, and even there are randomized trials published on that, but it has not been approved by FDA.
Thank you.
Thank you very much, Uni. Let me ask Dr. Mohan a very relevant question in the new era of all this new medication. Our part of the world still uses lots of sulfonylureas. What is your experience in the elderly, especially the rate of hypoglycemia in elderly population in India?
Longer acting sulfonylurea is a big no in elderly population. There is no doubt about it. It is better to use shorter acting version, maybe glipizide or even glyclazide, which is not modified release. That can be used in selected patients, but they do cause hypoglycemia in elderly population.
Thank you. Please come to the microphone. I think we have only about 3-4 minutes left. There is another symposium, although I said it's the last one. There is a very important another Lilly symposium happening here. So please wait for that as well. Over to you.
Okay, so my question is for Dr. Manoj Chadha, sir. So since you spoke about SGLT2 and how they are here to stay even with the presence of GLPs, so I wanted to know, according to the pioneer and sustained studies, as GLP is shown better MACE reduction and deaths due to CV causes and lesser heart failures, and also the new finding is that with SGLT2s a lot of genital infections is also occurring, whereas in GLPs it's mainly gastrointestinal limited to nausea. So what do you think the space of GLP will be there post patent expiry?
I think a short and sweet answer to that is you're going to see a combination of SGLT2 inhibitors plus GLP-1 receptor agonists.
Okay. Thank you so much, sir.
Last question, and we have to conclude.
So, just a DPP-4 inhibitor and SGLT2 combination, along with this, if we use also the pioglitazone, what is your opinion at present scenario, role of pioglitazone, it will help or not?
No, pioglitazone is a good drug. My only issue is putting it into the combination. So I use the DPP-4 SGLT2 inhibitor separately and pioglitazone as and when required separately. I don't like to mix the two.
No mixing. If
Yes,
you using in the same patient, you separately add the pioglitazone.
Sure, if it's going to improve the insulin sensitivity, so it's a good drug to use if the patient is not well controlled on these two drugs by itself. Metformin is always going to be there.
Okay, thank you.
Thank you all. It was a wonderful session, and it reflects with the audience. They are still interested in engaging. Thank you so much.
Thank you all.
So I request Chairperson Dr. Lala to felicitate the speakers.
ध्यान दीजिए 1, 2, 9, 2, 1 मुंबई सेंट्रल तुरंत प्लेटफॉर्म अपनी निर्धारित समय 5:55 पर प्लेटफॉर्म क्रमांक 2 से जाएगी. May I have your attention please? 12921 Mumbai Central Turak platform will be back on time. 17 hours 55 minutes from platform 3.
Thank you for the informative session. Moving ahead to our next session, unlocking the dual hormone advantage for metabolic care. For this, I would like to call upon our moderator, Dr. Shailija Kale, to lead this session.
Yeah, good evening, everyone. So we have this interesting session. However, we are using it for last few months, left and right, I will say, in every clinic and most of the patients. So still a lot of discussion wherever I am doing these sessions. There are a lot of questions people have. We have great, eminent experts today for this session. So first, I would like to invite Professor Dr. A.K. Das. We all know him. He's an endocrinologist, Pondicherry Institute of Medical Science, but his introduction is like he's teacher of most of the endocrinologists, and he's a patron. He's past former national president for most of the societies from India. What I personally feel, sir, is that with his vast experience and seniority, still he has childlike curiosity and inquisitiveness. I think that keeps him young and going strong in academics. So we really respect to Professor A.K. Das. Please.
For this very generous introduction, dear friends, I'm just going to speak about a topic. It is not getting okay.
we will have these, I think we are waiting for the slides.
Yeah.
So we'll have these 2-3 important words of evidence and wisdom and opinions from these 3 lectures, and then we will have some time for discussion and question answers.
Yeah. Yeah.
So please go ahead.
Yeah. Dear friends, we are discussing obesity as an epidemic unraveling. Now, I will suffice to mention that today obesity has become the most important contemporary challenge, both in males and the females, and also in the children. Therefore, it is an epidemic which is really unraveling and posing huge problem. This program is sponsored by Eli Lilly, and speakers, including me, are presenting it on behalf of the Eli Lilly and Company. And during the meeting, you are requested not to take any photograph and not to ask any questions which is off level, that we can discuss, but will not ask it here, and not to take any photographs or videos. Now, I'm a speaker for Eli Lilly today, and I have also spoken for other pharma companies, and this session is sponsored by Eli Lilly. Now, I would like to start by saying that obesity is not a result of the lifestyle aberrations, not because of lifestyle wrong choices. 3 things we must remember. Obesity is a chronic disease, it's a progressive disease, and the accumulation of body fat poses risks to health. It was told about few years back that obesity produces 218 diseases. Today we know that obesity can produce 292 diseases at least. Dear friends, if you look at the global prevalence of obesity, it's about 2.11 billion, a staggering number, in the adults aged 25 years and above. And if you look at the male and female divide, approximately 1 billion were males out of the 2.11, and 1.11 were females. Dear friends, I must also hasten to add that if you look at the global prevalence of obesity, it is good to remember that we have a bad reputation, one amongst the 8 countries which have more than half of the global obese people. What are the 8 countries? China, next to it our country India, USA, Brazil, Russia, Mexico, Indonesia and Egypt. These 8 countries account for the more than half of the global population living with either overweight or frank obesity. In South Asia, the prevalence of overweight and obesity peaks much higher, 45 to 49 years in the females and 35 to 39 years in the males. This is also shown in the ICMR INDAB data. That means the obesity peaks at much younger age, both in the females and also in the males. And that's a huge problem for the life before them. Now, this is a paper which was published by us in the ICMR INDAB study, number 23, last month, in the IJMR. And you know, this speaks about the problem of obesity in our country. We have a very high prevalence of metabolic obesity in our country. ICMR INDAB 23 is a nationally representative study, about 120,000 people, assessing the prevalence and the health risk of the metabolic obesity subtypes in India. Now, this study, we also showed obesity subtypes. We had metabolically healthy non-obese, metabolically healthy in the sense they don't have any metabolically abnormality, and they are non-obese, the BMI is below 25. Mono stands for metabolically obese, but non-obese from the viewpoint of BMI. BMI less than 25, but at least 2 metabolic abnormalities are present, which is prevalence, or the NCD map of India. If you look at this, you will find that the abdominal obesity was in a staggering 351 million people. If you look at the overall obesity, you will find it was about 254 million. So, dear friends, I want to make a long story short by saying that obesity, abdominal, 351, and also overall obesity is very widely prevalent in our country. So diabetic and metabolic NCDs in India are more prevalent than we ever thought before the study was undertaken. Nearly 1/3 of our population have obesity. And obesity and prediabetes were even higher, prevalent higher across the country, where the diabetes was only 11%, pre-diabetes 15%. Overall obesity, including both abdominal and general, was almost close to 24%. Therefore, obesity and pre-diabetes is ruling the roost, and it is not long that the diabetes epidemic will accelerate because of the prevalence of obesity and, of course, pre-diabetes. Now, we classify obesity in our country into, based on BMI, very simply for the study, 3 types. BMI more than 25 kilogram meter square, constant to diagnose obesity, commonly divided into 3 types. Overweight, when the BMI is between 23 to 24.9. Dr. Anup Mishra gave this concept 23, so 22 to 24.9, we call it overweight. Between 25 to 29.9, class 1 obesity, and more than 30 is the class 2 obesity. Dear friend, this is very important to see here. The other data we have from the other studies like NFH 5 data, National Family Health Survey 5, very important for us. We found that 23% of the women and 1.1% of the men were overweight as per the BMI criteria. But to look at the abdominal obesity, you'll find 40% of the women, and repeat again, 40% of the women and 12% of men were abdominally obese. The prevalence of abdominal obesity was about 80 centimeter circumference. But what is most important to remember, we found the prevalence of overweight in children under 5 had increased. From 1.9 to double, it became 4% for NFHS 3 to NFHS 5. So very important to observe the obesity also increased in children. If you look at the projected trends in India and globally, you will find India's projected obesity trend according to the UNICEF World Obesity Atlas is that we'll find girls becoming obese at the age of about 8 and the boys becoming obese at the age of about 9. And you find the global overweight and obesity, if you compare between 2020 and 2035, you will find that both in the males and females, you find from 2020 to 2035, the obesity in either sex is increasing almost by geometric progression. It's a great disease. What are the barriers to manage this great number of obesity? Number one, we do not yet recognize obesity as a chronic and relapsing disease. Please remember, it's a chronic and relapsing disease. Even you treat it, weight reduces, but there is a concept that weight regain occurs if you stop the treatment. So obesity is not recognized as a disease. It's very important. My be-all and the end-all of this talk is to impress on you the obesity is a chronic disease, progressive disease, and it produces great health harm. Now we think that the cultural and family influence on the beliefs, attitudes, knowledge, and behavior of individual towards obesity and self-management, we think these are the factors, these are the misbeliefs and misinformations. Now, cost of the treatment, particularly for patients with a low socioeconomic status, may be high. There are a lot of comorbidities and multimorbidities, and the medications are multiple. Now, there are the patient's factor, lack of recognition, misbelief, misinformation, and also cost of treatment and comorbidities and multimorbidities. The physician factors, lack of time during general practice, we therefore need a focused practice, insufficient training and counseling skills in obesity, and lack of formal diagnosis of obesity because there are multiple parameters, metrics, which has to be taken into diagnose obesity. Now, how Indian people with obesity assess their health and weight? You'll be surprised to know that only 2/3 of people with obesity in our country consider themselves to have obesity or extreme obesity. 20% did not even consider themselves having obesity. But what is most important, only 1 out of 8 persons with obesity consider that their overall health to be poorer than the other. So either way, 20% totally unaware and 7 out of people do not know that because of the obesity, their health is poor. Therefore, dear friends, before I finish, I like to bring you the very important facts. Over 2 billion people, adults above 25 years of age, globally are affected by obesity and overweight, with countries like India, China and USA contributing to over half of the global burden of obesity. In India, more than 100 million people struggle with obesity, with higher prevalence seen amongst women. And in our country, the abdominal obesity, the treasure in the tummy, the visceral obesity, is especially widespread, affecting 40% of the women and 12% of the men, the latest data from the National Family Health Survey. Overweight prevalence in children under 5 has also risen sharply. It was 1.9% in NFHS 3. In 2 years, it has doubled to become 4%, and is a very bad sign if the childhood obesity and obesity among the children. In India, there are various patient factors and physician-related factors, and these are the barriers to meaningful, optimal weight management. Thank you very much for a patient hearing.
Thank you so much, sir. Please join me here on the platform of Mumbai Central Station, because it's a Bak, we call it in Marathi. So the next expert here, I like to invite Dr. Hemant Thakur. We all know him, he's a great speaker. He's the Director of Medicine at Jaslok Hospital, Department of Medicine at Bhatia Hospital, Senior Consultant Breach Candy and Reliance Hospital. It's a huge experience in clinical practice. He's a principal investigator in more than 35 trials, maybe much more. Innumerable publications. And I want to add one line that he's a prolific writer. And I won't be saying wrong if I say he's a Shashi Tharoor of internal medicine writing. So welcome, Dr. Hemant, and please go on.
Thank you, Chairman and Chairperson, and thank you for asking me to speak, Dr. Chawla and his team. And of course, क्या problem? ठीक है? So we have a mini obese problem here. Next. So after listening to the fact that metaphorically speaking and truly speaking, it was US that was throwing their weight around, but now it is India and China that is throwing its weight around. And I am happy from the metaphoric point of view, but not from the medical point of view, because I don't want the Chinese or the Indians to become obese. Mota moti, everything has been discussed about etiology, my disclosures, my disclaimers. Now we need to find a remedy for obesity management, and we need to identify the goals. The goals, of course, should be aimed at reducing body weight, maintaining the achieved lower body weight over a period of time, and then preventing it from going back. To set the goals for obesity management, you need the short-term goal, which is about 0.5 to 1 kilo per week, which could be 5 to 10% of weight loss. The interim goal should be maintain it. You have Ganpati festival, you have so many Diwalis coming, and you have to worry about how you will maintain what you lost. And the long term is achieve your target, keep your target there, and if you can manage not bounce back at all, because that was your goal to begin with. Now, if you look at the management of obesity, I cannot take away the fact that lifestyle management, your kids and your treadmill with a beautiful dietitian comes first. Men don't like to listen to the diet that their wives tell them, but when the rosy red lipstick and pink cheeks girl tells you what you need to eat, what you don't need to eat, they swallow it. The same thing is the highest sales of kids is in the first week of the new year, because following Diwali, Christmas, New Year, the obesity surge and everybody wants to buy new shoes to walk. So lifestyle comes in at stage of BMI 25 to 28, BMI 28 to 30, and all the way up to 40. You cannot afford to ignore lifestyle. Pharmacotherapy, interesting, at 25 to 27 or 27 to 30, hardly any people would like to use the pharmacotherapy unless you have adiposity-related complications. But at higher levels, 30 to 35, 35 to 40 and plus, you definitely need pharmacotherapy. And if the pen does not work, the knife comes in. And the knife definitely comes in over 30, whether you have complications, whether your optimal medical management has failed, etc., etc. So all individuals, regardless of body size or composition, would benefit definitely with point 1, which is lifestyle. And I'm not going to talk about it, except for the fact that a diet and physical activity, at least 60 minutes of physical activity, aerobic and resistance daily, or 300 minutes of activity per week. Hypocaloric diet, the diabetes prevention program has showed that minimum weight loss of 7% body weight through dietary modification is possible. 58% reduction in the incidence rate of diabetes with 180 minutes of moderate intensity physical activity. If you had a 5-day symposium of DRS in this center, we'd all be walking easily 10,000 steps, seeing how large the center is and how outspread everything is. Coming back to pharmacotherapy, the patient, the clinician, and of course the patient's family need to consider the obesity treatment. Information should be given to the patient, and then whether he has access, limited access, or full access, one has to advocate access, set the goals, look at contraindications, and then once started, assess efficacy, and efficacy monthly, 3 monthly, and look at goals. Where have you reached? If you don't reach, you need to escalate. If you, with escalation, fail, you need to change, as you will see in one of the cases. If one didn't work, you went to the other. And if the other didn't work, you also have an ultimate dual agonist. So reassessing the goals of treatment as you go along with the patient's values and the patient's desires to reach the target is really the practice of pharmacotherapy for obesity. What are the choices we have? Tirzepatide, start with 2.5 once a week. After 4 weeks, you keep stepping up till you reach 15 if you need to reach. I'm not saying you've got to go up. My practical experience tells me at 7.5 or even at 5, most of the Indian patients are consistently losing weight. I don't want to bowl a Bumrah if I'm getting wickets with somebody else. So if 5 and 7.5 are consistently giving me 2.5 to 3 kilos gone in a month, I would stay with that and see what my maintenance dose is. The maximum dose is only 15 and cannot exceed. Once a week, any time of the day with or without meals. Then you have a second choice. Remember, tirzepatide is the dual, the GIP receptor and the GLP-1 receptor agonist. And it's been available now since 2023, CDSCO approved. Semaglutide 2021, again once a week, you can go up from 0.25, 0.5, you can even go 0.75, 1.7 and keep going up to 2.4, which is the maximum dose. It is a GLP-1 receptor agonist. Again, you don't have to go to the maximum dose if you're reaching the interim goals, which are targeted to the final goals. And then, of course, I have to fill in the blanks and talk about orlistat, which is a reversible inhibitor of gastrointestinal lipases, but we hardly use it, so I'm not going to talk about it. Which comes where the bariatric or metabolic surgery comes in. Is the pen mightier than the knife? But the knife still remains dangling over your head if you don't succeed. So if you have people with BMIs of more than 35, regardless of presence, absence, or severity of obesity-related comorbidities, recent guidelines and surgical societies say, go for it. Previous guidelines talked about one obesity-related disease. There are lots of methods to do this. Several devices are available, but the decision for metabolic or bariatric surgery has to be a team decision. The patients and his relatives on the other side, the endocrinologist, the physician, and the surgeon on this side. And the outcomes amongst varying bariatric surgical procedures exist, from a sieve gastrectomy to a Roux-en-Y gastric bypass to an adjustable gastric banding. Lots of things are available. What began as an abdominal surgery then became endoscopic, laparoscopic. Now they even talk of mini quick procedures. Now I don't want to dwell on it because we have a surgeon talking about this. But remember, there are side effects, the dumping syndrome, the dysphagia, the vomiting, the GI problems of long-term issues. The GE reflects the Barrett's esophagus, anastomotic ulcers, erosions, intolerance. These stay. With the pharma therapy, you overcome the GI side effects. Not because I am a physician that I am trying to play up this, but I've seen my metabolic or bariatric patients coming with these long-term issues, but the results are fabulous, having said that. So a patient with diabetes and obesity, 50-year-old guy who had diabetes for 10 years, BMI 36, A1C 8.5, 10 years duration of diabetes, 95 kilos, hypertensive. He was on metformin, Sita, EMPA, and then he was trying to take semaglutide, went up to 7, could not tolerate, and of course he was on telmisartan. What would your treatment approach be to this patient to improve his sugars and to reduce weight? Pharmacotherapy further to lower A1C? Of course, lifestyle, exercise, pharmacotherapy is very important, and this is where we need to consider what is the treatment approach. Would you only want to lower A1C? Would you also look at both these things, or you want also weight? The answer is a sine qua non, and it's only a poser which is put to you. Now, this is another patient with obesity but without diabetes. 45-year-old male, 34 BMI, 105 kilos, 7 years obese, also hypertensive. He was put on lifestyle intervention for 3 months with diet and exercise. after 4 months of feeling a little better and the step counter on his phone showing 6,000 steps a day, he was disappointed with the scales when after a while he only dropped 2 kilos. And this is something which we need to remember. This is where what Dr. A.K. Das said, obesity is a disease. It's a chronic disease where you can lose something, but it comes back. And if you do not hit it at that time, this bounce back of obesity, this increase in the chronic disease is when the complications don't creep in, they run in. So you have to look at the fact that there are lots of comorbidities of these patients and you have to treat them quickly. Think of a dual GLP-1 and GIP agonist. Dosing is similar whether you're using it for type 2 diabetes or for chronic obesity. Maintenance dose I talked about. What about coexistence and how you use it with metformin, SGL2, T2s? Continue both of them. They all will add to it. Sulfonylurea and or insulin, obviously you'll have to reduce the doses, keeping the sugars in mind. No dose adjustment on age, gender, race, ethnicity, but not allowed under 18. You have to be careful. Nothing is required for hepatic or renal, but the experience of patients in hepatic severe impairment or ESRD is limited. Practical considerations, pancreatitis is a red light. Be careful, there are laws and rules how you can use that. Pregnancy, it has not been used, so I wouldn't use it. Breastfeeding also, we don't have experience. Diabetic retinopathy, the non-proliferative and the proliferative, the data is limited, as is with diabetic macular edema, so be careful. Use it early before retinitis sets in. Education of GI side effects is simple. Eat small portions, eat frequently if you have to. Once you feel a little full, stop eating. And avoid eating when you're not hungry. Just because Pavlov's ring has happened doesn't mean you get the bell in your mouth and start salivating. Stay well hydrated. Avoid the wrong kinds of foods and limit what happens today after 8:30. The fizzy drinks and the alcohol you have to limit. If you miss a dose and if you're less than 4 days into having missed it, take it immediately and get back into the schedule. If you missed more than 4 days, you had a fight either with your wife or with the lovely lady who comes to inject it, well, wait till next week's turn and get back into it. In summary, obesity management involves permission, assessment, advice, goal setting, and support. You have to be proactive. हाँ आप थोड़ा चलो, सीढ़ी चढ़ो, खाना ये नहीं खाओ, वो नहीं खाओ. This is a disease. What people used to say, okay, go and lose weight, you have to make them lose weight. BMI and complications guide treatment through the 3 components. Lifestyle change alone is not enough. Lots of surgical and pharma options available. Set the goal with the patient. Everybody's obesity, you have to tailor-made for that patient. I think having said that, I will stop and let's see what we hear from the knife.
Yes, Hemant, please join here as we will be having a discussion. So, I'd like to invite Dr. Mufazzil Lakdawala, a bariatric surgeon in this meeting, so a great addition. He's, in addition to his expertise in bariatric and minimal invasive and robotic surgeries, he has done an executive program in artificial intelligence from MIT Boston. And he's director department of general surgery at Reliance Foundation Hospital. And I think he's almost everywhere in Mumbai, Saifi Hospital, Hiranandani Hospital, and many of them. Whenever there are cross pathies come on one dais, I think we learn a lot. So definitely we hope to learn, and I hope you will learn much more from this august audience and the experts here. So welcome, Dr. Lakdawala.
Thank you, ma'am. The very fact that I'm speaking here means that I probably just removed my surgical cap outside and come here. So today I'm going to speak to you more about medicine. So maybe today is the era of not saying surgery or medicine, but actually talking about a symbiotic relationship. Today I'm going to speak to you about a very exciting molecule. We've all seen and heard about this molecule. We've also seen the huge potential of this molecule in treating probably the scourge of this century, that's obesity. So when you look at two molecules and two hormones, actually, GIP and GLP-1, you would say, why mix the two when they've got contralateral actions? GLP-1 activity at the central nervous system, as we all know by now, even lay people know that it reduces food intake, increases satiety, and in turn increases nausea. At the pancreas level, which lay people would not know, but as doctors we all do know, that it increases insulin sensitivity and it reduces glucagon. Delayed gastric emptying is supposed to be a bugbear of GLP-1, but that's basically the way which this hormone actually works. What does GIP do? GIP also reduces food intake, but unlike GLP-1, which increases nausea, this actually goes on and decreases nausea. And therefore, when you see this drug, tirzepatide, you see that the nausea is slightly less. What it does with the pancreas, whether it increases insulin secretion, increases glucagon like glucose-dependent way. But the most important effect of GIP is through the adipose tissue. It increases insulin sensitivity, it increases lipid buffering capacity, increases blood flow, increases storage capacity, and decreases the pro-inflammatory immune cell infiltration. And we all do know that obesity is a chronic inflammatory condition. So, as a single molecule designated to activate both GIP and GLP-1, it's basically the native GIP sequence, okay? What it does is GIP receptor is similar to the native GIP hormone. But in terms of the GLP-1, its action is lower as compared to the native GLP-1 hormone. And because the half-life is approximately 5 days, it almost works out as a single weekly dose. The other good thing is that it is recommended for patients, and there's no dose adjustments required even in patients with renal and hepatic impairment. And we do know that diabetic patients, and especially obese diabetics, have some form of MAFLD, MASH, which is fatty liver disease in its extreme form with obesity, as well as diabetic-related retinopathy, obesity-related nephropathy. So all these things, when you don't need dose adjustments, it works for the molecule. Well, and in terms of the studies, tirzepatide has been tried in various SURPASS trials, as well as in various SURMOUNT trials. So let's talk about the SURPASS trials. For those who do not know the various studies, well, the SURPASS 1 was with placebo. The SURPASS 2 was vis-a-vis semaglutide. SURPASS 3 was vis-a-vis insulin degludec. And SURPASS 4 was insulin gargling. SURPASS 5 was versus a placebo. So just so that you'll know where the SURPASS trials were. Now, these are the SURMOUNT trials. SURMOUNT trials was basically, the SURMOUNT 1 was all about weight. When they started increasing the tirzepatide dose from 5, 10, 15 milligrams and pitched it against a placebo. They had almost 2,500 patients in that arm and a 72-week study. SURMOUNT 2 was weight management with type 2 diabetes of 10 and 15 milligrams of tirzepatide versus a placebo. SURMOUNT 3 was intensive lifestyle program to start with, and then you had tirzepatide versus placebo. SURMOUNT 4 was weight reduction maintenance, when you had tirzepatide, which continued in one group, and after 36 weeks it stopped, and you went on to placebo in the other group. And SURMOUNT 5 was tirzepatide versus semaglutide. And in this, what they did is they took almost dose comparables, 10 and 15 milligrams of tirzepatide vis-a-vis 1.7 and 2.4 milligrams of semaglutide. So almost equal labeling out over there. Now, the approved indications, as all of us do know, is type 2 diabetes and in chronic weight management. So both of these are approved therapies for the use of this drug. Now, let me just talk to you a little bit about these various trials. So when we talk about SURMOUNT-1, and if we can compare the various things, tirzepatide gave you 16% total body weight loss. Remember that anything above 5% total body weight loss is and was an approved drug by FDA. Tirzepatide 10 milligrams was 21.4%. When we switched over to tirzepatide 15 milligrams, you saw that the jump was not too much, not that you got an additional 5 or 6% total body weight loss, whereas placebo was just 2.4% total body weight loss over a 72-week period. So the average reduction in body weight with 5 milligrams was 16%, and with around 15 milligrams was 22.5%. Hitherto, no drug had ever gone above 20%. So this is the first molecule ever that went above 20%, almost coming close to surgery. And we are used to seeing early results of 25 to 30% with surgery. Long-term data says around 20 to 25% with things like sleeve gastrectomy, which you all would be aware of. Then we come to SURMOUNT-1 in terms of how many patients achieved it. So in more than 5% total body weight loss, if you see that in placebo arm, around 27.9% achieved it, but with 5 milligrams, 10 milligrams, and 15 milligrams, you had almost close to 90 to 95% of the people achieving more than 5% total body weight loss. What happened with 10% total body weight loss? Well, it was a 75% almost with 5 milligrams, 86% with 10 milligrams, and almost 90% with 15 milligrams. When we came to 15% total body weight loss, well, 5 milligrams, only half of them achieved it, but still with 10 milligrams and 15 milligrams, you had more than 1/3 achieving the same kind of results. And when it went to more than 20% body weight loss, even then, at 10 and 15 milligrams, if you look at it, more than half of those people, and at 15 milligrams, almost 1/3 of those people still achieved 20% total body weight loss. What happened with the cardiometabolic parameters? Well, systolic blood pressure dropped at an average of 7 to 8.2 milligrams of mercury. Diastolic blood pressure again dropped by 4.6 to 5.5 milligrams of mercury. The triglycerides averagely dropped between 24.3% to 31.4%. HDL cholesterol, which we do know would be a good rise, would be around 7 to 8.6% rose, and LDL eventually went down by 5.3 to 8.6. So dyslipidemia definitely did improve with this drug. When it came to adverse reactions in SURMOUNT-1 trial, the two most common ones, nausea and diarrhea. If you see that with the dose escalation, there was a mild increase, but it was not statistically really significant. So compared to the placebo, of course, these drugs did produce around 24% nausea, 24 to 30% of nausea, and diarrhea in around 18 to 20% of patients. Constipation, of course, was lesser with the increased dose because diarrhea was more. Dyspepsia was around the 10% mark. The eructations was under 5%. And the most important thing was discontinuation due to adverse reactions was 4.3% in the 5 milligrams, 7.1% in the 10 milligrams, and 6.2% in the 15 milligrams. Discontinuation due to gastrointestinal issues like diarrhea or constipation, 1.3%, 2.8%, and 2.9%. So averagely around 3% due to gastrointestinal issues, people discontinued this drug. Now, when it came to the average reduction in SURMOUNT-5, when you compared semaglutide versus tirzepatide, what you overall saw is that tirzepatide of 10 milligrams and 15 milligrams was 21.6% average, whereas 1.7 milligrams and 2.4 milligrams of semaglutide was 15.4. So maybe a combination or dual agonists like GIP and a GLP-1 was probably doing far better in terms of at least around a 5% to 5.5 to 6% increase total body weight loss. When it came to waist circumference, again, around a 7.9 inches difference between the two groups, semaglutide or tirzepatide. The overall safety profile of tirzepatide versus in SURMOUNT 5 trials, what you did see, again, like what we had seen, around the same type of nausea. Ideally, we would have seen little better nausea profile with tirzepatide, but the data didn't really prove it. The diarrhea was around the same thing in terms of gastroesophageal reflux disease, and dyspepsia, however, semaglutide was more than tirzepatide. Now, when it came to type 2 diabetes, even the lowest maintenance dose of tirzepatide, 5 milligrams, demonstrated a superior HbA1c regulation of 2.1% with 5 milligrams, 2.4%, and 2.5% with 15 milligrams. Now, the only difference here is that at that point of time, semaglutide was approved as 1 milligram. So you've not used the higher doses of 1.7 and 2.4 milligrams. Maybe you might get equal results with HbA1c controls. But as far as this SURPASS-2 trial went, they compared 1 milligram of semaglutide vis-a-vis 5, 10, and 15 milligrams of tirzepatide. When it came again, HbA1c control, as you can see across the board, you saw that at 6.5% and less than 6.5, at 5.7%, tirzepatide stood head over heels in front of semaglutide 1 milligram. Then superior weight reduction that did not plateau over the study period of 40 weeks. With semaglutide, you had some degree of plateau, whereas with tirzepatide, with the higher doses, it did not plateau, and it kept getting better and better weight loss. At 15% was almost 12.4 compared to 6.2 of semaglutide. So overall, they said that tirzepatide 15 milligrams helped nearly 3 times as many patients achieve a composite endpoint as compared to semaglutide 1 milligram. In terms of HbA1c control, weight loss of more than 10% and no clinically significant severe hypoglycemia. As you can see, that the more the drug milligram, the dosage of the drug, the better the control of type 2 diabetes and HbA1c. When it came to the nausea, of coursingly, you would see that 15 milligrams kind of gave more nausea as compared to the 5 milligrams. And semaglutide almost at 1 milligrams was similar to the 5 milligrams dose. So similar nausea, diarrhea, and various other abdominal side effects. The hypoglycemia events, as you can see, with semaglutide 1 milligrams was less as compared to the 15 milligrams of tirzepatide, of coursingly more, but that was expected as the dose rose. But severe hypoglycemia was almost similar. So you had hypoglycemia more, but there was no severe incidences of hypoglycemia, even with the 10 and 15 milligrams of tirzepatide. So in summary, I would like to say that I think we've got a fantastic tool to treat obesity, especially the diabetic obese population. Tirzepatide significantly reduced body weight by an average of 16% at 5 milligrams and at 22.5% at 15 milligrams. Tirzepatide demonstrated superior weight reduction versus semaglutide at 15.4% of semaglutide to 21% with tirzepatide. Superior HbA1c reduction with all 3 doses as compared to 1 milligrams of semaglutide. And most of the common side effects were nausea and diarrhea, which were dose-related and could be easily stopped. Thank you so much.
Yes, thank you so much. So please join. I'm arranging chairs here for the discussion. So I am sure that we all have a lot of questions for the, we need more chairs, sir, not only one. Otherwise, he will look like he's in Katara and we all there asking. Yes, so please join, sir. Come here, sir. Dr. Hemant, please join. Yeah, yeah. It's better when everyone is facing the, it's a better kind of a dialogue then. So I think I'll sit here. So we have this wonderful molecule, and I know this is a very exciting incretin effect which we learned many, many years back. And in healthy volunteers, if you see, the 2/3 of incretin effect from the beta cells come from the action of GIP. So definitely it has a much stronger effect in incretins. And as we saw, GLP-1 acts mainly on central and gastric emptying, and the GIP mainly on the adipose tissue, as he showed that lot of receptors. And the postprandial state actually changes towards very healthy state by this addition of GIP along with GLP-1. So, and we all are now experiencing clinical effects of it. So definitely I have some points, but we can start with the questions. Yes, Dr. Sanjeev.
So excellent talk and a symposium, 3 speakers. I was expecting Dr. Lakdawala might be talking about using dual agonist after bariatric surgery and patients started gaining weight. Large many of them do. And many of them go to Dr. Hemant, being a cardiometabolic physician. So how is your real world experience, which did not appear on the screen, about GLP-1 RA? You could take either of those all along what were available in post-bariatric surgery. I know it's a Lilly symposium and off-label you may not be able to speak anything, but whatever you want to send, then Hemant would add on.
So post also and before also. So that is your...
Before could be very easy and you might lose some of the patients deciding to continue medical therapy and not go for it. But post-surgery is really challenging.
Thank you for your question. As Dr. Hemant reiterated, there are pros and cons with any surgery. Now, especially after you've done surgery, if someone were to regain weight, then that's a double whammy, because you've done a surgery and if you're regaining weight, or some of the comorbidities such as type 2 diabetes, dyslipidemia, hypertension are coming back. I think especially 2 things I would like to say. One is that a number of revisional surgeries has definitely reduced because of these drugs. Hitherto, we had drugs like Orlistat, we had various other drugs that were not really as effective. You know, we used bupivacaine, bupiprione, and we never really got the kind of effects, especially after surgery, and the oral semaglutide was not as effective. But most of us have now started using both these molecules, and I think that we've got fantastic weight loss results, even after. In fact, I believe it gets amplified almost. Your diabetes control gets so much better. And like Sir said, you actually don't need to go to the top dose. You might stop at much lower doses than you would. Another very important factor is some of the patients we've operated prior to transplant surgery. When they come in post-transplant, they've had a sleeve gastrectomy, for example, which is a much lesser invasive surgery and lesser malabsorptive. You use these drugs, so they're very, very effective in preventing the transplanted liver from going down, preventing the transplanted kidney from going down. So I think these drugs have added.
Yes, you want to add something?
Thank you very much. It's nice to see that surgeons and physicians are now joining hands, because evidence has surpassed and even surmounted the facts today that, indifferently speaking, as Sanjeev said, the number of metabolic surgeries are going down, because pre-operatively, if you show them this weapon, half of them fall by the wayside. But definitely, as Dr. Lakdawala said, that after the first surgery, there's no question of revision, because they immediately jump on to the pharmacotherapy wagon and everything settles down. So that's where India and China join hands. And I think it's for the betterment of fighting obesity as a chronic disease.
Yes. You want to add?
You know, I think I did attend a meeting of this particular issue alone. And it was highlighted that one has to stop the GLP-1 array or the GLP-GIP combination 1 week before the surgery. That's a very important point all to remember, that if one is going for a surgery, before 1 week you stop the drug. Number 2, it is said that giving this drug before surgery makes this surgery easier. I don't know how it works out, easier. But giving it after, the use is advocated 8 to 12 weeks after the procedure. It prevents two things. It prevents lot of metabolic aberrations. Number two, it probably helps in the weight regain.
Yes, true. And I think Manoj has kept a session for routine surgeries and the use of GLP-1 and this dual agonist. So Dr. Hemant, you were talking about this weight loss. So there are two questions. The weight regain once you stop the and whatever weight regain is more of a fat percentage. So your comments on that and how to deal with that. Short answers because I can hear Dolby system from the other home.
The short thing is that when you are put on an antihypertensive, you can bring down the dose, but you can't stop it. So if you have a tendency to jump back and the adipose tissue to return, whether it's with a vengeance or courtesy, you have to continue some dose.
I just one sentence.
Yes, please, sir.
Sorry, is that you know that any chronic disease, be it diabetes, be it hypertension, be it hypertriglyceridemia, you stop the drug, it comes back. It comes back, and it has been estimated it comes back to 70%. You may not go back to the original.
Yes.
70%. But the most important issue, the bottom line is that if during the course of the therapy, you can give a good lifestyle and the behavior, I mean, whatever you call it, then it may decrease. But these drugs have to be continued, has to be continued for the full benefit.
So the role of skeletal muscle resistance exercises, the paper published with liraglutide trial, which showed that there is weight regain, but then it's a muscle mass also increases and not much fat regain if the patients are put on the programs. So I think this meeting is, they're talking a lot about going to be there in patients when we use these dual agonist, especially like tirzepatide. One more important, still you, Dr. Hemant told about pancreatitis and the GI side effects and retinopathy. But just Professor A.K. Das, your word about, because still someone is writing first time in first month. There are sleepless night for treating physicians if you're prescribing this with the fear of pancreatitis. So can you just?
I think, Shailaja, we are using these drugs, not in this format, incretin mimetics, incretin enhancers, GLP-1 arrays, oral was available as pointed out long time we have been using. I must mention here, I have not seen, I come from a place where alcohol is cheaper than water. And there are a lot of cases of alcoholic pancreatitis. It is something like Goa. It is, I come from Pondicherry, French territory. So, but you know, I have not seen anybody who has developed a severe pancreatitis. But having said that, it is a good practice to inquire about the history of previous pancreatitis, which all of my residents, we always do. Any there is previous sign of pancreatitis, you should not give this drug. Number two, we always tell the patient beforehand, if you develop any time during the course of the therapy, acute, severe, persistent abdominal pain, stop the drug and come to us. I think these two work very well.
Yes, very true. And
Next conference has to be in Pondicherry.
Yes.
Oh, yes. So retinopathy, I think Dr. Hemant has described quite well, but there is no evidence of direct damage by these molecules. It's how you reduce glucose and gently reducing. So in relation to that, my question is, we have focused a lot about weight loss with these drugs. So after using for a few months, how is your effect of like decreasing antihypertensive drugs, decreasing anti-diabetic drugs in patients with CKD? It's a great benefit. So what is your opinion, Hemant, about it?
So you can tackle both the epidemics, the sugar epidemic as well as the obesity epidemic. And if you can successfully bring down the HbA1c by then only using one or two drugs, there's no harm in continuing it. Because if you have maintained HbA1c where you wanted it, you're now looking at the renal, the cardiac, the eye, and so many other complications which you're going to reduce. And of course, you're keeping weight at target. So it's an anti-diabetic agent. The cardiologists have stolen SGLT2, the nephrologists have stolen them. But where is the question?
Stealing.
This is anti-diabetic.
People are stealing that.
The surgeons will take whatever suits them. So they are also happy taking, whether it is your Jaro or my Jaro, it's now Mun Jaro.
Very good answer. But Helen, having said that, the glycemic efficacy of a higher dose, I'm talking about oral sema, is known. And of the injectable Monjaro, the glycemic efficacy also is known. But I don't think there is any precipitous fall in blood pressure produce hypoglycemia.
But I think there are occasional hypoglycemias you see in practice when the patients are on insulins and sulfonylureas, and when you add these drugs. So it's better to be aware of that. So Professor Lakdawala, I want to ask you about these big evidence from SOS trial, 30 years follow-up, maybe more than that. And it also reduced cancer, not only cardiac, it's overall mortality. So do you think this will happen with these molecules in use with the long term, like 15, 20 years of follow-up?
CDC guidelines now clearly state there are at least 13 different types of cancers directly linked to long-term obesity. And that's the reason why SOS, which is a long-term study, has shown a drop in cancer rates. I think what's exciting to note is that we're just starting. I think we will see a lot more. We've already seen MACE improvements. We've seen MASH and MAFL for the first time being treated with a drug, which is almost on par with surgery. I think a lot of these transplants that are happening, diabetic transplants, like nephropathy, secondary to diabetic nephropathy, that might delay the onset of some of these. So I think it's exciting times to be in. I think this drug has probably, and a lot of people will be talking in future, 10 years, 15 years down the line, you'll see things like cancer reduction coming in because of these drugs. You will see that.
You can stop me anytime and ask questions. Everyone is most welcome. Meanwhile, when the patient, first question is, for how many months or weeks, actually they ask how many days I have to take this drug. So what do you answer?
I usually say that you have to continue 6 months, and that's my talk to them, and they almost do it.
Yes. So at least they should be prepared for using it for 6 months. Yes, sir, please.
My question is, prior to surgery, as some drugs, anti-diabetic drugs are, stopped or withdrawn for a period. So what about the GLP-1 and GIP before surgery?
He just said it, that 2 weeks or a week to 10 days, you will stop the therapy.
Is there any definite evidence for that, for stopping it?
There is evidence for that. We have to stop.
So I'll take this one. So the American Diabetes Association has come out with guidelines that clearly state that 1 week of stoppage of these drugs, depending, half-life, sir. Half-life of 1 week is out. When it's oral drugs, it could be even shorter. Like Ribelsis, which was the oral molecule, you could stop it even. But they are saying that 1 week, because the half-life, most of the drug is out of your system, it's safe enough. And it's only because of gastroparesis. Because when you give anesthesia, you tend to have reflux, and that's the reason why they...
For other drugs, there's a definite indication why to stop. But about GLP-1, GIP, is there anything definite? Can we say it should be stopped?
All these are the guidelines, sir.
Yeah.
You have to stop it.
Correct. See, sir, it delays the gastric emptying, which is an ominous sign, sir, for the anesthesia, full anesthesia.
Right.
Number 2, it also produces gallbladder stone sludge. That's the reason why they get gallstones. So it slows. That's why if the patient has been on therapy for some time, we have to stop at least 1 week before.
Right.
Plus the CNS axis is also invoked. So you want the whole body to be removed from this effect.
Yes.
So a woman planning pregnancy, how much prior to the this thing should be stopped? This drug, whether it should be stopped or it may not.
No, it should be stopped. Data says 1 month at least prior to planning. But as a clinician, I would say 3 months. If she is very obese, then she can try, and let's see how she gets pregnant, but I will still not give the drug.
Right now, the evidence suggests 1 month, like Sir said. There are ongoing trials with people who are pregnant and the drugs being used. The data is not yet out, so the trial results are not yet out. But until that point of time, 1 month.
Just a last point. There was some paper published about meta-analysis of all GLP-1 trials. and the Indian Asian population showing a major good effect, also cardiovascular. There is a criticism about this meta-analysis, I understand. But Professor Das, what is your
Sir,
opinion?
it's a very burning question. And you know, our center recognized by ICMR as a systematic review center. So we are doing it again. But there are evidences that all these drugs, incretin, GLP-1 work better in the Indians. And the cardiovascular benefits are better than the other ethnic population. Am I correct? So
Yes,
we have more cardiovascular
That's
problems.
what the paper says, but it's like quite logical because we are a very high CV risk population,
and
very
much earlier.
adipose and
So
bad
much
kind
earlier,
of a fat.
Much earlier, at least 10 years earlier.
Yes.
So that's why the effects are very, very much pronounced.
As which we are seeing. So if there...
In lighter vein, even the government is helping you because in the next GST slab, there will be no GST. So the prices of such drugs also will come down.
Yes.
So there are few cases of NION which are reported with semaglutide. Anything with tirzepatide. So
I think I will attempt to answer your question. You see, there were signals in the SUSTAIN 6 trial. And it was shown NIO, as I rightly said, but what was more pronounced was on the onset of the therapy, the vision being dizzy and vision being affected. And that was, as Chairperson Madam said, that it was alluded to the rapid fall in the blood glucose. Now the ball is not settled about the retinopathy, but there are some signals, as you rightly said, about the Wegovy, about the other drugs, but about the Minjaro, so far there are no signs. But I think it is, we have to be alert. We have to be alert. I must tell you one instance, very simple instance. Somebody gave that drug, anti-TB drug, which affects the retina, not used nowadays. Ethambutol, to a surgeon. And surgeon came back to the OPD saying to the resident that I'm seeing little hazy and I'm not able to do surgery with that. And it was ignored. Delay developed lot of. So therefore, I think what you said, madam, is correct. NIO signals are there, but so far the final word is not settled. And even this fact also came.
doctor, for a diabetic patient, we do tell them to check their retina regularly. But since these medications are given for obesity to even non-diabetic population, are we still screening their retinas before starting the medications or periodically just to rule out or keep this in?
I think that's a very good question. Ideally speaking, what you said should be done for every patient before giving it. Ideally. But since the signal is not strong, since it is not something like hydroxychloroquine or something like ethambutol, if the patient is taking it for weight loss and has no sugar problem, you might not do it when you start, but you will highlight to him or her that you have to come back if there is an issue immediately.
So Dr. Lakdawala, since you have operated so many patients with obesity, have you ever seen that after bariatric surgery that the patients have developed some kind of eye problems? Is it because of the
drop in sugar?
Yeah, thing after the bariatric surgery which is getting replicated by these medications? What could be the correlation? I am still not able to understand why an NION gets developed with the...
Actually, I'm as lost as you are because with surgery, you get rapid control of HbA1c.
So that is for diabetic patients. There are multiple reasons because it's pre-diabetes and the microvascular complications have started way before. So all of this can be said,
signal was in
but
the
just for
diabetic
obesity.
patients.
Yeah.
The signal was in the diabetic patients.
So we are safe in giving patients with
I'm not
obesity.
saying that. I qualified even in my lecture that nobody knows what happens to proliferative or non-proliferative retinitis or even to macular edema. So if you have that, stay away till we get more data. But are you going to deprive the roly-poly Humpty Dumpty for fear of this? You have to decide.
Yes, Dr. Indurkar.
Sir, the weight loss. हो गया इनका?
Yeah, after Dr. Indurkar, sir.
NION is multiple litigations in US are happening, and I think we have to take it really on board because out of 1 lakh, if 2 people lose eyes, it is all of us that if you, me, or our primary relative is going to take tirzepatide or semaglutide, so I would really prefer to have a primary eye evaluation with talking, because NION is really a serious disease. And kindly note that EMA has put it on paper that the prescribing information should mention NION as a rare side effect. And I think we have to take it seriously. We just can't ignore the person who is going to lose vision. For him, it is 100%. So we have to note this point and do it practically for every patient. For diabetic, we do retinal assessment. Additionally, CDR would be helpful.
Yes. Thank you for the comment. Last question here.
With GLP and GIP, there is a drastic and immediate weight reduction. It's not in graduation. So, to Lakarwal doctor, I want to ask the question as far as the bariatric surgery experience is concerned. In my opinion, I have seen so many cases of bariatric surgery, their mortality is very high. What is the cause? We can compare with this drug also to bariatric surgery.
So I don't know where you get your data from, but the best centers in the world have less than 1% mortality rate, which is on par with any of the surgeries. So I would love to look at where your data is for very high mortality rate, because most obese people, if you look at some of the data, so the SOS data, Christou's data, Ted Adams data, they all show that if you're obese and diabetic, 96% survival rate at 10 years if you had the surgery. Cancer drop off less than more than 46%. So all data shows improvement in lifestyle. Surgical related mortality, they say in good hands is less than 1%, as much as with hysterectomies, with hernia surgeries, or with gallbladder surgery. So I think maybe you need to change the bariatric surgeon you are referring to.
Where would you like to do the bariatric surgery in spite of being patient treated with these drugs?
So, like Dr. Hemant mentioned, this is a chronic disease. It is not, this drug will not work in everybody. Some might not be able to afford the drug long term. Some who are above a BMI of 40, 45, drug alone will not work. So this is, like I said, exciting times for, it's like cancer therapy, sir. You have some patients for radiotherapy, some for chemotherapy, some for surgery. This is going to be, obesity as a treatment is going to have lots of options. You're going to have treatment options with drugs. Some will be just lifestyle and diet management, and some will be surgery.
How many percentage of bariatric surgery cut down in your practice?
Not
asking the wrong person.
I don't think so. I think it's
70% of my volume.
I heard the tinkle and the bell.
Together efforts, and the patients are going to be benefit more surgery plus these drugs. So ultimately, it's patients benefit when we start working together. So thank you so much for that. I think I will ask Professor Das to sum up and end this session.
Yeah, I think we must recognize obesity as a chronic disease, and we must realize in India we have 1/3 of the people who have either abnormal obesity or general obesity or both, and we must identify those people. Number two, we must recognize that to put the chronic disease and all the maladies from type 2 diabetes to CVD to cancer away, we have in the armamentarium drugs which were never before. We never had such weight loss, which my dear friend Hemant referred to. We never had so much weight loss of 5%, 10%, 15%, sometimes 22%. I don't want that, but we didn't have in the armamentarium. We have a drug which we have to use judiciously. Final point, the take-home point from here, that we must use proper metrics along with BMI to find out the obesity, and whenever it is possible, we have discussed with the patient and prescribed this drug, and it is going to change the trajectory of the metabolic map of our country. Thank you.
So thank you so much. Thank you all my experts here. Thank you the interesting audience, and congratulations to the organizers, Manoj, Purvi and entire team for successful first day. Thanks.
And Chair, Professor Dr. Shailaja Kale for a very, very able conduct of a session which is very difficult.
So I request, so we'll take a group picture. I think I'll make it short.
1, 2, 9, 2, 1 Mumbai Central, Surat, A. Now, A. Mumbai Central, Surat, Flight 9. अपने निर्धारित समय 5:55 पर प्लेटफॉर्म क्रमांक 3 पे जाएगी. May I have your attention?
On behalf of the organizing team,